see the back of your head. That's what it is. It's capturing you. That's it. It's okay. Okay. So I'm going to show you. I think you won't be able to see the YouTube screen. Okay, because I'll watch it. Right. Be careful. Is that you hit it? Okay. I don't have to go around. Yeah. Okay, so this is the YouTube screen. It's already set up. All you can do is click here and your presentation. This is what you'll see. You won't see anything else. So cool.
Okay, so just keep right like this right now, or?
Yeah, yeah, I'm gonna leave with this.
Okay.
What I'm
So
saying.
do anything more than just a thing else?
Close the line. Just do this. Do that. Okay. It should, as long as it's active, it should be active. But if it does, the box screen, you can also choose it.
Yeah. Do I need to, I guess we're not.
You can. If you're at the book, you can just keep this one. Just keep this one if you want. If you want to stand here and speak, and just, yeah, that's right. Let me see if this works. So, over here, you have to face the screen. You have to point it towards that. Wait, do that? It won't show up on theirs.
Oh,
Okay. That's only for the,
so what's the one again?
for the people that have the live stream.
But it'll show up on.
Right.
Good morning.
Good morning.
How are you guys?
All right, sorry, we're setting up the live stream.
No worries.
How are you?
Dave Metzger, nice to meet you.
Nice to meet you.
Nice to meet you.
Pleasure.
Dave, Tommy
Good
Joe.
Nice to meet you.
Have some coffee and there's breakfast outside if you.
Speaking my language.
Yeah, they're a little finicky with the times and the breakfast. At 8:45, they will take it. So if you are on 8 o'clock or after our first talk, grab as much, or maybe 9 o'clock, they'll take it.
Yeah.
Grab whatever you need and keep it because there's no third way.
Oh, they do this in here?
They'll leave this here until 9:30. That's it.
Are you staying here at Caesars?
Mm-hmm. You guys from Texas, right?
Yeah. Yeah, actually, we're from, he's from Houston, I'm from Austin.
Oh, it's very good. I'm glad you're able to get it to see. Will they want you for your sample? Yeah, I'm glad you do it in Texas. Okay. After I spoke to you, yes. Well, after I spoke to you, I can still.
Do you do any kind of cruise thing?
Yes,
Alright.
we actually were we did a Europe cruise,
Alright.
Mediterranean cruise, just this past summer.
Alright.
And this coming summer, most likely we'll be doing a cruise out of Galveston. At least we're not really finalized on those plans, but
Okay, so I will check.
yeah, typically we'll do at least one cruise in a year. Or at least,
Good.
that's our intent anyway. We've only been around for a year as so.
sure this was his. See it?
Morning.
Yes. So you want to start there? There's that. Livestream.
We can just do that.
Well, I can show this. In my, so the point view is, that's what we see right now. Let's see right now, okay? But what I'm saying is that you have to go back and switch again. You don't want to do that. So we'll look at one screen at a time. So you can go to. Honestly, I think it's just better. You want to present It's on. You were right. Yep, it is live. It's right here, you can see it. So I'm gonna keep mine on mute.
How are you?
Hello, how are you?
How are you?
Mr. Lay. Nice to meet you. Hi guys, how are you morning?
Can't wait.
Nice to meet you.
John Lee.
John.
Nice to meet you. Grab a seat, guys, grab some breakfast. You people must have had late nights there. It's a little.
We are in Vegas.
We didn't get it until original 11.
Oh,
really?
last night? When are you leaving?
All flights out from Pennsylvania. So the flights suck. It's either you pick a bad flight or
And it's,
you pay 3 hours.
Hello, how are you?
I mean,
Nice to meet you. Yeah, what are you doing? Is it bad flight or what?
you either pick a bad flight or an expensive one.
Closest to
Yeah. But then it's like flight home, so you get there early, it's direct, so it's hard to find.
But it's a real flight, right? Jet engine and all that?
Yeah.
'Cause I've been on some from Boston to Albany. The flight attendant got up there. Well, you guys are like, you sure? I want to be reasonable.
But we're gonna need somebody to push the propeller.
Right. You got some water?
shall we go ahead and sort of,
Yeah.
as everybody's,
There's one.
give everybody just a couple more minutes and we'll get started. So I guess we'll go ahead and get started. I want to welcome all of you for coming here and joining us for this evening course. So over the next couple of days, it'll be probably 15 hours this evening. Just to tell you a little bit about me, and then I'll let Dr. Calais tell you about himself. I'm a family doctor. I practice in Austin, Texas. Been practicing for a little over 20 years. Started out with, doing family medicine, then became section chief, became chief of quality at the clinic, at the multi-specialty clinic where I work, Austin Diagnostic Clinic. Got just a little over 150 providers. And eventually I went on to write a book. It's called Health and Claims, Doctor's Prescription for Living Beyond Diet and Exercise, and ended up giving a TEDx talk as well. Always kind of been in the space of improving quality of health, quality of care for various chronic diseases. And so, together with Anish, we decided about a year ago, CME Travel Academy. I'll let Dr. Clay say a little bit about himself.
Pretty similar. I was mostly a faculty for about 20 years. Practiced full scope family medicine until about 3 years ago. I was still delivering babies. I was still running the ICU, and I was still running the youth nursery as well. About 3 years ago, my wife said, "I'm tired of being a single parent, so you need to cut your time down a little bit." So that's what I did. As part of that job, I was also in quality and peer review, and then of course journal activities and publications and so forth. So, like Dr. George, I have a few books that, case files, you've heard of those, some of those are mine, and then some of the U.S. Family Preparation for Step 3 are mine as well. So, we have a few publications, and then aside from that, a lot of peer review publications. I've had the good fortune of being able to be participating in a lot of the national guideline committees for the AAP, as well as the American Academy of Pediatrics. So, that's been very fortunate because we see a lot of people that are doing the same kind of work and trying to help them with the guidelines that we need to use in practice. I think a big part of the core for both of us is that there's so much in medicine that doesn't have evidence. There's a lot that does. And what we see is that, not just what we see, but we've got good publications out there that tell us that a lot of the guidelines that are already out there that show decreasing morbidity and mortality are sometimes just not being followed. In fact, we'll share some of that data, and sometimes only 3% is being followed by clinicians. And is it because of inertia? Is it 8 a.m. and 1 a.m. or 1 p.m. at 3:30 and 10 o'clock when it's busy? We hope that we can empower everybody to kind of read the guidelines, be able to practice evidence-based medicine, and also make sure that we're not just leaving everything to specialists, but also that we can take care of what we need to do. We started the company last year, and we typically do a couple of different types of conferences. We have in-person conferences like this several times throughout the year. We've already posted the first 6 months of 2026, so if you guys are interested in talk for next year, take a look. They're usually, a lot of them are nice resorts, nice vacation destinations. We typically do one grand one. In July was our last big one. That was the cruise to Italy, Greece, and Turkey. So we continue on with that one. And then this summer we'll do something like that too as well. And then we also have on demand. And of course we have what we call what's unique to us, which is CME Anywhere, where you can join any of our conferences virtually, and you can go to a location of your choice. And then we have something called custom CME, where you can choose your own location, choose your own date. So check those out if you're interested. A couple of housekeeping rules. The food is going to be taken out away around 9 o'clock. So please, around at the end of the first talk, go grab whatever you can, because they're just going to throw it away. And we have no control over the food after that. So please, that's what they say. Grab whatever you want and keep it in the room. Otherwise, we'll take care of it. The coffee, I think it'll be here till 9 or 9:30. There's a lot of union rules here, so not so much we can control on those kinds of things. So just be out of the room and go to the left. That's where the restrooms are. And then before lunchtime, we'll talk to you guys about where you can grab lunch that's nearby. It's fairly easy to get access to. Okay. And a couple of people live streaming, so if you see us kind of looking here and there, that's because we want to make sure they're still online.
I'll just make one other quick point about what makes CME Travel Academy a little bit different and maybe unique in some ways. We do provide the CME content just as a lot of other CME providers. We also have this spaced repetition, which is one of these learning techniques that's very familiar in the educational circles, but we don't a lot in medicine. But basically, just as a way to improve retention, so that once you hear it, there's a lot of studies that say you forget maybe half the information within a day or two. When by a week out, you're forgetting almost 80% of it. But there's a lot of good evidence that spaced repetition, which is the idea that you reintroduce the topic at spaced intervals over a period of time, will improve that retention from as little as 20% to as high as 80% after 6 months to a year. And so, this conference is sort of the start of our commitment, and over this next year, you guys will be able to get on our learning platform, which is called Thinkific, which if you have access to the internet right now, you can actually log on to Thinkific, and that'll enable you to get to the one-pager handouts that we have for each of our talks. It'll also give you access. That's the platform that we use for our spaced repetition questions, and it's also where you'll have the videos that that are recorded from this talk, from this this conference. So if you have access to the internet, you could actually, there's a link that you guys should have received. I think out a link to the Thinkific platform.
We signed everybody up automatically, so you should have received an email from Thinkific. It might say CME Travel Academy or Thinkific, I'm not sure exactly how it comes on your end. But if you sign up for it, you'll be able to log in directly. And you've already been enrolled, so you can also go through our website. On the very right side, it says log into learning platform or log into courses. That will give you access to all the slides as well as the handouts.
Yes, so I'll slide so you guys can follow along, and then we'll also be going over these one-page handouts. That's another thing that we do a little bit different, which is that every one of our talks we have a one-page handout, which is a point of care reference. So ideally, if you choose to, you could laminate it, you could put it on a ring, on a ring and hang it up in your exam rooms, and you have access to the one-page point of care reference right there at your fingertips. Okay, so I think we'll go ahead and get started. Our first talk is on hypertension, updates and evaluation and management. And I'm going to let you learn, just read through the learning objectives. They're going to be fairly similar from one talk to another. I'm not going to read it verbatim, but basically it will be an overview of the guidelines. We'll talk a little bit about the latest research and then how to incorporate those guidelines for treatments based on your own individual patients. So, starting out with pathophysiology, hypertension is due to a confluence of environmental and genetic factors. Really has three, main drivers that cause hypertension, and so you have sympathetic overactivation, renin-angiotensin-aldosterone overactivation, which leads to increased sodium retention and fluid retention, which leads to hypertension, and then endothelial cell dysfunction that leads to the inability to produce nitric oxide efficiently, so that you don't have sufficient vasodilation, so you end up getting hypertension as a result of that. If you look at the guidelines, so very interesting. We just had a new set of guidelines that just came out just about a month ago, and so this would be new to everybody. But if you look at the guidelines, there have been various guidelines over the years. The JNC8 guidelines from 2014 is actually still referenced to some extent. And there is disagreement in the community about which guidelines we should be following. So I want to state that up front, and we'll talk about some of the evidence for why one organization may support one set of guidelines versus another. 2017 8 guidelines came out, and they recommended, based on the SPRINT trial and some other trials, but largely heavily weighted on the SPRINT trial, they recommended a much more aggressive goal than the JNC8 guidelines are recommended. But important to state that the Professional Association for Family Physicians and the Professional Association for Internal Medicine Physicians, ACP and AFP, did not endorse the 2017 AHA-ACC guidelines. They, in fact, said to follow the JNC8 guidelines. So largely in disagreement for various reasons, which we'll get into in a little bit. They actually put out a joint statement that largely agreed with the JNC8 guidelines at that time. Now, if you look more recently, AFP did lower their threshold, so they're a little bit more aggressive than they had been with the JNC8 guidelines. So if you look here, it used to be 150 over 90, but now pretty much across the board, they're recommending a blood pressure goal less than 140 and less than 90. And in fact, for AFP in particular, they said that they do recommend, if you're trying to reduce cardiovascular events, best to get under 135 or less than 85. So we'll talk a little bit about that and the reasons for the different guidelines. But as I mentioned, just a month ago, the ACC-AHA updated their 2017 guidelines. Now we have new guidelines which look very similar in terms of the targets, less than 130 or less than 80. But they're a little bit more aggressive than the previous guidelines. So we'll talk about that here in a minute. So here's some of the big trials that helped to influence these guidelines. So one was the Accord trial. This is a trial involving 4,700 diabetic patients. And they compared blood pressure lowering of less than 120 versus a systolic less than 140. And they found, surprisingly, no significant difference in cardiovascular outcomes and all-cause mortality. And there was more side effects. And as a result, it seemed, this was based in 2010 study, that the less stringent guidelines were fine, at least in the diabetic population. The SPRINT trial really changed a lot of things. So that was a trial of 9,300 patients. They were over 50. They were, however, not diabetic. Okay, so those diabetics were excluded from those trials, but they were high risk. And they compared intensive lowering to a systolic less than 120 versus systolic less than 140. And what they found was that not only was there a decrease in major adverse cardiovascular events, but a decrease in mortality, all-cause mortality. So that was pretty convincing. The trial was stopped early because of the benefits shown. And again, it had a big influence on the ACC/AHA guidelines. Then you have the HOPE trial that came out in 2016. This was 12,700 patients, intermediate risk. And they did not, so these were patients who were categorized to either get to, either their blood pressure was over 140 to start with, or if it was less than 140 to start with, then they did not see a benefit. So if it was over 140 in the beginning, before they started the trial, and then they tried to lower their blood pressure, it did show an improvement in outcomes. But if they were already less than 140, then going further down in systolic readings did not seem to increase, to reduce cardiovascular events. So this seemed to largely support the findings of the Accord trial in 2010. But again, more recently in 2021, this is the STEP trial, which involved 8,500 Chinese adults that were randomized to a systolic blood pressure goal of less than 150, or much more aggressive goal of a systolic of between 110 to 130. And they found that in fact, that cardiovascular outcomes were less in the more intensive treatment group. So once again, kind of supporting the SPRINT trials. Important to say that there's some, again, if you look at the SPRINT trial, the goal was to get their systolic pressure under 120. Okay, but if you look at the ACC/AHA guidelines, they recommended to get to under 130 for most patients. And we'll talk about a little bit about why that was. So, if you look at which of these guidelines are the most influential, by far, ACC/AHA guidelines have been the most influential here in the US. And so we will largely focus on that, but we'll also incorporate some of the other caveats that the other guidelines bring up and talk about that as well. So using this hypertension criteria, less of, stage 1 hypertension being over 130 and over 80, that means that about 45% of the population is hypertensive. And then you could look at it as primary hypertension versus secondary hypertension, as in something else, some other underlying cause of the hypertension, which there are several. I did want to just briefly introduce this one-page handout to you guys. I should have done this at the start of the talk, but let me just kind of overview this. If you have access on Thinkific, you could look up while we're looking together, if you like. But your handout is going to be a little bit different because the AA guidelines just got updated just a month ago, and we haven't put that on this display yet. But you'll see that this is a hypertension algorithm, and you'll see that on your one-page point-of-care reference. You'll see the various medications that are used for treating blood pressure, the degree to which various interventions in terms of lifestyle interventions lower blood pressure. You'll see a little bit about the management of resistant hypertension. On the back side, you'll see a lot of the causes of secondary hypertension. So as we just talked about, various reasons that you have hypertension, such as hypothyroid, hyperthyroid, obstructive sleep apnea, so all that is on there. You'll see a little bit of information about treating hypertensive emergency, resistant hypertension, and then some of the labs that are used for evaluating blood pressure. Okay, so back to our talk here. So if you look at the ACC-AHA classification, they've categorized blood pressure into 4 main categories. Normal is less than 120 over less than 80. Elevated is 120 to 129 over still less than 80. Stage 1 hypertension is less than 130 and less than 80. And then stage 2 hypertension is less than 140. There we go, less than 140 and less than 90. I'm sorry, over 140 and over 90. I'm sorry, I said in reverse of what I should have said there. Now, keep in mind that, once again, AFP, ACP have different thresholds for defining blood pressure, and in particular for older individuals, they have a little bit of less stringent targets. Okay, when we start out with evaluating blood pressure, we want to obviously get an accurate reading, and that's probably one of the things that is most important. Is we oftentimes, and in fact, studies indicate that over 90% of the time in the office, we're measuring blood pressure incorrectly. So let's talk a little bit about how to properly manage, how to properly take a blood pressure reading. The ideal way is that the patient should be resting 5 minutes before you even check it. And so, right off the bat, I think if you watch a lot of our MAs in action, maybe they might really take the blood pressure without proper rest, and so that's going to influence it. No caffeine for at least a half hour beforehand. No exercise. No smoking. All these things influence blood pressure a little bit. Your bladder should be empty. Right? Feet should be flat on the floor, not crossed. Your back should be supported. Your arm should be resting on a platform at the level of your heart, not hanging. So again, when you look at studies that have been done in doctors' offices, over 90% of the time, we're not getting blood pressure right. And so it's also important to have the proper cuff size. Too small of a cuff can cause blood pressure to be seriously high. Too big of a cuff can make it falsely low. And then during the reading, you don't want to be, you want to make sure that the patient is not talking. And again, once you've had them sit for 5 minutes, you take the blood pressure, you also want to repeat it after at least a minute or 2. And then you get the average of those 2. And that's the ideal way to get the blood pressure. Something as little as just having your blood pressure, your arm at your side instead of resting on a platform can make the difference of 4 to 7 millimeters of mercury. Just based on this study, this is a 2024 study that showed that just the arm position itself can have a big impact on your blood pressure reading. So again, it's important to have that really good blood pressure technique. But one of the ways to do that is, of course, to get home blood pressure readings. And, a lot of times it's difficult to do it in the office the proper way, just because of time and various constraints. And the fact that a lot of people have white coat hypertension, a lot of people have blood pressure that will go up. I mean, there's studies that have shown that blood pressure will go up just by having a doctor in the room. You don't even have to be, interacting with them. Just having the doctor in the room raises the blood pressure. Same thing with the nurse. So you do want to get at least 2 readings, at least in 2 different visits. So, if you got that and you average that out and it's over the hypertensive range, then you can make that diagnosis of hypertension. As I talked about, white coat hypertension, which is meaning that the blood pressure is higher in the office but low or normal at home. And then there's the opposite, which is masked hypertension. Masked hypertension is where blood pressure readings are normal in the office and it's kind of high at home. Any idea why that would be? Maybe stress, maybe a stressful work, home environment that is kids. There you go. You can make a diagnosis of hypertension on a single visit. You don't necessarily have to have that second visit if you have a very high reading, so if it's over 180 and over 110, and you want to make sure you rule out that they're not, or some other reason, maybe they just got into a big argument with their wife or something like that. That obviously those things can raise the blood pressure. So you do want to be cognizant of that. But having ruled out those factors in the context of a very high reading, you don't necessarily have to send them home and tell them to get several readings and come back in a month. You could go ahead and start the medication at that point. So this is a comparison of the various methods of blood pressure monitoring. There is, of course, the office blood pressure monitor, ambulatory blood pressure monitoring, and home blood pressure monitoring. These are kind of the main ways we get blood pressure readings. Now, if you look at which one is the most accurate, and how do we know what's the most accurate? Well, it's based on what predicts cardiovascular outcomes, right? If you look at which one it most closely aligns with the outcomes in terms of clinically relevant outcomes of cardiovascular outcomes, ambulatory blood pressure monitoring is the most accurate. So this is where basically they're wearing a blood pressure monitor, it's strapped to their arm, and they go home with it, they wear it for 24 to 48 hours, and it's measuring blood pressure every 15 minutes. Okay. And so you get a pretty good idea of how it varies through the day, and that's, again, you're not necessarily having somebody measure the blood pressure, so anxiety provoking, less likely to raise the blood pressure. So that's kind of the gold standard. The home readings are actually better than the office readings, if you can properly educate your patients on how to get a blood pressure reading. So if you can tell them, make sure that they're resting for 5 minutes, they haven't had coffee just 5 minutes ago, and they're doing all the proper techniques, then home blood pressure readings are actually more accurate. And so if that again points to the importance of getting the patients to get home readings so that they can help to you don't want to rely on just that one data point that you get from the office when in fact a lot of those office readings are a little bit off. This is an interesting study that looked at what's called an automated office blood pressure reading. Okay, so we looked at home blood pressure readings, office readings, and ambulatory readings. But there is something called the automated office blood pressure reading method, which is basically you go and you have the patient sit in the waiting room. As soon as they come in and check in, they strap a blood pressure monitor on them. The monitor doesn't go off. Once they're sitting, after 5 minutes, it automatically checks the blood pressure. And then after a minute or two, it will check it again, and it can potentially check it 3 times in a row, and you get the average. And that is a very accurate way of getting blood pressure readings. The sprint trial that we talked about used this method. And here's the thing, that this was one of the concerns, or this is one of the legitimate concerns that AFP and ACP brought up in terms of reliance on the sprint trials, because no one actually measures blood pressure that way, at least in the office. I mean, most people don't. Now, if they do, that's great, then we should follow that data. But what they're worried about is, are we over-treating our patients and putting them at risk for hypotension, because now you're being really aggressive with blood pressure management because you're trying to get down to less than 130, and in the sprint trial it's less than 120, right? Now, ACC, AHA did have a legitimate counter argument to that, which is that they set the guideline not at less than 120, which was what the sprint trial would have supported, but less than 130. So that's to adjust to kind of mitigate for the fact that some of the readings are not done in an ideal setting. So let's say you have a patient and you determine that they do in fact have stage 1 hypertension. So their reading is over 130, let's say it's 135 over 85. You had them come back after a month, you taught them good technique, they get home readings, and in fact it's still in the 130s and 80s. Then you could you decide what's the next step we do. Well, the next step, according to this the latest ACC/AHA guidelines, is to use the prevent risk calculator. Everybody familiar with the prevent? Anybody heard that one? Yes, sort of. So this is a risk calculator that is very similar to the older ASCVD risk calculator, which is another 10-year risk calculator. The ASCVD risk calculator is thought to have overestimated risk in certain populations, and so ACC/AHA guidelines, ACC/AHA came out with the prevent risk calculator just about a year ago in 2024. And now they recommend using this and incorporating that into finding your risk score. Okay, so not everybody who's in the 130s and 80s are automatically going to be started on blood pressure medicine. You first have to calculate that prevent risk score, and then it used to be that if it was over 10% using the older ASCVD risk calculator, then you start treatment. Now, the threshold is lower. So as I mentioned at the start of the talk, the ACC/AHA guidelines have gotten a little bit more aggressive with regards to blood pressure management. So now, if the 10-year risk threshold is over 7.5%, if your calculated risk score is over 7.5%, the recommendation is to go ahead and start treatment at that point. 7.5%. Oh, well, one other caveat. If it's over 7.5%, or they have either cardiovascular disease, diabetes, or CKD, then you go ahead and start treatment. But if it is under 7.5%, then you prescribe lifestyle changes, therapeutic lifestyle changes, and then you want to reevaluate in 3 to 6 months. And at that point, if it's still high, then they recommend you go ahead and start treatment. So meaning if it's still in the 130s and still in the 80s, even though their 10-year risk score is less than, maybe it's only 5%, but they come back in 3 to 6 months, they've tried the lifestyle changes, it's still 135 over 82. Recommendation from the ACC/AHA guidelines is to go ahead and start treatment at that point. In the previous set of guidelines from 2017, it was the recommendation was a little unclear. They didn't really specifically say start treatment. Here they're saying very clearly you start treatment at that point. And then of course, we didn't really talk a whole lot about the lifestyle interventions, but that's really a very important part of managing blood pressure. And so the best data comes from the DASH diet in terms of reducing blood pressure, just lowering salt intake and increasing dietary potassium has shown to blood pressure by 6 points, just by that small intervention alone. Physical activity, so at least 30 minutes a day, 5 days a week, or 150 minutes of exercise per week of moderate intensity, or 75 minutes a week of higher intensity exercise have been shown to lower systolic pressure from 4 to 8 millimeters per mercury. And again, this is on your one-page handout, so you'll see that in that lifestyle interventions box. Weight loss, we've all known this, but this is a way to quantify it and kind of explain this to your patients, is that for every kilogram of body weight they lose, they can expect roughly a 1 point drop in their systolic pressure. And of course, these are, all these are additive, right? So you could, not necessarily strictly additive, but the more you of these interventions you use, the better it can be. And in terms of, there's a good chance you can manage a lot of this with lifestyle interventions. Now, the most common pharmacological agents, we're going to talk a little bit about the various ones out there that we use for this, but the RAS inhibitors would be among the most common, ACEs and ARBs. Then there's the calcium channel blockers, diuretics, beta blockers, and the mineralocorticoid receptor antagonists. There are other ones out there, and we'll mention some, but these are kind of the main ones that the labs that we use. This is again the recommendations from ACC/AHA. Check your electrolytes, your creatinine, CBC, urine albumin-creatinine ratio, thyroid, glucose, or an A1C, and then EKG. And then some patients, they should have an aldosterone test as well. And this is something that's being increasingly pushed by ACC/AHA. Anybody who's got resistant hypertension should have their aldosterone checked. In other words, checking for hyperaldosterone, which involves checking renin activity, aldosterone, and renin to aldosterone ratio. Anybody who has sleep apnea should have a screen for hyperaldosteronism. Hypokalemia. If you check their labs and they're hypokalemic, even if they're on a diuretic, you should be checking for hyperaldosteronism. And if you find an incidental adenoma, or if they have a family history of early onset hypertension or early onset stroke, that would be an indication for checking to make sure that they don't have hyperaldosteronism. Okay, let's talk about a little bit about each of the individual agents that we use. So the ACE inhibitors, as you know, they block the conversion of angiotensin 1 to angiotensin 2, and thereby prevent the release of aldosterone. Aldosterone, as y'all recall, increases sodium retention, increases fluid retention, and so by you basically lower sodium, lower fluids, and lower blood pressure as a result of that. And you know, of course, the ACE inhibitors used to treat hypertension, particularly helpful in heart failure patients, used for patients who have CKD. And common side effects, you guys are aware of this: cough, hyperkalemia, angioedema, dizziness. And here's some examples: lisinopril, enalapril, ramipril. The angiotensin 2 receptor blockers, they block the angiotensin type 1 receptor, which again basically prevents the release of aldosterone. And so again, less fluid retention, less sodium retention, and therefore lower blood pressures. It used to be in the even in the 2017 guidelines that the ARBs were kind of second to the ACE inhibitors. Here in the 2025 guidelines, they pretty much have, you can use either or. It's not necessarily a preference of one versus the other. Now we have, it used to be that ACEs just had more data to support it, but now there's adequate data over time, just accumulated for the ARBs as well. Now ARBs can cause the same sort of side effects. Now angioedema is less common with them with the ACE inhibitors. If you have a patient who has been on an ACE inhibitor and they've had angioedema, you can put them on an ARB still, but you should wait at least 6 weeks after they've been off of the ACE inhibitor before you start that ARB. And you guys are familiar with the examples of losartan, irbesartan, valsartan. And then, of course, if they've had a reaction, in other words, if they have angioedema with any of the ARBs, you don't want to use another ARB. Same thing with ACE inhibitors. Calcium channel blockers. So here we have the dihydropyridines and then the non-dihydropyridine calcium channel blockers. They block calcium influx in the vascular smooth muscles of the peripheral vessels. And then in the case of the non-dihydropyridines, they block the calcium influx of the peripheral vessels and of the heart, so they reduce contractility and heart rate as a result. So these, generally you want to use the longer acting formulation, so not the, so for example, nifedipine has extended release versus instant release, and the ones that are extended release are the ones that are appropriate for blood pressure management. And the diuretics work by inhibiting sodium and water reabsorption in the kidneys, and therefore reducing blood pressure. Used to treat hypertension, used to treat heart failure and edema. Now, in this case, in the case of hypertension with CKD, generally up to stage 1, 2, 3, you're going to prefer the thiazide diuretics. Stage 4 and 5, at that point, the loop diuretics are actually more effective blood pressure management. And you guys are familiar with hydrochlorothiazide, chlorothalidone, and dapamine. There are various thiazide diuretics. Beta blockers block the beta receptors in the heart and reduce contractility, reduces heart rate, and it also thereby reduces blood pressure. Used to treat arrhythmias, heart failure, control angina. It is used post-MI. There is some new studies that are starting to question whether beta blockers are as effective post-myocardial infarction as we once thought. It's certainly true that it is effective for anybody who has a reduced EF heart failure, or if they even have a mildly reduced EF, it probably is likely beneficial. Some of the more recent studies have called into question whether if they have a normal EF, if it's really beneficial or not. So that's kind of a major change. That has not made it into the guidelines as of now. This is, again, relatively new studies that may influence further future guidelines. And these do cause more side effects, so they don't tend to be the most preferred blood pressure medications, but they can cause fatigue, depressed mood, bradycardia, of course. There are some various examples, metoprolol, which has better data than atenolol outcomes. And then you have the mixed alpha and beta blockers, such as labetalol, which has, and carvedilol, which has some vasodilatory effects in addition to the lowering of the contractility in the heart rate. They also, carvedilol in particular has some beneficial effects in terms of preventing cardiac remodeling. So it has a particular indication for heart failure patients as well. Then there's the mineralocorticoid receptor antagonists. These act in the kidneys, preventing aldosterone from exerting its effects, and therefore, once again, leads to increased sodium and water excretion. And also used to treat hypertension, heart failure, particularly effective for resistant hypertension. We have a whole talk that Dr. Pillay will be going over for that. Common side effects, hyperkalemia, hypertension, dizziness, fatigue, gynecomastia. Now there's a new mineralocorticoid receptor antagonist. Are you guys familiar with finerenone, which just recently came out? That has the spironolactone and eplerenone are steroidal mineralocorticoid receptor antagonists. Finerenone is a non-steroidal mineralocorticoid receptor antagonist that don't cause gynecomastia. Seems to have better outcomes, particularly in patients who have CKD and diabetes. Okay, so those are kind of the agents. How do we go about managing blood pressure? Well, you're going to start with the first-line medications, which are really three groups of medicines: thiazide diuretics, ACE inhibitors or ARBs, which is the RAS inhibitors, and then the calcium channel blockers. For most patients, that's what you're going to go with. Then there are various indications that you're going to use to individualize treatment to various other patients. You're going to try to, the recommendation is to try to use a simplified regimen as much as possible. So if you have a 2-in-1 combination pill, that improves compliance. So use that, and so whenever you can. In stage 2 hypertension, you're going to start with 2 blood pressure medicines. If their goal is over 20 points from the systolic goal of less than 130, or or more than 10 points from the diastolic goal of less than 80, then the recommendation again from ACC/AHA, either of those, you go ahead and start with 2 medicines at the same time. These are some common combinations, but there are other ones out there. And then once you start the medicine, then again you want to educate your patients on proper blood pressure monitoring, have them come back in a month, reevaluate, and then adjust their medication as would be appropriate. And one of the concerns that the AFP and ACP brought out was aggressive blood pressure management, especially in the. And so ACC/AHA doesn't really have a different goal for these individuals who are elderly. They, in fact, cite the studies such as the STEP trial that showed decreased cardiovascular outcomes in those patients. But there are also potential for harm. As you know, we treat our blood pressure, we treat our elderly blood pressure patients too aggressively. They could be at risk for falls, electrolyte issues, kidney issues, and so you do want to be a little bit cautious in that patient population. Maybe periodically reference the AFP or ACP guidelines just to have another another look at that. Also important to note, sometimes in our elderly patients, they're sitting down and their blood pressure is high, and then you manage them very aggressively, and they continue to be high. They come back, it's still high, and so you continue to be aggressive with it. But what you may not notice, what you may not have noticed is that if they were standing, the blood pressure drops. So important every once in a while just to check a standing blood pressure reading in that population. And generally, of course, start with lower doses, particularly for sorry. So start with the lower dose for the patients who are a little bit older. Monitor for orthostatic hypotension. In the black population, the ACE inhibitors tend to be less effective. Why is that? Their baseline renin tends to be lower because, just from an evolutionary perspective, if you think about in the distant past, living in sub-Saharan Africa, it was very hot and humid, and so, if you have, you want a mechanism to retain salt and fluids, and so having a lower baseline renin tends to help for that. Now, ACE inhibitors are more effective if your renin levels are higher, and so it's less effective in the black population as a result of that. So which medications are preferred? In those cases, thiazides and calcium channel blockers are preferred in black patients. Now, if they have another indication, such as they have CKD, then you're still going to start with ACEs and ARBs in those individuals. In our diabetic population, same goal, still less than 130, less than 80. ACEs and ARBs are going to be preferred as first-line medications because they do help with preventing the progression of albuminuria in that patient population. So those are appropriate medications to start with. Again, all of these are available on this one-page handout. It tells you by population. On the front side, if you look over here, you can follow along and you can see that there are various indications based on different populations, okay, which blood pressure medication is preferred in that patient population. In CKD patients, the goal is per ACC-AHA, the goal is to get their blood pressure down less than 130, less than 80. Now, if you look at the KDIGO guidelines, which is the kidney disease and outcomes guidelines, they actually recommend a little bit more aggressive treatment, which we'll go into when we do the kidney disease lecture. But in this patient population, ACE inhibitors and ARBs are preferred. And then diuretics for volume control, again, keep in mind that in the later stage CKD patients, you want to go with the loop diuretics as opposed to thiazide diuretics. And then, once again, the goal is less than 130 over 70. Same with all the other patients. In the case of the ACC-AHA guidelines, there are a few exceptions with regards to when that goal is different. And those are patients, maybe, again, as we talk about elderly patients, you might have to individualize that treatment goal. Hypertensive emergency where you're trying to prevent end organ damage. Pregnancy, the goal is less than 140. In an acute CDA, you have a different goal, depending on if it's a hemorrhagic stroke versus an ischemic stroke, and the time frame from the onset of the stroke, which we'll look at in here in a minute. In pregnancy, the goal is less than 140 over less than 90, so a little bit different from the rest of the population, as we mentioned. This patient population, labetalol and nifedipine are usually the first-line medications, followed by methyl-dopa, just because that's what we have evidence for in this patient population. Aspirin is recommended to prevent preeclampsia. And then in AFib patients, hypertension is the most significant risk factor for AFib. Beta blockers are going to be appropriate for this patient population, and then the non-dihydropyridine calcium channel blockers as well. In a patient who has a stroke, the blood pressure is the leading risk factor for stroke. Blood pressure, just reducing blood pressure down to normal can reduce the risk of stroke 35 to 40%, which is pretty dramatic. But in this type of patient population, for those who've just had a stroke, there's a period of time in that first 72 hours when you're going to allow that blood pressure to be really high, even up to less than 220 and less than 110. And the reason is because after a stroke, there's, and we're talking about an ischemic stroke, there's an area of the brain tissue that can still be perfused because with higher blood pressures, if you try to lower it too aggressively, you'll prevent the perfusion of that, what's called the penumbra, the area of the brain that is still salvageable. And so, there's a period of about 72 hours you're going to allow blood pressure to be a little bit higher. But then eventually, your goal is still going to be less than 130 over less than 80. By the time you see them in the outpatient setting, usually after 3 or 4 days, you want to start getting that blood pressure down. And in this patient population, the calcium channel blockers are actually not preferred. which is a little bit different than any other population because calcium channel blockers have less evidence to prevent recurrent stroke than the ACE inhibitors and the thiazide. They still have evidence, but less preferred. And in hypertension and heart failure, the main agents we're going to go with is the ACE inhibitors and ARBs, beta blockers, and with regards to beta blockers, there's only specific beta blockers, and then aldosterone antagonists. And then, of course, you're going to use the diuretics as needed for symptom management. And we have a whole talk on heart failure, so we'll go over this in a lot more detail at that point. And this is for heart failure with reduced ejection. Preserved ejection fraction is still the same agents, but the focus is more on blood pressure control, whereas in patients with heart failure with reduced ejection fraction, the focus is really on not just blood pressure control, but also the specific medications you're using to get that blood pressure control. In your heart patients, ACEs and ARBs are particularly effective for preventing cardiac remodeling after an acute coronary event, and so those are first-line agents. Beta blockers are usually used for angina. You can use calcium channel blockers for angina control. They include both the non-dihydropyridines as well as dihydropyridine calcium channel blockers. Again, use the long-acting agents. Once again, avoiding the short-acting agents in patients with CAD. And then, once again, for peripheral artery disease, same blood pressure target, same blood pressure medications that you prefer, ACEs, ARBs, calcium channel blockers, or thiazide diuretics. And now this is a little bit new in the 2025 guidelines. The treatment goal for patients who have hypertension and obesity, still less than 130, less than 80. But they do say that you can consider using a GLP-1, which is really new. That didn't exist in the older 17 guidelines. Well, and it's something that you can consider if their BMI is over 27. And we've all known that if you guys have all seen patients who are started on Ozempic or Mounjaro and their weight comes down, you're seeing that their blood pressure comes down. Well, this is pointing that out in the guidelines that you can use that as a way to treat blood pressure, not just for obesity, in those patients who have obesity. Now, level of evidence here is 2B. 2B is a little bit weaker level of evidence. So if you remember the levels of evidence from ACC, AHA, there's class 1, which is lots of support from lots of randomized trials. 2A, which is still strong evidence, and 2B, which is relatively weaker evidence, but it's still a potential option. And then resistant hypertension, again, we have a whole talk about this, so Dr. Pillay will go into this in a lot more detail. But these are patients who have not achieved goal despite being on 3 different agents. Of course, you want to check that aldosterone, make sure that you're not dealing with hyperaldosteronism. And a lot of these patients, of course, evaluate them for any secondary causes of hypertension, and they benefit mostly from the aldosterone antagonists or the mineralocorticoid receptor antagonists. Hypertensive crisis. Also, Dr. Pillay's got a lot to talk about in this aspect as well. Basically, hypertensive emergency, you're going to send them to the ER. That means that they have end organ damage. Hypertensive urgency, you're going to keep them out of the ER, probably, okay, for the most part. And again, a lot more detail coming on that. Okay, here's a clinical case study. 68-year-old male with a history of ischemic stroke and CKD stage 4 with an estimated GFR of 25 presents with a blood pressure reading of 148 over 92. Okay, so this gentleman is already on an ACE inhibitor, 20 milligrams of lisinopril, and diuretic furosemide, which is appropriate in this case because it's stage 4 hypertension, right? 20 milligrams of furosemide BID. What is the next most appropriate step in the management of his blood pressure? A, increase lisinopril dose. That's legitimate, but probably we're not going to get a whole lot of benefit going from 20 to 40 on lisinopril. B, add a calcium channel blocker. That is the correct answer. Now here's the thing. I just told you that calcium channel blockers are less preferred in patients who've had stroke compared to ACEs and thiazide diuretics, or loop diuretics in this case. But this patient is already on on a loop diuretic and is already on a ACE inhibitor. And so, the important thing in terms of managing risk for stroke is to get the blood pressure under control. Absolutely, use the calcium channel blockers if that's what you need to get that under control. It doesn't really have a cardiac indication. Beta blockers are usually used for certain cardiac indications from AFib, post-MI, heart failure, angina. It doesn't have any of those indications. The increased furosemide is already on 40 BID, so probably not going to have a whole lot of benefit from that. He switched from furosemide to a thiazide diuretic. No, I would have said exactly the opposite. If he was on a thiazide, switch him to a furosemide. But in this case, B is the correct answer. One of the focuses of the newer guidelines and the reason for the more aggressive treatment is because it's been shown to reduce cognitive decline, and especially in patients who have hypertension in midlife. And so what we're seeing is that if you have blood pressure that's maybe just in the 130s and 80s, low 80s, well, if you treat them a little bit more intensively, you're reducing their risk of dementia. And so, again, they put this as a class 1 recommendation to go ahead and start them on medication as a result of just the fact that you can not only improve cardiovascular outcomes and decrease all-cause mortality, but also improve cognitive health. There's, again, more and more evidence accumulating that getting the blood pressure down, especially even under 120, has even more benefits, even like 40 to 60-year-old patients that you're seeing. So some practical considerations. You want to engage your patients. You want to help them to simplify their treatment regimens. Get them to be engaged with checking their blood pressure. Help them out by showing them how their 10-year risk score is. Show them the prevent risk calculator. Pull that up. You can go to MD-Calc, plug it in the numbers with your patient right there in front of you. That helps them to engage, understand their risk a little bit better, and then hopefully improve compliance as a result. Okay, so highlights. Okay, now that was the entire talk. I'm just going to go real quickly through the highlights of this talk. So once again, ACC guidelines recommend blood pressure goal less than 130 or less than 80 for a vast majority of patients. Lifestyle interventions are foundational. Healthy diet, exercise. They even mention meditation, stress reduction, but especially the diet and exercise, and we saw the impact of each of those interventions. First-line agents, thiazide diuretics, ACE inhibitors, and ARBs, calcium channel blockers, especially the long-acting calcium channel blockers. But tailor the therapy to individual comorbidities. Again, you have that on your one-page point-of-care reference. Periodically reference the older JNC 8, AFP, ACP guidelines, to especially population. And then recognize that there are different thresholds between the different guidelines. Practice good blood pressure monitoring techniques. So it's so important. No caffeine. Keep that arm at that heart level, not at the lap. Feet flat, back supported, sit 5 minutes. All these things make a difference. Each of these make a significant difference. Stage 1 hypertension, calculate their risk score. If it's over 7.5% or they have diabetes, CKD, clinical cardiovascular disease, you start treatment. If it's less than 7.5%, start with therapeutic lifestyle changes. Still not at goal after 3 to 6 months, start them on medication. Preferred medications. For most people, again, 3 major classes: ACEs, ARBs, calcium channel blockers, diuretics. Reserve beta blockers for those with the cardiac indications of post-MI, heart failure patients, angina, AFib. Stroke patients, you're going to prefer the ACEs and ARBs and the diuretics over the calcium channel blockers. Remember, the black population, less responsive to ACE inhibitors, so go with the diuretics and calcium channel blockers. CKD patients, ACEs and ARBs, resistant hypertension. Remember to use mineral corticoid receptor antagonists after you've had 3 major classes of medications. And then for pregnancy, labetalol and nifedipine are usually first line, and then methyldopa after that. Okay. Thank you.
For the next talk, if you guys need to go to the restrooms, out and to the left. and feel free to grab some drinks and so forth. For those of you joining online through YouTube or Livestream, please either text us on our company phone number or email us for your name, your actual phone with your name, just for recording purposes. We need to make sure the attendance is appropriate. All right, thank you guys.
I have one question.
Yeah.
She's about 75, but blood pressure is always systolic, always extreme. Stays like 115 over 65, 66.
Oh, wow. Okay. Yeah.
She's on, the cousin trying to look at. She's on an arm, she's already at the type guy.
Yeah.
We don't know what else to.
She's already on a medical package, as spironolactone or?
She's, no, we have it on, ties like, she's on I've got to.
Okay. That would probably be the next step for most patients. Of course, you want to make sure there's no secondary hypertension. You want to make sure she's not getting orthostatic when she stands up. But in her case, that would be a pretty good indication to make sure that they're checked for hyperaldosteronism. But usually the next line agent for resistant hypertension is going to be aldosterone. Good question.
So, end result, actually, because there's this extreme challenge.
So when the patient has to. First thing in the morning, same time every day.
Yeah.
What's your preferred?
Yeah, so they actually do recommend in those kind of different readings, so sometimes in the morning, sometimes in the evenings. And that way you get an idea of how it varies.
Sure.
Get the patients to bring in column of readings from the morning, column of the evening. That would be.
I mean, I haven't seen anything specific about it, but I just kind of tell them.
Yeah.
Kind of like ambulatory monitoring.
Yeah,
And
exactly.
sometimes in the morning,
Yeah.
sometimes in the afternoon.
I think that's exactly right. I mean, ambulatory monitoring seems to predict the best, most accurate in terms of outcomes, and so,
So the variety of
Yeah.
for people who want to just check with them.
exactly.
Yeah, I figured that was the.
We also want the blood pressure to always be controlled, right? Not just in the morning, not just in the afternoon.
Sure.
So that's the other reason. For me, I tell them to check it, maybe just once a day, because we don't want people checking it 5 times a day.
Sure, no,
'Cause
then they get
they'll freak
neurotic.
out and they'll,
No.
So I just tell them take it maybe Monday, Wednesday, Friday in the morning, Tuesday, Thursday, Saturday in the afternoon.
Mhm.
That way, when you bring me the logs for 4 weeks, I still have over 30 readings for both
Right.
times, and that can adjust and see. And we'll talk about that in the resistant hypertension talk, but
Mhm.
that we don't want people to just check the blood pressure right after they take their medicine, and then other times it's always
Right.
super high.
Yeah, I hear you.
How's the temperature for you guys? It's okay. It's a little warm in the beginning, but I think once we close the doors, it will cool off a little bit. So before we left, my wife asked me, "Are you sure you didn't forget anything? Are you sure you didn't forget anything?" I'm not gonna admit it, but I forgot to sign. So if you guys don't mind, just writing your name on here for me. We'll do it once each day, just to make sure the attendance is appropriate for all the certificates. So she's not coming up here, so no one's gonna tell her that I forgot something.
Did you say that on live video?
Oh, I very much doubt she's logging into our video. After 21 years in there, I don't think she feels it necessary to support every little endeavor. Well, we're going to talk about CHF right now. Were there any other questions for Dr. George? If there are, we'll address those at the end of this talk. Just to keep on time, to make sure you guys get out by 12 for lunch, we'll try to do a couple of talks back to back, and then we'll take some questions and so forth. Okay. All right, so CHF, just before we get started, how many of you guys do manage your own CHF patients in some form or fashion? Most of you do? Okay. How many of you guys are family physicians or internal medicine? And nurse practitioners or PAs? You guys are all doing mostly primary care, PA? All right, great. So as you guys, as I mentioned earlier, I was a residency director for quite some time, and heart failure in our clinics and residency clinics, of course, we take care of a lot more than primary care patients. People do outpatient because there's a lot of referral options. But when you're teaching residents, we want to make sure that we're practicing medicine, that we're practicing the full scope of what we can. And in that regard, they have some benefits because they get to see the patients inpatient and outpatient. How many of you guys are still doing any inpatient? A couple of you? Okay, great. Yeah. So I did inpatient. I stopped. Well, I didn't stop. I still had some privileges, but I don't do as much in the last year and a half, just because this company, but also for other reasons. But so part of my job is to see clinic patients, and then I was still running the hospital, and of course I helped start 3 different residency programs over the last few years. So doing the residency training as a program director, and had to step down in that role just to be able to try to have a little bit of sanity in my life at this point. But I hope I can answer some questions regarding inpatient as well as outpatient, but this talk specifically is going to be mostly on outpatient management. All right, if you guys can quickly either scan the QR code or just use a text to go into Slido, if you don't mind. Shouldn't take that long. Our first question is, what percentage of patients with preserved heart failure die due to cardiovascular related complications? Hopefully it'll start coming in. And those of you that are online as well, I think there's 5 or 6 joining through online live stream, chime in as well. We'll get at least 10 or 15 responses before we move on. I think we have 20 or 25 attendees total, so if we get at least half, that'd be great. Won't make too long, but let's see. So most people are saying 40 to 50%. Great. We'll talk. We'll get back to this later on. There seems to be a pretty good consensus in the majority. All right, good. Now this is the next case. 67-year-old black male with past medical history of CHF, hypertension, diabetes, CKD3A comes in for a follow-up. His last echo showed a pretty preserved EF without any valve issues. His labs were normal except for the potassium and except for the creatinine. And the rest of the time, he's overall okay, except for when he has to walk over 3 blocks. Then he has some mild shortness of breath. He got a recent stress test that was normal with no ischemia. His current medications include an ARB at a maximal dose, chlorthalidone, which is thiazide diuretic at a maximal dose. He also has dihydropretic calcium channel blocker near maximal doses after a moderate intensity scan. His blood pressure is still not controlled. Exam is fine. What would be your next step? One choice is missing at the bottom. Show it to you. So that's the hydralazine isosorbide. So yeah, you can either add a mineral corticoid, you can add epinephrine, furosemide, the new brand name Entresta, sacubitril valsartan, or hydralazine with nitrate. What would you add in this patient? Technically geriatric patient with heart failure, diabetes, kidney disease, preserved EF, not controlled on 3 medications. All right, and we'll get back to this. So let's see where everyone's kind of going towards. So it seems like there's a split between a mineralocorticoid, a little bit for Entresto, and a little bit for hydralazine, a little bit more for hydralazine now. All right, great. So hopefully we can answer some of these questions. And the final question I have, you have a patient that's 45 years old with hypertension. He's currently asymptomatic, his vitals are okay. Which of the following clinical or diagnostic findings allow him to be considered stage B pre-heart failure. And we'll talk about the classifications later as well. Let's see where we're leaning towards. Elevated filling pressures. Right. Some symptoms based. Okay. All right, we'll get back to this as well. So our learning objectives, we're going to talk about classification schemes. There's 3 different classification schemes. We'll talk about the medications. We'll talk about when to ask for help. We'll talk about when to get help because someone's doing really bad and someone's in the ER. Okay. So how common is this problem? When we look at heart failure, of course we know that in the Medicare age population, one of the leading causes of hospitalization and readmission is CHF. We also know that it's one of the most common causes for mortality if you've been diagnosed with CHF, especially in the geriatric population. A lot of patients have this, we know that, and then unfortunately it's not just in the United States, but it's also global. The lifetime risk for heart failure, we have almost a third of patients who are going to have heart failure, and then if you have hypertension, your risk has actually increased by 50%. And the reason for that is a lot of times patients feel fine. And it's very hard to convince that someone who feels fine to take this medicine, which is not going to make you feel fine, but trust me, in 10 years you'll thank me, right? That's a hard thing to do, but how do you convince these patients? What look at survival rates. And if you look at the one in red, you see that after 5 years, our mortality starts going quite a bit down, right? Or sorry, it goes up, where 50% of patients almost are not going to be around. And if you look at the 10-year data, almost 70% of patients have had some issues happen at that point. So we really need to make sure we're controlling these patients according to what the studies showed us. When they looked at the studies, they noticed that the patients are very tightly controlled, they're trying to follow their diet, they're monitoring them regularly, there's a lot of structure in there. We don't always get that on the outpatient side, so we have to be able to replicate that with a little bit more, perhaps more frequent visits. So this is the case that we're going to follow throughout this lecture. 55-year-old male, past history of hypertension, CHF, hyperlipidemia, diabetes, obesity. He comes in after a year, he hasn't been doing any diet or exercise, he takes the medicines half the time, he is still smoking, and so not uncommon, right? This is probably bread and butter for most of us. Not taking the medicines appropriately, not tracking the numbers too well. He came in because his wife made him, right? As many of us do. And then he drinks about 4 to 5 cups of coffee every day as well. He says, why do I need to take my medications? Because I feel fine. I work hard, I'm active in my work, why do I need to take any of these medications? So how do we answer his question with the latest evidence? The first part, what he's asking us is, why does this matter, right? And one of the things we can talk to him about is the 7-year mortality is about 7%. That may not mean a whole lot to him when we just look at this way, but if we look at heart failure mortality, they have a higher risk factor. Okay. The other part we can say is that over time, it increases. Once you've been diagnosed, once you go into the hospital at least once because of heart failure exacerbation, your risk for going back in, your risk for mortality increases quite a bit. This is an interesting trial that was done. It was actually done in the emergency room setting, in the hospital setting. What they looked at is, if you look at the methods, they looked at 4,000 patients, and we know that there's a lot of stuff in medicine that doesn't always help. But there's pretty good data for ACE inhibitors and ARBs, which means that if patients have been diagnosed with active heart failure, unless they have acute renal insufficiency, everybody should be on an ACE or ARB. But in the patients that are appropriate to get an ARB or ACE inhibitor, only about 80% got it. That means that 20% left the hospital without it. For beta blockers, again, ACE inhibitors, beta blockers, all these medications, there are a good 20-30% that we're not getting it. Then we look at the next one, which is melanocorticoid antagonists, and only 60 or 30 to 40% were getting it upon discharge. And now you look at the newer agents, which is the SGLT2 inhibitors, which have very strong data, which I'll show you later, that 20% less hospitalization, less readmission, and less decrease in morbidity and mortality. So we can decrease it quite a bit, and that was only 1.5 to 2%. The other part that this study showed is that not only did they not get the medicine, but they didn't get augmented. So remember the studies, when you look at heart failure studies, they looked at beta blockade. Heart rate has to be titrated to a resting heart rate between 60 and 70. How often are we titrating the beta blocker, even if the blood pressure is okay, to get that heart rate controlled? The other part is, if you have somebody on ACE inhibitor mineralocorticoid antagonists, and their CKD levels not controlled, so they're still spilling urine, they're still protein to the urine. How often are we titrating that up until we get that microalbumin to less than 30? How often do we check it? We shouldn't be just checking it once a year if it's abnormal. We should be checking it every 3 months, right? So all of this stuff wasn't happening. And what they also found is that whatever the patient got discharged with is what they ended up at 1 year. So for 1 year, not much change is occurring. And this could be due to maybe the provider didn't feel confident, maybe the provider didn't have time because we're all seeing a lot of patients, we've got a lot of things to do each time. Maybe they felt, oh, the cardiologist or the nephrologist, they know what they're doing, they should be taking care of it. And maybe they're feeling like, okay, I'm taking care of X, Y, Z, they have a PCP who should be taking care of it, and it ends up no one's taking care of it, right? So that's the downside. There's some clinical inertia from both specialists and clinicians. Now, the data that I showed you earlier, right here, this is not just patients on seeing only primary care. The specialty rates are actually not much better, which is one of the reasons we do the one-pagers, is we want you guys to look at this lecture, remember a little bit of information, use the one-pagers in your clinical practice. That way you can see at point of care what you need to do, and it's a quick cheat sheet, right? So you can actually use that information to titrate effectively because the evidence already heart failure. Well, we know that the blood pressure, cardiovascular outcomes, heart disease, these are the #1 causes, but there's also other issues. There are some concerns with valvular heart disease. There's some family history for amyloidosis and sarcoidosis and those kinds of things. There's some endocrine issues with not only obesity, but also thyroid problems and renal issues. So there's a lot of other conditions that can cause it. Arrhythmia, the heart rate's not controlled, like AFib, A-flutter, that can be a problem because you have decreased filling time, right? And then you have the infectious causes and the inflammatory causes. And then, of course, unfortunately not uncommon, which is substance abuse. And it's not just cocaine or crack or crystal meth. It's also things like caffeine, right? Someone's drinking 12 Diet Cokes a day, that's a concern. Someone's vaping, they're also having marijuana, they're also having some nicotine gum or chewing tobacco. All these things are additive. So we have to be careful about all these things. So in terms of common associations, we know that the top half is pretty common, right? Cardiovascular issues. But the bottom half is still important because we really need to make sure that we're taking care of the other conditions that these patients are coming in with. And one of the reasons for that, we'll talk about why patients die. So in that respect, the first question that I asked you guys, why do patients with preserved EF die? One way to look at this is that patients with heart failure with reduced ejection fraction die more often than people with preserved ejection fraction. But even in the patients with reduced ejection fraction, 70% to 80% of those patients die of cardiovascular complications. So we have to still make sure we address those conditions. For those of you that mark the 40 to 50%, you're correct. For heart failure with preserved ejection fraction, that is correct. But another way to look at that is 50% of those cases are dying of other causes than heart failure, coronary disease, or blood pressure. So we still need to manage their diabetes or COPD, make sure they're vaccinated properly, etc. And as the Framingham studies have reaffirmed that if you have a reduced EF, you're more likely to die than the patients with preserved. So not only are we looking at what they have initially, but we want to do goal-directed medical therapy to make sure they stay in the preserved side. So how should we approach our patient in terms of what to ask him, what kind of exam should we do, what's the initial work that we should do? So if you look at the history, we want to ask about past history. What kind of symptoms have they had? What kind of workup have they had? Have they had an ischemic evaluation? We don't want to be just repeating tests for no reason, right? If they have an echo from the last year, that's not going to necessarily treat it unless there's some sort of event. We want to see if there's an ischemic event that they've had ischemic evaluation, they've had baseline EKG, not only looking for arrhythmias, but also structural changes. Is there evidence that they're already starting to have LVH, which will eventually become into RM, left atrial enlargement, then right ventricular hypertrophy, then maybe even right atrial enlargement? Because then you have all these areas in the right atrium that are thinking that they're going to take over the sinus node and have AFib or a flutter, right? So we want to see are there structural changes that are occurring. We also want to see if there's valvular abnormalities. From aortic stenosis, because we know that once patients have aortic stenosis and they become symptomatic with presyncope or shortness of breath or dyspnea insertion, their mortality rate is substantially worse. They start having mortality rates in the 3 to 5 year range unless we do something about it. So this is a person that we need to get consulted to a colleague to repair that valve, right? If it's bad enough. So we also want to look for a clinical suggestion. How do they feel most of the time? Are they having any medications to take for this? Are they taking it properly? What's their diet like? What's their portions like? Are they doing any kind of exercise regimen? If patients tell you that they feel fine, what do you do all day? Well, just sit in front of the TV all day and you're not having symptoms. Does that really mean that you don't have heart failure or clinical symptoms? The answer is no. So we want to get an idea, how do you feel when you get up and go to the restroom? How do you feel if you go to Walmart and walk around? How often do you walk in Walmart? Do you take a cart? When they walk into your office, how winded are they? Right? So we want to look at all these kinds of things. We want to see if the sleep is affected because of breathing, or they feel like heaviness in the chest, signs of right side failure. We have typical symptoms, which we all know about, shortness of breath, dyspnea exertion, orthopnea, edema, etc., right? But we also have what we call less typical symptoms, and these are significant. So if you look at these patients, the abdominal bloating, early satiety, abdominal distension, these patients get extensive workup from the GI side. They get put on, because of dyspepsia concerns, they get put on PPIs, they might get other medications, abdominal ultrasound, everything's fine. I had a patient that I had for many years who saw me very compliant with his blood pressure logs, his weight logs. His blood pressures were always perfect, less than 120/80. Heart rate was always maintained. He had AFib in the past. He was always very good, but he always came in. He walked regularly, a couple of miles a day, and he always said, "I just feel bloated. I just feel full all the time." And he had an extensive workup because at the medical center that he was going to before he saw me. And when I laid him down, 30 degrees, definitely had JVP. When I checked for hepatojugular reflex, definitely positive. He didn't really have much edema though, surprisingly. But I added throttle back to him, and after about 4 weeks, he felt a whole lot better than he ever felt before. Now this is a guy that wasn't really having exercise intolerance. His clinical finding and his symptoms kind of went together, and then we did a trial of a drug. And one of the best things we have as physicians and clinicians is follow-up, right? More than anything else. Let me try something, see you back in 2 weeks, see how you're doing. If you're not worse, and if you're better, I'll check some labs to make sure I don't make you worse, that your potassium and kidney function are worse. And if those are okay, we'll continue this. And that's what happened. He did great. So sometimes those subtle symptoms might be what you have to pay attention to. In the exam, we also want to look at the vitals, look at the BMI, see how deconditioned they are. Are they having issues in just sitting there and walking to the exam room? Just when you have to get up from the exam room to stand up and move around, are they winded? These are all things that we have to be paying attention to. And I think a lot of times in the current era, a lot of times the exam is suffering. Obviously because I teach and train students and residents, we pay a lot of attention to the exam. But how do patients just lifting up their shirt and laying them down 30 degrees, examining that way, looking for edema, these things are all important. Speaking of edema, whenever I ask the residents, how do you measure edema? I get lots of different answers. And so just to make sure that we're all on the same page, when you talk about edema, you want to see if it's pitting edema or non-pitting edema. So pitting edema, of course, you put pressure against the anterior part of the tibia, and you push down until you reach the tibia. And then you let go. And if it indents, obviously it's pitting edema. Then you want to say how high it goes. Is it to the mid-tibia? Is it to the knee? Is it even higher, right? Is it all the way going to the abdomen and scrotum? That's anosarchy. That's no longer just pitting edema. So that gives you a heart issue. Now, otherwise, if you're looking at how much edema they have, 1 plus edema, 2 plus edema, 3 plus, these aren't things that we just eyeball. 1 plus edema means that the depth is 1 millimeter. Okay, 2 plus edema is 2 millimeters. So as exam findings, they should not be subjective because they should be reproducible and valid. So it can't be my impression of 1 plus and your impression of 2 plus, right? It has to be something that's standard. So it's the depth of millimeter of edema. Right? So hepatojugular reflex, I mentioned this earlier. So when we lay someone 30 degrees and then we look at their neck veins, if it's over 5 centimeters, that's JVP. If it stays above 5 centimeters, that's JVP. Measured from the sternum notch. Now, if you push on the right upper quadrant and you push down and you hold it there, everyone's going to rise. But you hold it past 10 seconds, those of us that don't have any conditions, that rise should go back down. It shouldn't be as inflated. But if that person's JVP is still high, then that's hepatojugular reflex is positive. Signs of right-sided congestion, right? From the heart, it goes out to the liver. So it's something to think about if you're not already checking that. And then, of course, you also want to look for changes for liver disease, but unfortunately, for clinical signs for early diagnosis, hard because liver disease signs, the telangiectasia, the TPI, all these other things are very late findings, right? So we may not always see that in the early parts. So there's more specific signs, perhaps a little bit less sensitive, and then we have one sensitive, but perhaps more sensitive. So these are some things to think about. If you're not already incorporating some of these into your exam history, I would encourage you guys to start incorporating them. So what should we do for initial lab and EKG testing? CBC for everybody, at least once a year. You're looking for anemia. If they're anemic, let's figure out why. We don't want the heart to have to work harder and cause structural changes because they're anemic. If they have erythrocytosis because they smoke or they drink or they're on testosterone therapy, let's do something about it. It may be as simple as telling them to donate blood every few months. That's a very quick way to solve that. But let's make sure they don't have another hypercoagulable state because their blood count's so high. Right? We also want to take a look at their platelet function because if they have CHF, more likely than not, they're probably going to have some underlying ischemia or coronary disease, and we're going to put them on some sort of antiplatelet therapy. We also want to check the kidney function and the electrolytes, because some of these might be diagnostic, but some of these we might make worse with the medicines we choose, so we want to make sure we're controlling them properly. And then, of course, we want to look for urinalysis to see for any early signs of kidney disease. Not just proteinuria, but also are there red blood cell casts. If they're RBC cast plus they have hypertension, maybe there's some sort of nephritic syndrome going on. If their urine is looking at 3+ proteinuria on a random urinalysis, and they have a lot of edema, and their albumin's low, and their blood pressure's high, maybe there's nephrotic syndrome that we're missing, right? So we wanted to pay attention to these labs, and I always tell the residents when they want to order, convince me why, right? And as long as they have a solid answer for why, it can't be, well, I'm trying to figure this out. I'm ruling this out or I'm ruling that out. That's not a real reason. I'm making sure that I'm crossing out this differential because this patient has X and Y findings. Lipid profile, really a risk prognostication. We have good data that the presence of a statin helps in a lot of different ways. And we'll talk about that later, but the presence of that statin makes a big difference. However, there's some argument to get that LDL down full, depending on their underlying condition as well. And then iron studies. So if you have a patient who has slightly elevated ferritin, their transferrin's a little high, they've got slightly abnormal LFTs, right, which we're thinking is fatty liver, but maybe not. Maybe their AST/LT only double what they should be. And they have some erectile dysfunction, you feel their testicles are starting to become soft and a little bit smaller, maybe some chromatosis, right? These are conditions, of course, if you go to a specialty talk, it's going to be that we're missing a lot of these cases. And there's some validity to that, but it's not it's not a high number, but it's still possible. So diabetic with abnormal LFTs, maybe some erectile dysfunction issues, and mild elevation of iron and ferritin, maybe a transferrin level, we'll figure it out. Okay. Thyroid both ways can cause a problem. EKG, at least once we make sure you have the baseline EKG. You're looking for structural changes, LVH, atrial enlargement, etc. You're also looking to see if they have are they predisposed to arrhythmia because their QT interval is high or wide. There's some sort of bundle branch blocks. If you have a patient with CHF, new left bundle branch block, you got to make sure there's no underlying ischemia. Okay. And then, of course, A1Cs. So if you have somebody that's anemic, we can't always rely on the A1C, right? So either check a fructosamine level or do some blood sugar testing. BNP, we use this regularly, and I want to make sure we're using it correctly, so I'm going to do a whole slide to this. So when we look at BNP, you can either do a BNP or a pro BNP, either one, but you cannot use them interchangeably. So whichever one you're using, continue to use that for your trend. Okay. There are a couple of things that affect the BNP. So if you have renal disease, for example, it changes a certain way. If you have obesity, then it might give you a falsely reliable reading. And then you can do serial measurements, but there's only certain ways that it works. You can't do it every single day. One way to use a BNP is to see if they have underlying heart failure right now. Someone comes in with classic symptoms, they smoked a lot, or you're not sure if it's COPD or CHF or both. A level that's pretty low, a BNP less than 50 tells you it's probably not acute heart failure. A pro BNP less than 125 tells you it's not. So you can't use them interchangeably because there's a little bit of discrepancy between the two. Make sense? Now, if they're 400, 4,000, 400,000, it doesn't matter which one you use. Now, what about the other side? So if you have the higher the BNP, the more likely it is heart failure. What I mean by that is if you have a BNP of 200, it's probably heart failure. 400, 4,000, definitely heart failure. 400,000, no matter what else is going on, there's definitely heart failure, right? So the higher the number, the more the predictive value. The stop heart failure trial, this was looking to say, are we missing people? So what they looked at is usual care plus get a BNP just to see. And this was done a while ago. But what they showed is that we got more patients diagnosed because these are signs of elevated fluid pressure also in a sense, right? So we're looking for elevated BNP in those patients, maybe we're missing some of these heart failure patients that are coming with other day symptoms like that, abdominal bloating, or this tie. Those are the people that we're missing. Another trial looked at using the BNP after admission, okay, when they're about to go home. And what they found is that the BNP does not decrease by 30%, they're probably going to come back in at some point, where the risk for readmission or mortality is higher. Another way of looking at that was if the pro-BNP did not go to less than 1,000 upon discharge, that also had worse prognostic. That also prognosticated with worse life. So on the outpatient side, we want to see them pretty soon, and we can check the level to see, you know what, is this person that level still pretty high? They're not quite diuresed yet. They don't need to go to the hospital just yet because they feel okay, but I might want to see them every week for a while, right? Until I get them fine-tuned. What about diagnostics? I'm going to skip to the next slide because it's easier to see. So if you look at basic tests that we do chest X-rays and we do echoes, right? For echoes, not only are we using it to look at the EF and the valves, but we're also looking sometimes at patients who need chemotherapy when we get baseline pre and post. And in some cases, we're also trying to see, do they have significant valvular disease? Do they have areas of the heart that are not pumping properly? Is there diastolic dysfunction, et cetera? The chest X-ray can give us clues about pneumonia, effusion, is there something else going on? One point I would like to tell you guys, if someone is newly diagnosed with reduced EF heart failure, so heart failure, reduced EF, they almost 50% of the time they have some sort of underlying ischemia. So the guidelines do state that if you have a new diagnosis of heart failure with reduced EF, they need to go and undergo an ischemic evaluation. Now, I'm not saying that the hospitalist has to do that, but we need to arrange for that as an outpatient. Okay? Good question.
I was just rubbing my eye.
Oh, okay.
Sorry.
No worries. All right, so functional testing, I'm going to skip over. I just want to let you know there are things that we can do looking at function, which is 6-minute walk test. This can be done in the office for us. It can be done with a specialist for different staging issues. And then a lot of the cardiopulmonary testing, as well as cardiac PET-CTs, and those kind of things, typically, they're looking for more advanced stuff. Sometimes for ischemia, but more times when they're looking for like transplants and LVAD and stuff like that. So now our patient comes back, how do we classify him? What kind of terms should we use to make sure that when I talk to you on this phone, you understand what I'm saying, and we're both talking the same language, and so that we can coordinate our care. And then how do we look at that to direct our goal-directed medical therapy? So the first one I'm going to talk about is the ACC-AHA classification. And these go from a stage of A through D, okay? Yeah, I'm going to go to the next slide because it's easier to see. So A is you're at risk for heart failure. You don't have any symptoms, you don't have any structural findings. You don't have any exam findings, just at risk. That's stage A. Stage B is where you have structural findings, still don't have any symptoms. And that's the key. Once you have symptoms, now you're in class C. And then class D is end-stage heart failure or refractory heart failure. Despite everything you're doing, which is the right things that you're doing, you're still having recurrent hospitalizations, you're still having symptoms and so forth. Then we have the New York heart. That goes from 1 through 4. This is the one that we all kind of grew up with, so to speak, right? The way this one works is based on your symptoms, okay? So you have class 1, really no symptoms. Class 2, no symptoms normally, but with severe exertion or significant exertion, you have some symptoms. And then class 3 with minimal exertion, even with ADLs and stuff, you have some symptoms. And class 4, even at rest, you have symptoms. So why were there new classifications? Well, the reason is because with this one, it's subjective. I'm depending on you to tell me the answer. Also, you're depending on me being a great doctor to figure it out, right? Some patients, you've all seen patients, you ask them, did you tell the ER doctor about this? No. Why not? He never asked. It's his job to ask. I have patients tell me that all the time. Did you tell the cardiologist you're having chest pain still? No, he never talked to me. He just came in and left. Right? So we want to make sure that both sides are doing our jobs. So the first part I would say is if someone comes in and let's say they came in when they're tightly controlled. Class 1. They had a big Thanksgiving meal, they had some drugs, they're horribly symptomatic, class 3, class 4. Right? So this is a huge variation. Or you have a doctor who didn't have time. Your doctor's really busy, they've got lots of stuff going on, trauma going on. What do you do at home? They don't have time for that. And so sometimes maybe they didn't get a chance to do the proper exam. So it can change over time. There was limited reproducibility, validity, depending on who asked and who's answering. But nevertheless, we have about an 8 on it, right? We know that people with higher stages do worse off. We know that it's used a lot in studies. We use a lot in clinical practice. So, it's still worth looking into. So now our patient comes in. He's had his echo done. There was some LDH on the echo, left atrial myopathy on the echo. He's got diastolic. His EF is preserved. No other problems. His blood pressure is still not controlled. He's got some symptoms now, which is different than before. Now with heavy exertion, he's got some symptoms. And then on exam, he's got some JVD and clubbing. So how do we classify this patient? This is important for your coding team, your billing team, and the powers that be for reimbursement, but it's also important for the language that we're speaking. So this person has not just hypertension, he has hypertensive heart disease with heart failure. That's your first code. Hypertensive heart disease with heart failure. The second code you're going to add is the kind of heart failure. He has diastolic heart failure that's chronic. Okay? And then you're going to add that what stage is he. Just by the fact that he has symptoms, he's now class C, or the ACC classification, right? He's class C, he has symptoms. He has symptoms with more heavy exertion, not with normal activity. So therefore, he would be class 2. So if we put all that together, it's hypertensive heart disease with heart failure, diastolic heart failure, so he would be technically in the category of heart failure, preserved EF, class 2C. The reason I spent so much time on this is I want you guys to start looking at this in your documentation and start working on documenting it this way if you're not already. And the reason for that is if we don't do it that way, on a good day, we think clearly we're doing everything right. But sometimes you got 20, 30 patients and you maybe didn't do your charts well, right? And so how well and effectively are you making sure that each patient is cared for right? So having this in your problem list or wherever you have it, it helps. So we have lots of risk factors and a lot of quality of life factors that patients care about. So we want to make sure we address some of these things also. Is there some sort of underlying mental health issue that we need to address? Because these things matter, right? Patients are not going to, if someone is extremely depressed or anxious, you telling them all these great guidelines and things like that, none of that matters. You tell them to exercise all the time, they can barely get up and take care of their basic necessities. So we want to address their mental health issues. We want to see if there's any other issues that we need to worry about, some fall risk and support and any social services. So try to get those kind of comprehensive assessments in place as well. Dr. George talked about the blood pressure goal, and absolutely we want to reduce the blood pressure. If we don't reduce the blood pressure, the morbidity and the mortality rates are higher. In fact, when the blood pressure is reduced, the outcomes are way better. We know that from data. So most of my references are either at the bottom of the slide or they're at the end of the reference page. So feel free to look at those. Spring trial was very good about telling us that people do better if we control their blood pressure to goal, regardless of age, unless they have symptoms. So if they have symptoms, regardless they're 70 or 80, get them down to goal unless they have problems. Problems could be symptoms, orthostasis, etc. Problems could be potassium's too high with all the drugs you're giving them, or the kidney function is getting worse, right? It could be any of those things that are problems. But if they don't have any of those problems, we want to keep them below 120 rating. T2 data, I'll show you this later, but just as an overall management, they reduced overall risk for hospitalization and morbidity mortality by about 20%. It kind of depends on the study you look at, but about 20% is the average. What about diet? Good data for both DASH diet and Mediterranean diets. Mediterranean diets have the benefit of making sure that they're for longevity. It's easier to follow for a longer period of time. DASH diet, we have talks about what a sodium level should be. So we always say less than 2 grams of sodium, right? That's a common thing that we all hear about. Does anybody know conceptually what a 2 gram of sodium is? About how much that is? And we're the ones telling the patients, right? Half a teaspoon total for the day. So patients always tell me, I don't want any extra salt. Well, that doesn't matter. McDonald's put it in for you, right? Or Pizza Hut put it in for you. It doesn't matter who put the salt in. So I tell my patients, if it doesn't taste like bread or water, it's got salt in it. So it's not just the packaged foods and the chips and all those other things, but it's also the turkey meat from the deli, which is preserved in sodium, right? Subway, all those things have a lot of sodium. So people can be very frustrated with what they can eat with sodium intake. One of the trials that showed in the inpatient side is that if you keep it below 1.5 grams, there's benefit. But if you go to less than 0.8, it doesn't add any more benefit. So the right answer is somewhere between 1.5 to 2.5 grams of sodium per day. Not sodium chloride. We also know that it's low saturated fat. Getting your protein through some non-animal based products is also a good idea. We want to have more fiber in the diet because that preserves your glycemic index and also keeps you fuller longer. And also there's some good data against preventing colon cancer. We want to know, have a little bit of calcium, and if you can tolerate, that's great. But if you can't, you use like lactate or something. But there's good studies that show that people that tend to have a couple of servings of calcium through dietary intake, they tend to be healthier. Now, is that because the people that drink milk and you eat yogurt typically also exercise? Maybe, right? But there's some good data that this is a nice memory stabilizer, but people that eat this kind of stuff stay fuller, so they don't eat the bad stuff as much. And I tell my patients in terms of diet, what can you do? So for example, if you had one of the muffins, right, that we tempted you with outside, one of those muffins might have been 300 to 400 calories. You're a quarter of the way done for the day already. Or you could have had a small bowl of cantaloupe, 40, 50 calories, 2 hard-boiled eggs, another 150 calories, and then maybe a glass of milk, another 140 calories. So you could have a 500-calorie breakfast, 2 eggs, some fruit, and a yogurt, all for the same calories as one muffin, right? Similarly, if you had one slice of pizza from Papa John's that had meat on it, about 400 calories. That would take you 8 apples to get to 400 calories. But none of us could eat 8 apples because that chewing time and that fiber and that sugar, it would prevent you from getting there. So we want to encourage our patients to get their fruits and vegetables first, then focus on eating as bad. Okay? The key, and I'll talk to this about more in the obesity talks, I don't want to spend too much time here. The key is not making sure the patients still feel full. All right, nutritional supplementation. So there's lots of stuff out there, right? And there's not good data that any supplementation makes a difference, unless you're deficient. If you're iron deficient, yes, let's replace the iron. If you're B12 deficient, let's fix that. If you're vitamin D deficient, fine, let's fix that. But if you're not deficient, there's no good data. The vitamin E studies about cognitive health and maybe helping heart actually were not true. They increase the brain bleeds, they increase other bleeding, and the trials on heart disease prevention were stopped early because they had worse outcomes. If you have too much vitamin D, kidney stones, right? Too much vitamin C doesn't do a whole lot. We'd rather get it in fruit form rather than pill form. If you take too much zinc, it can affect your sense of smell. And there's all sorts of side effects. The point is, unless they're actually deficient, no need to replace. And there's strong evidence to suggest that. The data on PUFA, so the polyunsaturated fatty acids, I'll show you guys later, the data on that, but over-the-counter products do not help. Right? Our activity, I'm going to skip over some of this because I think we all know. Activity is good for you, helps with depression symptoms, helps with reducing fall risk, helps with muscle mass. But one of the things I wanted to let you guys know about is cardiac rehab. For those of our patients with heart failure, if we refer them to cardiac rehab, what do they get? They get a comprehensive assessment about their overall health, their diet, their exercise, their medications. They tell them why they take the medications. They give you some basic strategies to stay out of the hospital. For example, if you're noticing more symptoms, your weight's increasing, maybe take an extra dose of diuretic for 3 to 5 days, right? Strategies like that. They also keep an eye on their weight and their blood pressure. So these are some basic things that they incorporate. If, however, your patient cannot afford it or their insurance isn't covering it, I gave you some basic guidelines on how you can recommend some basic rehab. I gave you some basic information about aerobic stuff you can recommend, as well as some of the resistance training you can recommend. Okay. And those are the slides that you have available to you. And we talked about our patients who have about 30 to 50% of the time, they're dying of other reasons besides heart disease, depending on the kind of heart failure they have. And so we want to make sure we still have a comprehensive strategy. We want to make sure they're vaccinated, we control their diabetes, we control their weight management. We do all the things that we're still supposed to do because we cannot just focus on one thing, right? That's kind of the job we've taken on, is that we're taking care of the entire health. So what are some of the medication benefits? The first part, ACE inhibitors. We know that helps with remodeling, it reduces morbidity and mortality, and then overall it can also help with hospitalizations. And there's several trials that show that have been referenced in here. The statins do a couple of different things. They not only help with the LDL and the cholesterol, they also increase the HDL cholesterol, which is protective. They stabilize whatever plaque we have, and we all obviously have some plaque, right? They stabilize that plaque so that it doesn't flick off and go and cause heart disease, strokes, heart attacks, etc. Well, for all of these reasons, the presence of a statin is beneficial, but of course, in patients with compelling indications, we want to get their LDL and HDL to go. For ARBs, similar to ACE inhibitors, there's lots of data initially to show that they're non-inferior. There's some data now that talks about maybe there's some mild superiority, but again, the basic thing is that you have the renin-angiotensin system affected, but also the vasoactive mediators are also decreased. So those are 2 reasons by far that they help. Big afterload reducers, so they quite a bit to help in terms of blood pressure reduction. For beta blockers, Dr. George went over their mechanisms, so I'm going to keep going. And then in terms of overall renal considerations, which is a big part, heart and kidney go together all the time, right? So there's a lot of renal blood flow all the time. 20% of cardiac output is going to the kidneys. The problem, of course, is that this is looking at the GFR, and the GFR is affected by lots of different things. And then over time, kidneys trying to auto-regulate. But when they start getting some of the cardiovascular symptoms, they start getting reduced GFR. We try to compensate for those symptoms with giving diuretics, which pull the fluid out of the vasculature. They don't just go to the legs and pull the fluid out. They get it from the vasculature. So if they don't have enough albumin, if they don't have enough kidney function, if they don't have enough volume, that's going to worsen their kidney function and reduce the GFR. So the things that we're trying to compensate for, we have to make sure they have good nutrition, that they're drinking plenty of water, they're not taking NSAIDs, otherwise it's going to make this up worse. So we know that this makes a difference for ACE and ARBs, the RAS inhibition. We know that it helps with not only the inflammatory modulation, but also hormonal, but also overall into patient-related outcomes, such as reduced hospitalizations, reduced mortality. The greatest benefit is going to be for heart failure with reduced EF. However, there's strong data now that also helps with preserved EF. So both classes you can use it in. There is no difference among the ACE inhibitors, so you can use one of the older ones. The big difference is obviously in terms of how often they're taken. If you have a medication like enalapril, which has to be taken twice a day, even lisinopril, which we think is once a day, it doesn't fight us a full day. So just be careful about those kinds of things. Now, in terms of the ARBs also, really doesn't make a big difference. What you do have to make sure is that we're not giving them high doses right off the bat. Otherwise, we're going to cause potassium issues and kidney issues. If I give everybody here an ACE or ARB, all of our kidney functions will decline by up to 20-30% in the first 2 weeks. But then our kidneys take over, they auto-regulate, and it'll go back to normal. So after you initiate an ARB or augment an ARB or ACE inhibitor, we should check the BMP within 2 to 4 weeks, just to make sure we're not making it worse every time, not just the first time. Okay, so the next one is beta blockers. We talked about this now here. Not only does it help with chronotropic effect and blood pressure, it also reduces the myocardial oxygen demand. So the work the heart has to do, which is one of the reasons that it's beneficial in heart failure. The trial data is different in this one than the ACE and ARBs, where we do have specific ones we should be using. So here we should be using bisoprolol, extended release metoprolol, or carvedilol. Those are the only 3 what we call evidence-based beta blockers. When you look at the one-pagers, I've listed that as using evidence-based beta blocker. These are 3 that were mentioned. If you look at the one-pager, when you guys take a look, the first part is about symptoms, how to diagnose, and then I have all the classifications listed there. Below that, I have the history and exam findings, and below that, I have the labs that we should be ordering, what kind of things to look for an echo or chest x-ray, and then after that, we have when to send to the hospital, when to send to the cardiologist. Diuretics are our mainstay of treatment, both clinical symptoms, but also in terms of fluid overload, those kinds of things. So one of the things that we do is that we notice that patients that have, when they're in their acute phase, having a diuretic makes them feel better, but also reduces readmission and keeps them out of the hospital, because you're ultimately diuretic them. The question about mortality is kind of, it depends on what you're looking at. Long-term mortality, there's no good data that diuretics can make an improvement. In the short term, in the acute inpatient setting, absolutely. They can become resistant. If they take NSAIDs, the diuretics don't work as well. Okay? If they have a lot of high salt diet, it doesn't work as well. What you can do though, you can sometimes give them IV. You can use a better bioavailable diuretic, or you can combine diuretics, adding metolazone or something like that. But again, that comes with the price. You add more diuresis, they feel better, their numbers look better, but their kidney gets worse. They get more hypokalemia. Okay? So when we look at diuretic types, loop diuretics are the mainstay. So I want to spend a little bit of time on the different kinds of loop diuretics. The mainstay of what we use is furosemide, bumetanide, or torsemide. A couple of things to think about is that the furosemide has the lowest half-life, and the PO to IV conversion is the worst. Okay? So I'm going to skip over this to the next one. So furosemide, 40 milligrams of oral furosemide is equal to 20 milligrams of IV furosemide. So there's a 2-to-1 conversion there. That's one downside in the outpatient setting. Number 2, it doesn't last that long, 6 hours or so. So theoretically, patients would have to take it 2 or 3 times a day. Okay? I tell my patients to take it at 8 a.m. and 2 p.m. That way, around 8 or 9 p.m., it's out of their system, they can sleep through the night and not wake up at night and maybe fall because of other reasons, right? So I try to tell them not to take it at night. But if you have a choice, these drugs are coming down in price. Torsemide is now very affordable. It's not $4 or $2. It's not $2 or $4, but it's actually gotten to the point where we're having a lot of range for torsemide. So it does work pretty well. The newer agents, the ARNIs, these have a lot of different reasons that they work. They help with fluid retention, decrease the vasoconstriction, fibrosis, remodeling. So these have become a mainstay of practice. And we'll talk about when to use these patients. Now, if they have angioedema to an ARB, they cannot be on this drug. There's strong trial data. I'm going to go through these this time. In the initial, there was very strong data for chronic heart failure with reduced EF. Then data came about with mildly reduced EF. And now there's more and more data that says that every stage of heart failure, in every classification, mildly reduced, reduced, or preserved, ARNIs are a strong suite, as long as you have New York Heart Association 2 and above. Okay. So we'll show you guys that data in just a bit. I'm going to show you this in a table format, which is easier. I know you can't see too much of this, but hopefully you can see the slides. But basically, regardless of what you looked at, whether it's hospitalization, readmission, mortality due to cardiovascular causes, or mortality due to all causes, the ARNIs did better in the patients with advanced heart failure. They're better data than the reduced EF has better data than the preserved EF, but they still are both pretty strong, 20% reduction almost, compared to phenolic. What about the mineralocorticoid? Also, pretty good data about reducing symptoms, but also in terms of effective diuresis, blood pressure control, and data. In the patient that's adequately controlled with ACE inhibitor and beta blocker, adding the adding the MRAs will lower their risk by 15 to 18 to 20%, depending on the trial you look at. And that was really in the RAILS, EMPhASIS, and EMPhASIS trials. All right, so this is the data on the MRAs. I should project it better, but on the right side of the screen, which is this side here, this is the reduced EF. The effect sizes are more pronounced. So that's why it has indications for that. But if you look at the preserved EF, and I'm sorry that it's not projecting as well, but on the preserved EF, the effect sizes are a little bit less. They're not as robust, but it is better for heart failure readmission, for mortality, both of those. So in both classes, you can use it, but the stronger data is for heart failure with reduced EF. What about hydralazine isosorbide? This was a tried and true drug for many, many years. It worked. Lowered the blood pressure, made people feel better, it worked great. Why did it get out of favor? Because when the ACE inhibitors and ARBs came out in the 90s, they were just 20% better across the board in terms of hospitalization, admission, and mortality. So we went to those. But in the right patient, so if you have an African American patient with the low EF, okay, reduced EF, and they are already on the other drugs, ACE inhibitor or ARB, beta blocker, and mineralocorticoid, once they're on all 3 of those, if they're not controlled, you can add this drug, and it'll make a difference. Or drugs, because some patients, you give them a little of anything, their potassium shoots up, or their kidney function doesn't tolerate, or they've had angioedema. In those patients, this is a great drug. Okay. So now what? SGLT2s. SGLT2s show great data in terms of reduced hospitalizations, reduced readmissions, reduced mortality across the board in all classifications. Better data initially for reduced heart failure, but now preserved heart failure data has come out too. All right, so there's a new drug which I haven't used yet, which is called sotagliflozin, and this is a dual inhibitor of SGLT1 and 2. Time will tell how effective that is and how the data is on that. Let's see for 3 or 4 years. This chart, all I'm trying to show you guys here is that all these different trials, all the trials were ranging from 500 to 4,000 patients in each of the trials, and they all show the same similar amount of benefit, between 15 to 22% reduction in outcomes, in bad outcomes. So now we have indications for a couple of different things. SGLT2 for diabetes, CKD, and heart failure. All of them independent of each other. So if you have a heart failure patient without diabetes, without CKD, they should still be on this agent. What if you have a patient, I told you guys when we look at the heart rate, we want that heart rate to be between 60 to 70. What if the patient's blood pressure is perfect, if they're like 105 over 70, but their heart rate's 90s all the time? They're already on a beta blocker. In those patients, as long as they have sinus rhythm, you can consider adding evaporating. The data is not superb, right? We're talking about a 5% incremental difference in bad outcomes, but it's something we can add. If you take that 5% and extrapolate over 100 million patients a year, that leads to some significant change. So evaporating is something you use for heart rate control without compromising blood pressure. And then next one is that you have various VI. This is another one, about 3 to 5% improvement in outcomes. This is a patient who's on everything else, all the other goal-directed medical therapy, but they're still not feeling control, they're still having recurrent hospitalizations, they're still not there. So you can add this medication, and hopefully it'll make a little bit of a difference. We're talking about a 3% difference in outcomes. So again, not magical, but something to think about. So how do we do all this? I talked to you about all the different guidelines and all these different medications. What do we do? And this is the part I think the one pages will be really helpful for, because what we've done is make a table for you that talks about each of the classifications. We have it incorporated into the New York Heart and the ACC classifications, and for each class we say this is what they should be on. Okay. So our patient was given naloxone, they were titrated up to 20 milligrams. They were also given atenolol and verapamil, and they come in. They've already had a negative, they have a ischemic evaluation that's pending, they're on a low-dose statin. Their heart rate is okay, and their blood pressure is okay at this point. What should we do for this patient? Continue the same regimen? Probably not. The first thing I would say is that, right, the beta blocker, which is atenolol, is not a clean beta blocker. It has a worse lipid profile. It hasn't been studied in the literature, so we want to switch it over to an evidence-based beta blocker. This patient has CHF, so they need to be at least on a moderate intensity statin. Pravastatin is not going to cut it, so we want to increase that to rosuvastatin. And last but not least, verapamil, which is a non-dihydrogenated calcium channel blocker, which worsens the heart rate, or I'm sorry, it affects the heart rate. There's strong data that those patients, heart failure patients, those class of medications actually worsen outcomes. Mortality is bad, unless they have AFib or something like that. So in this case, all three B, C, and D are correct. If they've had MI, of course, they need to be on a beta blocker, ACE inhibitor, and statins. If they have OBF, maybe switch them over to a diuretic, especially if their CKD is worse, switch them over to loop diuretic. All right, in the stages of management, I'm going to go over this in a table format, actually. So if someone is classified, remember we said that the heart failure with preserved EF is better than the heart failure with reduced EF. So if someone has reduced EF on admission or initial diagnosis, and they stay reduced, they're reduced. If they go from 40 to 60, we never call them preserved EF. We just call them improved EF. And the reason is because we have to remember that at one point they were low, and so they're still in that classification. So we want to treat them aggressively because they still have a worse outcome. People that have preserved EF, when they drop down to less than 40, they're considered reduced EF. If they drop down below 50, they're considered mildly reduced EF. So the whole point is that you have to consider what is the worst EF when you start treating patients, and that's the classification is stable. So when we look at heart failure with preserved EF, they stay preserved unless their EF drops. If they're mildly reduced, if they keep dropping even more, they go down to reduced. So medication management for stage A, which is just risk factors, no symptoms, no structural findings, we want to put them on a statin. We want to make sure that they have the right diabetes medicines. If they're on diabetic medicines, put them on SGLT2 inhibitor. And then, of course, if they're stage B, structural findings, no symptoms, it depends on their EF class. So if their EF class is low, make sure they're on an ACE inhibitor and beta blocker and a statin at least. And then if the EF is higher, then we control their risk factors. So I'm going to show you this on a table because it's easier to follow. So once they get to the more advanced side, right, stage C, stage D, if they're class 1, really no big symptoms, manage their comorbidities, ACE and beta blockers. Once they drop their EF, pretty much the same. If they get much, much worse, we have to augment their goal-directed medical therapy. Once they start getting worse, class 2 to class 4, that's where we start doing more things for them. We switch them over from the ACE and ARBs to ARNIs. That's preferred. And the loop diuretics, the mineralocorticoid inhibitors, and the SGLT2s. If they're not controlled with their beta blocker for their heart rate, we add the ivermectin. If there are all these things and they're still in the hospital at the time, that's when we add the Vericiguat. This is if you have trouble figuring out if they have heart failure or not, there's some rubrics you can use. And the links are there, I'll let you guys look at it yourself. So what do? We want to control their blood pressure, their diabetes, their obesity, their CKD, their CAD, and their AFib. We want to control all of these things because that's how we keep these patients healthier for longer. We want to reassess these patients regularly. Don't just follow them up 3 months if they have not controlled yet. So you want to make sure you see them on a regular basis. Consider using the BNP like we talked about on a regular basis. Make sure we check the BMP regularly and check the echo to see if your goal-directed medical therapy is working. Typically, after 3 to 6 months, you should be getting some improvement in the remodeling and the ejection fraction, post-MI. All right. I'm going to give, for the interest of time, I'm going to kind of go a little bit faster on this. A couple of things that we want to look at is if they're not controlled and they have a low EF, you could consider digoxin. It makes them feel better, doesn't keep them out of the hospital. The omega-3 fatty acids, the prescription ones, not the over-the-counter ones, can help by about 1 to 2%. So not a big difference. Okay, last resort. And then potassium binders. This is key because a lot of the agents we use mess with the potassium. And so sometimes patients with CKD, give them a potassium binder regularly so you don't have to take them off the ACE inhibitor and go to the ERB or the minus. All right, this is what Dr. George was talking about, semaglutide. There's now data for semaglutide that it makes a difference in heart failure patients. So 17,000 patients, huge study. It showed a pretty good improvement in outcomes, especially in the heart failure with reduced EF. Not as much as preserved, but definitely the reduced, which is great because that's the people that got more often. And this was reproduced in Lancet in 2024. And then tirzepatide, which is Mounjaro, also showed some of this. Now the data for Mounjaro and this, what was interesting here is that not only did it improve outcomes that we care about as clinicians, outcomes for hospitalizations, readmissions, but it improved the rate of the symptoms. How often they had to use diuretics, how often they were classified class 3 and class 4. And it also reduced, improved their walking distance, their 6-minute walk distance without symptoms. So there's some good data for the Mounjaro products as well as the other GLP-1 agonists also. All right, a couple things to avoid. Calcium channel blockers that affect the heart rate. Verapamil, Letaza. Don't use those in heart failure because they increase the mortality data. Diazolidine diols, obviously we know they increase the fluid retention. DPP-4 inhibitors, this is something that you may not know. That DPP-4 inhibitors and Januvia, Tradjenta, these drugs, they can also cause the worst outcomes in heart failure patients. Not a huge impact. And then answers we know about. All right, I'm going to skip over some of this. I've given you guys guidelines on when to refer patients for CRT and ICD therapy. Okay, which patient, which class. Not only am I giving you the data to justify it, but I'll tell you why very quickly. When we looked at patients that were in New York Heart 2 and 3, right? New York Heart 2 and 3, 67% of the time they died of the same reason. Guess what that reason was? Anybody? Sudden cardiac death. How do you prevent sudden cardiac death? It's pretty hard to do. So we found that because the most common reason for that sudden cardiac death was VFib, VTAC. And what's the best effective treatment for that? Immediate shock, right? So that's where the data show that these guys, if you implant the right patient, New York Heart 2, 3, class C, class D heart failure, in patients who have a low EF, a QRS that's appropriate, in those patients, reduces morbidity and mortality up by 20-30%. So that's what all these trials are showing. So I won't go into the study details, but this tells you which patients should undergo valve repair for mitral valve disease and which criteria should be used to set them for aortic valve repair. Okay. And when to use ICD versus CRT, the differences between the two are also labeled here, and along with the data that backs that up. All right, so a couple of things in progress. They're looking at the baroreceptors in the neck, denervation of the kidneys. They're looking at autonomic nervous system control. They're looking at where to control the bundle of this versus the different areas of pacemaker to control the heart rate and the ejection fraction. So all more to come. We don't have really good data on any of that stuff. All right, I'm going to kind of skip here. There are a couple of things I think we can look at in terms of how to keep people out of the ER. Basically, goal-directed medical therapy, reassessing them frequently, doing labs regularly when you make medication changes, and then optimizing their other conditions, COPD, diabetes, obesity, etc. And then last but not least, if you need help, there's a nice acronym that you guys all know, the cardiologists love acronyms. So I know you can't see it on this slide, but it spells out, I need help. And each of those stands for something. So if they need IV inotropes, if they need cardiac synchronization therapy, if their diuretics are, if they're not diuresis effectively, if they're having edema and heart failure risk. So all those conditions are kind of spelling out what I need help stands for. Okay? And then when to refer to the hospital, they're not controlled despite everything you do. You try to do everything, but they don't have room in their blood pressure or their heart rate for the drugs you're trying to give them. They have poor reserves. They've also got COVID. They've also got COPD. It's a little old 88-year-old person with almost no reserves, right? That's worse. The kidneys are getting worse. They need dialysis perhaps. So these are the reasons to start thinking about, of course, ACS, acute decompensation. All right, I'm going to stop here. A couple of things as you guys think about this lecture. If you forgot how to classify patients, that's on slide. Looking at the evidence-based guidelines, and then how to look at echo findings to classify patients, that's on slides 51 and 52, and then what medications to avoid is on 68. All right, so what percent of our patients die of heart failure and preserved EF? That's 40 to 50%. Okay. All right, shows some improvement, huh? And then this patient that was on multiple medications, what should we do? Well, his potassium's high, so we can't add the first two agents, right? We can't add the furosemide because his creatinine is uncontrolled. He's African American, potassium's high, creatinine's high, blood pressure not controlled. He's already on every other gold recommended therapy. At this point, we would add the last choice, which was the hydralazine with isosarline. And then last but not least, which of these findings are suggestive of pre-heart failure? Remember, pre-heart failure means they have no symptoms. So all the ones with symptoms and clinical findings are gone. So the right answer is elevated filling pressures. Right? All right, I think I went over quite a bit, so I'm going to stop here. And if you have any questions, I'll take them outside the room while Dr. George sets up.
All right, if you guys need like a 2-minute break, we'll try to reconvene pretty quickly. So if you need to step out and get coffee or have a restroom break, it's fine. And by the way, I do want to make sure that everybody is familiar with how to log on to Thinkific, because again, a lot of the material is there. The one-pagers, the spaced repetition will be there, the videos will be there. So if you guys are not familiar with it, you can access it through cmetravelacademy.com. There's a login. We also have sent you a link that you should be able to use to log in as well. But there is if you go to our website, cmetravelacademy.com, on the far right of the menu, I think there's it says actually log in, and you can click there and sign in. Videos won't hear us. Videos are going to be
And again, if you guys do have questions, please write them down. We'll look at those as well. Or you can ask me outside. But we do have a session called Rapid Review on day 2, where we kind of go over all the questions that you guys had, as well as some key points. So tomorrow and today, if you have questions, please write them down, and we'll take them with us. That way we address all the questions that any of you have. Because of course, if any one of you had it, maybe other people had the same question as well. We're working on the slides, guys. I know the projection's not changing the color schemes in between to see which one projects better. Like I did all of mine in black to see if that projected better. And Dr. George switched his to white this one. So I don't know, it's a challenge, but hopefully you can see all the slides on the other option also, by the way, is we are live streaming on YouTube as well. So if you click on the YouTube link, we're broadcasting it directly from our computer. So you can see the slides on there as well.
Yeah, the slides come out very clear on the YouTube link. So
we usually get a TV screen, and this is one of the first time we got a projector. Now we know for next time not to use projector screens. So hopefully that helps.
anybody going to the sphere? Any shows? Anything good going on in Vegas? Anybody seen Wizard of Oz?
He just wants to know.
Circus of Day, yeah.
We're going to see Sebastian Maniscalco tonight.
Oh, I wonder. The Sphere's it's crazy, but a long time.
How do you email? Oh, how do you get that to?
Well, I'm already, how do we?
Oh, we send it twice. We actually send out a text at the start of the day, and tell you where to text. If you want to, you can actually see that online too. If you go to our website.
You guys get the emails, y'all, most of you guys got the emails from Sunday or yesterday?
Yeah.
Not seeing them.
So we pre-registered you all, so you should be able to go to the login screen and then just say, it'll just have to walk you through it.
Okay, guys, I think we'll go ahead and get started. I know people are still checking in, but I'm trying to stay somewhat close to time. So this, our next topic is on asthma, patient evaluation management, and a lot of new content in this one. So excited to share some of this with you. I'll let you look over the learning objectives just real quick while we're waiting. So just a few points of fact that, asthma worldwide, over 260 million cases. In the United States, 25 million people have asthma, and 7 million children. A lot of preventable deaths, 400,000 globally. And in the United States, about 3,500 to 4,000. And what we know is that most of these are preventable. The vast majority of these we could do something about, actually prevent that from happening. Economic impact over 80 billion per year. Pathophysiology of asthma, so this involves chronic inflammation. And that's a key point to keep in mind, because this changes how we're managing asthma going forward. And we'll talk a lot about that, but it involves T cells and mast cells, and so a lot of inflammation that's involved. And if you're not managing the inflammation, you're not actively managing asthma. The second component of asthma is bronchial constriction, so the airways are hyper-responsive and they're narrow as a result, and because of smooth muscle contraction. And then, over time, when you leave this untreated, what can happen is you get airway remodeling. Basically, what happens is if you imagine a flexible rubber tubing, that's your bronchial tubes. But over time, if it's unmanaged because of chronic inflammation, that adds layers and layers on that on those bronchial tubes to where it becomes stiff. And now, when you try to treat it with responsive. So obviously that's one of the things that we want to prevent. Now, if you look at guidelines for asthma, the National Asthma Education Project that puts out guidelines. That's U.S.-centered guidelines. The latest one that they have come out with is in 2020. Prior to that, the latest update was from 2007. So it's not very frequent that they update the guidelines. But fortunately, the GINA guidelines, the Global Initiative for Asthma guidelines, are put out every year and updated yearly, the last one being from last May. And so we'll look at a little bit of the differences, but we'll largely focus on the GINA guidelines because there's a lot of new information that's come out in terms of asthma management. Asthma can be looked at in terms of phenotypes. So you can classify it as allergic asthma, where they're triggered by certain environmental allergens, or non-allergic. So in this case, your asthma is provoked by certain irritants, perhaps smoking, pollution, fumes. It can be any number of things. There's late onset asthma, where they don't have any kind of symptoms, they don't have any diagnosis of asthma until they're an adult. Cough variant asthma, no other symptoms other than a cough. Asthma with obesity, so their airways have an extra weight on them because they're obese, and so that leads to a state of lower levels of eosinophilic inflammation. Well, they'll respond to certain medications. So all these phenotypes are important because, again, it'll predict which medications are beneficial, which we'll see down the line here. And then asthma with persistent airflow limitation, this is what we're talking about we want to avoid. That's the airway remodeling where you're not fully able to reverse the degree of constriction of the bronchioles as a result of chronic airway inflammation. So in terms of diagnosing asthma, there's two components of it. One is the subjective component, and the other is the objective component. You have to have both. Subjective component means that you're going to have either chest tightness, shortness of breath, wheezing, or cough. And that's going to be varying over time. Sometimes it's better, sometimes it's worse, or sometimes it's there, and sometimes it's not there. And then it's also something that can be triggered, typically by exercise or sometimes cold exposure, allergens, and so there's various triggers involved. And then that alone, the subjective criteria alone, is not adequate to diagnose asthma. You have to also then have this objective, meet the objective criteria, which is one of several options. The preferred option is spirometry. So if on spirometry their FEV1 drops, if their FEV1 improves by 12% and 200 mLs of a bronchodilator, that meets the criteria for diagnosing asthma. Again, you have to have subjective symptoms too. Alternatively, a lot of us don't have a spirometry readily available. You could still diagnose it on the basis of the peak flow reading. So the peak flow reading in this case has to increase over 20% after bronchodilator use. Another option, a third option, is a bronchial challenge. This is it's called a methylcholine challenge, where you give them increasing doses of methylcholine and see if their FEV1 drops by 20% or greater. And if it does, that meets the criteria for diagnosis of asthma. You can also base it on their response to therapy. So maybe their spirometry is completely normal. That doesn't rule out asthma. You could then check 4 weeks later after you've started them on therapy, and if their FEV1 has improved by 12% and 200 mLs, then you could, that also meets the criteria for asthma. And then there's something called the fractional excretion of nitric oxide, which is basically, you can measure nitric oxide in the air that we exhale. And if that reaches, over 40 parts per billion, that is an indication of eosinophilic inflammation, and therefore meets the criteria for asthma. The important thing is that asthma symptoms can vary over time, so just because you have a normal test doesn't rule out asthma, and you do want to their symptoms so that you can potentially retest them at certain intervals. So the first step, once you've established the diagnosis, is to classify them as in terms of their degree of control. So if you look at the one-page handout for this, you can see that there's a table that classifies patients based on the degree of control. And so you can kind of follow along here. But basically, they're either classified as well-controlled, partly controlled, or uncontrolled. And your goal is to get everybody to well-controlled. Okay, so well-controlled would mean that they're having symptoms less than 2 times a week if it's daytime symptoms, or less than 2 times a month if it's nighttime symptoms. They're using their rescue inhaler less than 2 times, less than or equal to, that is, 2 times per week. They have no activity limitation. Their FEV1 is greater than 80%, and they have had no exacerbations in that 1-year time frame. If they are well controlled, you're going to start with what's called step 1 and 2 therapy, which is also going to be on your one-pager, which we'll go over what these steps mean. But let's say they're not, they're using their rescue inhaler more than 2 times per week, if it's daytime, or 2 times per month, if it's nighttime symptoms, or their FEV1 is 60 to 80% predicted, or even if they have had just a single exacerbation in a 1-year time frame. That puts them as partly controlled. And partly controlled means that we're going to start with step 3 therapy for them. And then anybody who's uncontrolled has any more symptoms. So either daily symptoms, maybe they have it oftentimes nightly or multiple times a week at night. They're using their rescue inhaler daily. They have significant 1 is less than 60%, those are uncontrolled. You're going to start with step 4 therapy for those individuals. Now, the other thing to classify with regards to asthma is their level of severity. Now, their level of severity is something you look back and classify. Okay, so their level of control, you're going to assess their control based on everything that the patient has told you to date, based on their history. You're going to classify them as well controlled, partially controlled, or uncontrolled. But their level of severity is something that you look back on and you say, okay, what step did I have to get to in order to get them to well controlled? And based on that, they could be either mild, if it's just at step 1 and 2, moderate, if it required step 3 treatment, or severe, if it required going to step 4 or 5 treatment. The point that we really want to get across is that a lot of asthma-related mortality is preventable. There's a study that have shown that, basically, this is a UK study. This was done in 2014, so it's a little bit outdated, but the data hasn't changed a whole lot. But what they found was that 60% of asthma-related deaths were completely preventable with appropriate treatments. So again, huge opportunity that we can really improve the quality and outcomes. Now, I'm going to overview the step 1 through 5 treatment, and then we're going to go over each of these in a little bit more detail. But basically, what we're going to do is, in step 1, you're going to use what's called as-needed low-dose ICS formoterol for mild asthma. Okay, so this is a big change from what you may have been familiar with to date, because I think everybody is familiar with using a short-acting beta agonist as needed. Well, GINA guidelines as of 2024, but certainly even in the 2025 guidelines, really emphasize moving away from that and using ICS formoterol, which, if you're familiar with it in terms of brand names, Symbicort. That's the one that's available for use right now for as-needed use. Okay, so that's kind of an interesting thing. And then step 2 to 4, basically you're going to start with a low-dose maintenance or inhaled corticosteroid with long-acting beta agonist, and then you're going to step up the dose in each of those steps. And then step 5, you're going to need to add some sort of biologic. Okay, so at that point you would be in a high-dose ICS long-acting beta agonist, and you're adding in a biologic. So, as I mentioned, there's no treating asthma without treating the inflammation. So, we're going to talk about the different classes of medications here, starting with the inhaled corticosteroids. These really are the cornerstone of managing inflammation. And so, for better outcomes, what we're finding is that this is an essential element of treating asthma inflammation to prevent airway remodeling. And then again, we're going to adjust the dosage based on severity. Low dose for to start with, and medium, and then a high dose. Make sure, of course, that they are educated on their inhaler technique, and also that they're rinsing out their mouth after each time, because otherwise they can get fungus to build up in their mouth. So obviously, we don't want that. The long-acting beta agonist and the long-acting muscarinic antagonists are used for bronchodilation, and they have a role in terms of asthma, but not independent, not by themselves. They should be used with inhaled corticosteroids. If they're used alone, particularly the long-acting beta agonists used alone, have been shown to increase mortality, mainly because you start providing them with long-acting beta agonists, and that leads to lower beta receptors in their bronchial airways, and so now when you try to treat them with a short-acting beta agonist for rescue, they're not responsive because they just don't have those beta receptors there anymore. So again, we definitely avoid using the LAMAs and the LABAs by themselves, but they can be a helpful tool in conjunction. The leukotriene modifiers, these are montelukast, zafirlukast. They can have helpful, particularly for asthma in patients who have allergic asthma. So in those individuals, starting them on montelukast or zafirlukast potentially can prevent them from needing further treatment. These do come with a black box warning for potential neuropsychiatric effects. Be cautious about using them, educate your patients, make sure that they're on the lookout for any mood changes, certainly suicidal thoughts, anything like that. You need to stop the medicine. And then biologics are kind of the new treatment in terms of asthma, and these are shown to be highly effective. There's several of them, and they're also listed on that one-page point-of-care reference on the back. You'll see it. And you know, these have been shown to be quite impactful. It really has changed the management of asthma. There's a lot of patients who in the past get to high-dose inhaled corticosteroids. Maybe put them on oral corticosteroids, but they still wouldn't respond and really didn't have a whole lot to do. That's changed in the last 5 to 10 years. Now with these biologics, they're incredibly effective. There are different ones, and they're used for different phenotypes of asthma. Some used for allergic phenotype. At Transpire, which is shown to be effective in allergic and non-allergic asthma, which is, really encouraging to see that there's some potential effects, helpful medications out there for those even without the allergic type of asthma. In this case, the study, the pathway trial looked at asthma exacerbations, and it's shown that using biologics reduced the percentage of reduced exacerbations by 71%. And so a pretty dramatic effect. I had an aunt who was maybe about 2019 or so, used to be, she had really severe asthma, unfortunately, and she ended up in the hospital, and after months, she was in the hospital over and over. And it went on like 5-6 months, and again, this was about 2019. This is when some of these biologics just made it into the guidelines. They started her on one of the biologics at the time, and from that point to now, she's not been in the hospital at all. So, again, it was a huge impact and something that really has changed the care of asthma. Okay, so mild asthma. Now we're going to talk about each of the steps in a little bit more detail. And again, if you can, you could reference that one-page handout. You'll see that in this step graphic here. You can follow along, it makes it a little bit easier. So in mild asthma, you're going to use ICS formoterol for symptom relief. Okay? As we talked about, we'll show you some of the data for that, but that's actually now the preferred treatment for intermittent use for asthma flare-ups. And now the dosage is, so again, it's budesonide formoterol. So the interesting thing about this formoterol is that it has short-acting and long-acting beta-agonist activity. And so it effectively acts not just as a long-acting beta-agonist, but also as rescue, because it has that short-acting property. And the dosage is the higher dose of Synthor, so 160 × 4.5. Up to 12 times a day if you needed to, 12 puffs a day in a single day. That would be the max dose. Say again?
Formoterol is LABA, right?
Yes, formoterol is both the long and short acting, but it is classified as LABA, but it does have short acting properties as well.
Use some labels with ICS.
Say again?
Use labeling with ICS, it's actually the best method would be with ICS.
ICS is the
Yeah,
budesonide, and then the formoterol
is the LABA.
is the LABA.
You see this ICS formoterol together.
Okay.
Yeah.
That's
So in the START trial, what this showed is that the ICS formoterol reduced asthma exacerbations better than short-acting beta-agonist alone. Again, I'm going to show you some of the details here. But in each of these steps, they give a preferred option, which is the track 1 option, and then the less preferred track 2 option, which is, in this case, you could use a PRN inhaled corticosteroid whenever you take a short-acting beta-agonist. So, you take one and then you take the other, right? So that is an option, but of course that's less preferred than making it simple on the patient and just giving one combined ICS formoterol regimen. There are other options. So each of these steps has an alternative option, which has less evidence. In this case, you could use low-dose ICS whenever a short-acting beta agonist is taken. You could take leukotriene receptor antagonist, particularly if they're allergic asthma. And then house dust mite allergen sublingual immunotherapy for those who may have dust mite allergies. It can be effective. Okay, so again, we kept talking about, why not the short-acting beta agonist? And now I want you to see some of the reasons for that. One is that short-acting beta agonists treat the symptoms, but they don't treat the underlying inflammation. And as I mentioned at the start, there's no treating asthma without adequately treating inflammation. And so if you're not treating the inflammation, you're just, you do temporarily make them feel better, but you're putting them at higher risk. And so one of the things that they found is that about 27% of asthma-related deaths occur in mild asthmatics. And you can't predict this. You don't know which of these mild asthmatics are going to have an asthma-related death. And so what they find is that if you use ICS formoterol instead of a short-acting beta agonist, you have reduced risk of a fatal exacerbation. And then the other reason to use ICS formoterol is that it prevents you from getting to the point of requiring oral corticosteroids. So by controlling inflammation, you prevent that exacerbation from getting worse, and as a result, you're and oral corticosteroids have been shown, even with just 4 to 5 doses, to be associated with increasing risk over time of pneumonia, heart failure, cataracts, diabetes. And so, this is important that we try to minimize the use of oral corticosteroids by appropriately treating the inflammation in the early part of the stage of asthma. Step 2 therapy in mild, this is mild asthma. You would start with, as needed, only ICS formoterol. Same as step 1, that's the same preferred treatment. Track 2, though, is a little bit different. You could use a low-dose ICS alone for maintenance. And again, you could use the inhaled corticosteroid alone. You wouldn't use any long-acting beta agonist or LAMA alone. So that's just something that you want to keep in mind. Other options, again, low-dose ICS whenever SABA is taken, leukotriene receptor antagonist, house dust mite allergen, sublingual immunotherapy for certain patients. And again, in terms of rescue, it's the ICS formoterol that's preferred, although you could use ICS with a short-acting beta agonist. We don't have that formulation in the United States. Or you could use, if you don't have anything else, you could still use albuterol as needed. One thing to recognize is that this is what the guidelines say, okay? But this is not necessarily what insurance will cover, okay? And so sometimes you will get into a situation where you're wanting to get the patient on ICS formoterol, but that it may be cost prohibitive. In which case, use the short-acting beta agonist. If that's all you have, that's still better than nothing. Here's a case study. So 35-year-old male with moderate asthma, well controlled with ICS long-acting beta agonist, but with frequent symptoms during allergy season. So this, there triggers, hopefully you're thinking back to the leukotriene inhibitors, which are particularly effective for the patients who have allergy-related asthma, that they tend to have exacerbations during allergy season. So here's an option for montelukast as an add-on therapy, and that would be appropriate. Step 3 treatment, again, your preferred treatment is going to be, this is a low-dose ICS formoterol maintenance treatment, okay? So this is what's called, again, this is just for maintenance. So you're going to be on a low-dose ICS formoterol every day for maintenance. Track 2, low-dose ICS long-acting beta agonist, which, again, there's some clarification. Long-acting beta agonist other than formoterol, but the preferred one is ICS formoterol, okay? And then other options, as we mentioned before, again, a medium-dose ICS. You can add on the leukotriene receptor antagonist. You can add on HDM sublingual immunotherapy. And then as needed, you could use ICS formoterol rescue treatment. Okay, so this is really different, right? This is what's called smart therapy. SMART therapy stands for single, maintenance, and rescue therapy. So here what we're doing is we're going to give them one single inhaler, and that would be ICS formoterol, ideally. And they're going to use that for maintenance twice a day, as we usually do for like single port. And then they can also use that same inhaler as rescue. And so that cuts down on the confusion. I'm sure if your patients are like mine, a lot of times they'll use their maintenance inhaler for rescue or vice versa. And so this really kind of cuts down on that kind of confusion, but also improves outcomes, regardless of, even if they weren't confused, they would be better off with this medication regimen. Step 4, you're going to be on a medium dose inhaled corticosteroid. You're going to skip through the less preferred tracks. Still, ICS formoterol as needed would be preferred, but if you can't use that, you can use a PRN short-acting beta. Going to add on everything we got. So preferred treatment would be add on a long-acting muscarinic antagonist. They should be on a high-dose ICS formoterol, and then you're going to consider adding on biologics. Biologics, I've got them listed on the one-page point-of-care reference, but you see those, you see those listed there: Fasenra, Dupixent, Tezspire. You may have heard the commercials. But those are highly effective in the right individuals. Some of them are particularly effective for certain phenotypes of asthma. Others are more effective in other phenotypes. But remember, Tezspire has an indication for both allergic and non-allergic asthma. And then there are some other options as well. So adding on azithromycin, which has some anti-inflammatory properties at low doses, can be effective. Adding on leukotriene receptor antagonists we talked about. Adding on low-dose oral corticosteroids. So this would be a 7.5 milligram prednisone daily. That can be effective, obviously not preferred. If we could get them off of that, being on a biologic or being on, or never getting to that point by controlling the inflammation in the early part of asthma stages, that would obviously be much more preferable. Okay, but there's more involved in terms of managing asthma. So here's a case study: 48-year-old female, severe eosinophilic asthma, and dependency on oral corticosteroids. So if they're having frequent exacerbations, they're already, probably uncontrolled, in which case you're going to be on step 4 or 5 treatment. Here, they initiated benralizumab, which is one of these interleukin-5 biologic, and they found that steroid use was significantly reduced within a 6-month period. Again, very similar story to what I mentioned with my aunt. She was put on the biologic, and sure enough, within a period of 3 to 6 months, no more exacerbations, right? So highly effective. In this case, there's a study that showed that benralizumab reduced oral corticosteroid use by 75%, which is huge. There are other components to control other than managing just the medications. They're going to minimize exposure to infections, obviously get them up to date with their vaccinations so that they're less likely to get those infections. Obviously control for allergens that they may be exposed to. So perhaps there's pets, perhaps there's dust mites, you use those dust mite covers. You want to address medication non-adherence. So a lot of these patients may actually be adherent to medications, but they're not going to take their inhaler properly. So you want to make sure you get good inhaler technique. And then for ongoing management, monitoring, you want to monitor them both with subjective measures as well as objective measures. There is the asthma control test and the asthma control questionnaire, which you could use to assess their symptoms and kind of objectify how they're feeling, their subjective symptoms. And then there's the spirometry, which is recommended at the point of diagnosis, and then usually 3 to 6 months after you start treatment, and then on a yearly basis thereafter, or anytime you change treatment. And particularly if you want to step down on treatment, you also want to check their spirometry after that. Once they're well controlled, again, we're trying to get everybody well controlled, for a period of at least 3 months, then you could try to step down on treatment. And that is the recommendation, is to try to step down to a lower dose. If they're on a high dose, corticosteroid with formoterol, maybe you go down to a medium dose. So you take down one step and reassess their control, and if they're well controlled, again, you can keep going further every 3 months. We mentioned inhaler technique. Again, just making sure that they're using, they shake their inhaler. This is their ICS formoterol or their short-acting beta agonist. They exhale, press down, and inhale at the same time, hold, and then exhale. And that's how you want to do it. Now, a lot of people do that, and half the medicine ends up in the back of the throat, which doesn't do any good. It needs to get up into the airways, so a spacer can be helpful in that context. And with a spacer, even babies can use that. You can't go wrong. You just have to use the appropriate mask or the mouthpiece, and that medication will make it into the airways. And we mentioned addressing the non-pharmacological interventions, smoke, pollution, dust, but also lifestyle interventions. Weight management. As I mentioned, weight is a risk factor for asthma, particularly the phenotype associated with obesity that's not inflammation related. And then we talked about some of the environmental factors that we want to make sure we control for. There's also certain comorbidities that we want to manage, because by managing, for example, gastrointestinal reflux, you can better manage asthma. So what happens is you get microaspirations, and that microaspiration triggers basal, the basal nerve to cause hyper responsiveness in the airways. And so managing the reflux, you can prevent asthma from getting worse. Likewise, with obstructive sleep apnea, you're getting hypoxic episodes throughout the nighttime. If that happens on a recurrent basis, you get inflammation from that. So managing the obstructive sleep apnea is an important part of it. Again, managing allergic rhinitis we talked about as well. Sublingual immunotherapy can be effective for patients who have allergic asthma. And we mentioned sublingual immunotherapy in particular for, so sublingual immunotherapy is particularly helpful for house dust mite allergens. But subcutaneous immunotherapy can be helpful for patients who have other types of allergic asthma, although it has a little bit less benefit in patients with house dust mite allergens. Obviously, quit smoking. That's the best way to prevent that irritant from causing inflammation and worsening of asthma. And obviously, those who have airway inflammation as a result of smoking have higher levels of inflammation, require higher levels of corticosteroid use, so preventing that is definitely smart. What all vaccines do we recommend? Okay, so obviously flu vaccine, any of those respiratory vaccines. So flu vaccine, COVID vaccine, and pneumococcal vaccine, and an RSV vaccine is also recommended now for 60 and over in patients who have asthma. Associated asthma, bronchoconstriction, they're using the short-acting beta agonist almost every day, then you should be on a maintenance inhaler, because again, they're having symptoms more than twice a week. Doesn't matter if it's because of exercise, they should be on a maintenance inhaler. In this case, ICS formoterol would be ideal. Again, smart therapy is what you want to ideally be looking for. In the elderly, there are some additional challenges, trying to minimize corticosteroid use. Also is important because, again, risk of osteoporosis and cataracts. You want to make sure that they have good techniques that they're capable of using their inhaler appropriately, sometimes because of back arthritis, rheumatoid arthritis, osteoarthritis. Sometimes it can be a challenge. And so that's something that you want to make sure you're addressing as well. And then we'll talk about the management of the asthma exacerbation, which is also on the back page here. Here, if it's severe, generally you're going to send them to the emergency room. Certainly if it's life-threatening, or they're confused and untended, or they're drowsy, then you're not hearing good air movement, you're going to send them to the emergency room. If it's severe, you could try, let's say their saturation is just under 90% and their pulse is elevated, respiratory rate is elevated, you could try some short-acting beta agonists and ICS formoterol and see if you can get their oxygen up, and if you can't, you can within a short period of time, you want to go ahead and send them to the ER. But for mild to moderate asthma, these are patients who have a peak expiratory flow rate greater than 50% of predicted, and their oxygen is 90 to 95%. You can treat them with rescue inhalers, and then at the same time, you will go ahead and start them on an oral corticosteroid. Here, we're using preferred oral corticosteroid for the GINA guidelines is prednisolone, which is the active form of prednisone, 40 to 50 milligrams, and then you're going to watch their oxygen levels, and then you're going to reevaluate and see if their peak expiratory flow rate is improving. If it's over 60 to 80%, you can potentially discharge them back home, meaning from your clinic, and hopefully you get the oxygen a little bit higher. And then in terms of follow-up, you want to reevaluate once you see them back in clinic, typically in about 3 or 4 days. You're going to send them home with a 5 to 7 day course of prednisolone. But when you follow up, you're going to see, are their symptoms actually improving? Are they relying less on their rescue inhalers? Are they feeling better? Then you're going to continue the same plan. But if not, then you might need to extend the course of that oral corticosteroid beyond the 5 to 7 day time frame. And of course, manage any of those associated triggers. Maybe they have pets in the house, maybe they have allergens that they are exposed to. So, do think about those things when you're deciding on the appropriate management in the outpatient setting. If you have even just a single exacerbation in a 1 year time frame where they require oral corticosteroids, then again, they're not well controlled. If they have 2 or more exacerbations, that's considered poor control. So at that point, they need to be on at least step 4 treatment. When they have an exacerbation, you do want to get them started on smart therapy. So they should be not only if they're just taking a rescue inhaler as needed, you need to start them on rescue plus maintenance. So ideally, smart therapy, and then you also will add the oral corticosteroid, and eventually, once they've been well controlled for 3 to 6 months, you can step down, as we mentioned earlier. Asthma action plan, this is ideally done with measuring the peak expiratory flow rate using a peak flow meter. You're going to use that and measure their peak expiratory flow over a week period. This is not when they just come out of the hospital. Okay, this is something when they're feeling back to normal, and then that's when you get your baseline peak expiratory flow rate. Now, sometimes we just don't have that data. Patients don't comply. They don't follow up and actually do what we're asking them to do. You can go and find their predicted peak expiratory flow rate, and that's easy to calculate. You can pull it up on MD-Calc or online risk calculator. You can find the predicted peak expiratory flow rate, and based on that, you could develop an action plan. So asthma action plan. So basically here in the asthma action plan, if they're in the green zone, you just continue what they're doing. Well, maintain, continue the maintenance therapy. If they're in the yellow zone, your peak expiratory flow is between 50 to 79% of either predicted or of their best. And at that point, you're going to increase their reliever use, their rescue reliever. And if they're in the red zone, they're going to have to add in oral corticosteroid. And obviously seek care in terms of seeing you or going to urgent care or potentially ER. Okay. So just quick highlights. Asthma, to be able to diagnose asthma requires both the subjective symptoms as well as objective findings. History, again, subjective findings include cough, chest tightness, shortness of breath, wheezing. They too vary over time. And then you have to have objective findings. That's usually based on spirometry, FEV1 improvement of 12% from baseline and 200 mLs after the use of a bronchodilator. Early intervention is critical. That's kind of the underlying message here. Start that ICS therapy early, prevent exacerbations, and prevent airway remodeling. And then, as I mentioned, a lot of asthma deaths, over 60%, according to this study from the UK, was entirely preventable. Now we know we have the tools to be able to prevent that. We just, need to adhere to those guidelines and understand that treating asthma requires treating that inflammation. So use that ICS for albuterol whenever possible, if you have ability to prescribe that as opposed to just the short-acting beta-agonists. Remember, montelukast does carry a black box warning due to neuropsychiatric side effects. There are several biologics out there. They help control inflammation in severe asthmatics. Use spirometry not just to diagnose asthma, but also to be able to follow them and decide on potentially stepping down from the treatment regimen that they're on. Make sure you educate patients on good inhaler technique and comorbidities, along with just managing asthma. So also managing their allergies, their reflux, their obstructive sleep apnea, and their obesity. Thank you.
All right, guys, let's take a 5-minute break, and then we'll start at 10:30. I know we're running a little behind in the schedule, but if we start at 10:30, we'll stay on schedule for the lunch break. If you need to take a little extra time, that's fine. Just come back in. We'll start at 10:30, though.
And if anybody happens to have any questions, I'm right around here, so feel free if you.
Yeah, the dimming of the light doesn't help, but you want to be able to see the projector a little bit better. We have a great view, which we've had to cover up. But if you take a look at the window, it's a pretty good view out there. Maybe I'll open it up a little bit. So
That's right, it's a natural light.
yeah.
Then you'd never see the screen.
Yeah. That's the drawback.
They love people in the pool.
For them.
I'll be your space one. Yeah, it's fun. I didn't realize all that stuff was there. Just do a couple of minutes.
Okay.
That's the other engagement. Everybody sign up. Sorry. But there's one person
Okay. So it's here. First. come here. Always get the question. Yeah, it is, you're right, because, you know, there's going to be things that I say ICS, well, there will be that, but it is,
Well, those schools are ICS portals.
Yeah.
ICS work.
oh,
So I see what you're saying.
yeah, I should clarify that. Yeah, sometimes it's easy to clear in your mind, and you don't think about it.
One of those is ICS.
Yeah. Okay, guys, I think, you know, we're gonna slowly go ahead and start so that we can somewhat stay on time. I'll just go ahead and display the learning objectives so that y'all can kind of start to look at that while we're waiting for everyone to slowly come back in. And I'll give you a couple minutes to look through it. Yeah, this is really.
My wife said, hey, this looks pretty good.
Really good 12 hours.
Okay, so, yeah, I think they were actually just so,
This is
9 months.
You guys, we're going to go ahead and start, and I know y'all are sort of looking at the learning objectives, but if you want to just take a minute to look at that. I'm going to go ahead, and there's a lot of information in this one, but I want to try to get y'all in time for lunch, so I'm going to go ahead and start moving forward, okay? So we're talking about CKD, chronic kidney disease, so it affects 37 million Americans. It affects 15% of the US population. In terms of global disease burden, it's the 16th leading cause of death. We'll talk about a lot of these risk factors in detail in the next coming slides. More common in African Americans, Native Americans, Hispanics. The pathophysiology involves the progressive loss of the nephron unit, so basically your filtration unit of the kidneys are being reduced over time. That leads to chronic kidney disease. Diabetes accounts for 40 to 45% of cases of chronic kidney disease. That's because of hyperfiltration in the glomerula, and that leads to increased damage to the glomerula and therefore chronic kidney disease unit. In another 15 to 20% is because of hypertension. Hypertension results in nephrosclerosis, which you could think of as a hardening of kidneys or a scarring of kidneys. And then there's anything that obstructs the urinary tract can cause chronic kidney disease, so any kind of tumor, cyst, even a prostate, anything that's causing obstruction on the way down can lead to chronic kidney disease. There's also polycystic kidney disease and vesicular uterine reflux and recurrent urinary infections. But the most common are those top three: diabetes, hypertension, another 20 to 25%, and 10 to 15% of glomerular nephritis. So to make the diagnosis, you have to have a condition for at least 3 months. And one of two things. Either you have to have signs of kidney damage based on urine specimen or some sort of structural imaging finding that you see, or some sort of finding based on a biopsy. Or you should have an estimated GFR less than 60 mLs per minute. And again, that has to be for at least a 3-month time frame. Now, we're really kind of talking about chronic kidney disease that's not reversible. So potentially, you know, let's say you have a patient who's on a diuretic and they're creating bumps and nobody notices it for 3 months. Well, that technically meets the definition of chronic kidney disease, but it's really not what the intent here in terms of diagnosis. So how do we calculate the GFR? Ideally, we collect a 24-hour urine on everybody, and we would then determine how efficiently the the kidneys are filtering blood. But that's not necessarily easy to do, and therefore it's an alternative is to calculate the estimated GFR. And why do we do that? Well, it helps us to monitor the progression of kidney disease over time. It helps us to guide us on medication management and dosing, appropriately changing the dosing, and it helps us to just assess their kidney function and determining the state of kidney function that they're in. And so, in terms of measuring an estimated GFR, the older equations, the Krakoff-Gault, and then came the MDRD equation, which was about 2010. But now we have the CKD-EPI equation, which came out about 5-10 years ago. And that is what's built into a lot of our EMRs. That's really what we use for the most part. The Krakoff-Gault equations are technically still in use because dosing, the FDA labeling were all based on the Krakoff-Gault equations. So that's technically something that you can use still, particularly with regards to dosing. And in terms of CKD staging, you guys are probably familiar with the staging, stage 1 to 5, stage 1 being over 90, stage 2 over 60, 30 to 59, and that gets divided into 3A and 3B, and then stage 4, 15 to 29, and then CKD stage 5 is less than 15, which is kidney failure. But really what we find is that this is not an adequate form of classification. In addition to classifying GFR, we also need to look at the degree of albuminuria. And so the new KDIGO guidelines convey the idea that we want to classify not just based on glomerular filtration rate, but also albuminuria. And the C here stands for the cause. Cause, glomerular filtration rate, and albuminuria. What you see here is a patient who's just stage 1, but has A3 levels of albuminuria is equally at risk as a person who is stage 3B without albuminuria. And so it's easy to underestimate, the degree of kidney damage that you're dealing with if you're just looking at stages without looking at albuminuria as well. Now, one thing you might notice that, you might have a patient who comes in and maybe they work out a lot, they take a lot of supplements, and bodybuilder type, they may have an elevated creatinine. Likewise, you have a patient who's frail, thin, elderly woman, and they may have a normal creatinine. Perhaps both their creatinines is 1.4. But the frail, elderly 1.4 creatinine is much bigger concern than the person who's got a lot of muscle mass, because we know muscle mass translates to increased creatinine. They also tend to take a lot of protein. That protein is metabolized into creatinine, and then they tend to take a lot of creatine, which is not directly related to creatinine, but it is a breakdown product that also leads to an elevated creatinine. So what we find, and what now the KDIGO guidelines recommend, is looking at cystatin C in some of these patients where you're a little uncertain because of body mass. And so it's less influenced by body mass. This is cystatin C is a protein that's produced by all the nucleated cells in the body, and it's a better measure of kidney function in patients at extremes of body mass. And it's also tied to better outcomes. They can predict better outcomes in terms of morbidity and mortality. So here's straight from the 2024 KDIGO guidelines, which is the latest guideline. That they don't put it out every year. So the latest guideline came out in 2024. They recommend, this is in quotes, this is straight from them. In adults at risk for CKD, we recommend using creatinine-based estimated GFR. If cystatin C is available, the GFR category should be estimated from the combination of creatinine and cystatin C. So that will give you a more accurate measure of kidney function. But what you can do, it's a very simple test. You can order it. You just order it as cystatin C, and you get the result back in terms of cystatin C-based GFR, and you'll get the estimated GFR on that basis. And this is, again, personally, I don't necessarily order in every single patient, but there is anybody who's concerned about their kidney function, or perhaps I'm concerned that maybe the creatinine is falsely high or falsely low. That would be a good scenario where you want to check the cystatin C. In some patients, we want to then do an ultrasound. Ultrasound can be helpful because it can assess the size of the kidneys, and by assessing the size, you can For instance, if it's a smaller sized kidney, that might be a sign of chronic kidney disease over several years, usually due to medical renal disease, such as diabetes or hypertension. If it's a larger sized kidney, maybe that's a sign of obstruction. Maybe there's something in the urinary tract, perhaps it's a prostate, tumor, a cyst, something that can give you a hint as to what's causing your kidney disease. And then you don't necessarily have to order an ultrasound in every single individual, but if they have, let's say they have rapidly declining EFR, that would not be really indicative of what you would typically see with diabetic-related kidney disease. So at that point, you would want to get an ultrasound just to rule out if there's something again, maybe an obstruction or something else, the decline in kidney function. So again, you don't always have to have it, but you're looking for a reason that would explain their kidney function if you don't have a good reason already. Most people, over 90% of kidney disease patients, don't know that they have kidney disease. They don't come in saying, hey, my kidneys feel bad. Actually, they might, but usually they're wrong about that, right? But usually what they'll say is that they feel fine in early stages. Over 90% actually don't have any symptoms. But in later stage CKD, they can have fatigue, they can have nocturia, they can have edema. In late stage CKD, they can have hyperkalemia, they might have fluid overload, uremia, where it's affecting their cognition. So those are all potential complications. In terms of the management goals for CKD, not only do we want to manage to prevent the progression of kidney disease, but we also want to manage the comorbidities, because by managing comorbidities, obviously you're going to prevent the progression of kidney disease as well. And all these patients with CKD are high risk for cardiovascular disease, so to prevent complications, you want to aggressively manage any kind of cardiovascular risk factors. And obviously that would mean blood pressure, getting that blood pressure down, and A1C down. The A1C goal in terms of KDIGO guidelines line up with the ADA goals for most diabetics, which is less than 7%. The blood pressure goals, as I mentioned, talk a little bit different, based on the KDIGO guidelines and the AHA, ACC guidelines, so you can sort of choose to some extent. KDIGO guidelines are a little bit more aggressive. They call for getting that systolic pressure down under 120. But again, the ACC, AHA guidelines, even in chronic kidney disease patients, recommend 130 and 80 or less. Important to manage not just with medications, but lifestyle interventions, particularly low salt. In all stages of CKD, low salt is important because increased salt intake means increased pressure in the glomerular unit, which causes hyperfiltration, which then leads to leakage of protein. And so by reducing protein intake in stages 1 through 5, you can reduce the degree of progression of kidney disease. Likewise, potassium and phosphate restriction is something to consider, and that's usually in later stage CKD. Definitely start monitoring stage 3B, and if it's starting to be elevated, you want to be able to restrict their potassium intake and potentially their phosphate intake. Usually, in terms of phosphate intake, it's those soft drinks that you want to manage and try to get them cut out. If there's those processed foods, less frequently, once they cut all that out, you could then talk about maybe reducing beans and nuts and phosphates as well. But usually, it's the processed foods that you want to talk about. Protein intake can be limited in CKD stage 3 or higher. And now, in this case, you want to be a little bit cautious because if you start restricting protein intake, a lot of them are already fairly restrictive in terms of their diet. So you want to involve a nutritionist usually to be able to enable them to have other options that they can actually eat, because otherwise they're eating the same thing over and over, and now you've gotten into a malnourished state. So use our dietitian friends when it's appropriate. Exercise has also been shown to reduce CKD progression, so that's important. Smoking doesn't help, so obviously quit that. Okay, pharmacological management. Used to be that we didn't have a whole lot of tools here, but now we do. Okay, so we all know about ACE inhibitors and ARBs. That is first line, that is what's recommended, and we want to get to a maximum tolerated dose. And you start those in all those patients who have proteinuria unless there's some contraindication. you don't usually stop it unless their creatinine bumps over 30% or their estimated GFR declines over 30%. They have difficulty to control hyperkalemia or signs of acute kidney injury. But usually, even in advanced chronic kidney disease, they're oftentimes closely monitored, but they can be continued. And as I mentioned, that was a long time. But now we have good evidence that SGLT2 inhibitors can also be used to prevent the progression of kidney disease. Here's a DAPA trial from 2020 showed benefit from using dapagliflozin. There's a trial called the EMPA kidney trial in 2022 that was published that showed similar benefit in using empagliflozin. And these are patients who didn't necessarily have diabetes either. So what you'll see here, the EMPA trial in a little bit more detail, is a randomized controlled trial with 6,600 patients. They were treated with either empagliflozin or placebo, followed them up for 2 years. And what we found is that kidney disease progression and cardiovascular outcomes reduced, not just in diabetics, but also in non-diabetics. And so this is something that's, Dr. Pillay mentioned SGLT2s with regards to heart failure. We'll talk about it with regards to diabetes, of course. Everybody's kind of familiar with using it in diabetics, but here in kidney disease patients, it's something that's been shown to be particularly effective for reducing the progression of kidney disease. And here, the main outcome, they were looking at kidney disease progression and cardiovascular outcomes in terms of cardiovascular deaths. And they found that it was reduced by, about almost 3.8%. And that was highly statistically significant. And the clinical takeaway was that, basically it could be used for preventing kidney disease progression and cardiovascular death, reduces all-cause hospitalizations. It didn't quite reduce all-cause mortality. It was a trend towards significance for all-cause mortality. And it supports the use of CKD, of SGLT2 inhibitors in CKD patients regardless of whether they have diabetes. Okay. Okay, so here's how they work. Okay. Now, if you look at the ACE inhibitors, they work on the efferent side of the glomerular filtration unit, and they cause vasodilation on the efferent side. So when you think about it, that drops the pressure into intraglomerular, right? And so when you start an ACE inhibitor, you'll see a little bit of a dip in their GFR initially in the first 2 to 3 weeks, but over time it actually improves because there's less hyperfiltration. SGLT2s work very similarly on the other side of the spectrum. So on the afferent side, they lead to vasoconstriction, which then, if you imagine, vasoconstricting on the side that's coming into the intraglomerular unit is going to cause a drop in pressures again. And again, that's going to lead to a decline in kidney function in those first 2 to 3 weeks. So don't be surprised when you check their level and you're seeing a worsening. But then over time, because of the decrease in pressure, their outcomes are better and their disease progression is slow. And so once upon a time, that was, okay, so as I mentioned, that's kind of one new tool. There's another new tool, which is these mineralocorticoid receptor antagonists. So these have been shown to be effective for kidney disease progression in patients. If their estimated GFR is over 25, you could use it. And they have normal baseline potassium, because you do want to watch potassium in these patients, especially because a lot of them are already on ACE inhibitors. And the aldosterone antagonists will raise that. The mineralocorticoid receptor antagonists will raise that. So watch that. And if they have albuminuria and they're already on a maximum tolerated RAS inhibitor, then at that point you can add in the mineralocorticoid receptor antagonist. And then there's one more tool, which is in particular for our patients who have diabetes. So in diabetics with CKD who have not achieved their A1C goals, maybe they're already on metformin and SGLT2 inhibitor, well, now you can use an GLP-1 receptor agonist. And that has been shown to improve kidney disease, prevent kidney disease progression. So management goal in diabetics, you want to get their A1C less than 7%. But even if it's less than 7%, you could still add an SGLT2 inhibitor because they have CKD. Okay, and that will prevent the progression of kidney disease. So let's say you have a patient who is on metformin, and their A1C is 6.8. You think, great, we don't need to do anything more. Maybe it's 6.4. You think, okay, super. Add in an SGLT2 inhibitor if they have CKD, because that will prevent the progression of kidney disease. So, and then if you need to, you can then add in a GLP-1 agonist as well. Okay, so here, kind of is a all that we talked about, and the scenario. So let's look at the first scenario. RAS inhibitors recommended, in patients who have diabetes and CKD and albuminuria, or even if they're not diabetic, they have CKD and albuminuria, it's recommended. It may be used if they don't have albuminuria, if they have maybe hypertension, right? Or maybe they have proteinuria instead of albuminuria. Albuminuria being a more specific form of proteinuria. And SGLT2 inhibitors, strongly recommended in diabetics. But it's also recommended even if you don't have diabetes and you have albuminuria with A2 levels of albuminuria, 200 milligrams per gram or more. And it may be considered, this is based on the guidelines, it may be considered even in those patients who don't have diabetes and don't have albuminuria. And it can be used to an estimated GFR less than 20 millimeters per minute in terms of the empagliflozin, which is Jardiance. Canagliflozin, I think, is 30, and I think dapagliflozin is up to 25. So look at that to make sure you're using it appropriately, but down to potentially 20 for empagliflozin. Mineralocorticoid receptor antagonist, here you're using it in diabetics with CKD and albuminuria, and they're already on a RAS inhibitor and an SGLT2 inhibitor. And then those patients, there being two different classes of mineralocorticoid receptor antagonists. Remember, spironolactone and eplerenone on one hand, and then there's now finerenone. It has better data to use finerenone in those group of patients to prevent CKD progression. It's not recommended in patients who are non-diabetic, but you may need to use it if you have resistant hypertension. In that case, it would be the spironolactone, the non-steroidal, the steroidal mineralocorticoid receptor antagonist. It's not routinely used for just plain CKD without albuminuria. Now, GLP-1 receptor agonist, obviously with diabetics, if you need it, especially for the A1C lowering, you could use it. No diabetes, not yet recommended, okay? And that's where I'm going to get to in this next slide, which is an interesting study looking at Ozempic. And this is a group of just 100 individuals. So it's a relatively small study, published in the Nature Medicine just in 2025, so earlier this year. But they found that by adding Ozempic, 2 milligrams, following them out to 28 weeks, decreased albuminuria by 52% from baseline. Compared, and this is in non-diabetics. So this is looking at the change in urine albumin-creatinine ratio in patients who are on semaglutide in non-diabetics. And so what they're finding is that even in non-diabetics, potential benefit hasn't made it into the guidelines. But let's see what the evidence shows. This is a small study, but interesting early data to suggest that probably it may have a broader role. Okay, now we're going to look at all the various complications of anemia, of CKD. And so starting with anemia, so CKD patients, because erythropoietin is produced in the kidneys. If you have chronic kidney disease, you're using less erythropoietin. Some of these patients will develop anemia as a result. If they get to being symptomatic, where their hemoglobin drops significantly, then you may need to put them on erythropoietin stimulating agents. If you're going to use that, you can also put them on iron so that they have the building blocks to be able to produce the hemoglobin molecules if they need to. You're going to aim to keep their hemoglobin between 10 to 11. Don't go above 11 because at that point you're increasing cardiovascular risk, or actually risk of clots and risk of potential stroke. There's a number of other changes associated with CKD, so low vitamin D, because as you remember, vitamin D is activated by the kidneys. And so if you're not, if your kidneys aren't working properly, you're not properly activating vitamin D. And vitamin D is instrumental for absorption of calcium. So if you have low vitamin D, you also may have low calcium. And then you also are, because of ineffectual excretion, you're going to build up levels of, you're going to have hyperphosphatemia. And as a result, all three of these independently increase or stimulate parathyroid hormone. So you're going to have higher levels of parathyroid hormone, which is going to activate osteoclasts. And then what else do you have as a result? Osteoporosis, bone mineral disease, exactly. So we want to prevent that. And again, all these are mentioned on the one-page handout. I think there's place where it shows the various complications associated with CKD, so you can kind of follow along when you get to seeing that. And then, also because of not just poor filtration, which is one reason you get hyperkalemia, but a lot of these patients are also on RAS inhibitors, which will also raise their potassium and potentially these aldosterone antagonists will as well. Okay, so, obviously, if you want to prevent that bone mineral disease, you want to control for those things that are stimulating parathyroid hormones, so phosphate binders, vitamin D analogs, potentially even calcium mimetics, and then you also want to make sure you're managing hyperkalemia appropriately. Again, it's common because they are on ACE inhibitors and potential medications that may increase their potassium. As Dr. Pillay mentioned, sometimes you still want them on the ACE inhibitor. If you can potentially even have them on a potassium binder so that you can make space for that ACE inhibitor, that can be beneficial for those patients. Other impacts, so have sodium imbalance, that could be high or low, because for fluid excretion, you can have hypernatremia, you can have hyponatremia because of course sodium excretion. Acid-base metabolism is affected. You're going to have typically a metabolic acidosis because of poor excretion of hydrogen ions. And some of these patients you need to treat with high sodium bicarb, particularly if their bicarb starts to drop below 18. And then you can have magnesium imbalance because of poor filtration, anemia we talked about, dyslipidemia. As we mentioned, CKD patients are higher risk for cardiovascular disease. One of the reasons is because they tend to, the CKD itself tends to produce higher levels of LDL, lower HDL, and higher levels of triglycerides. A lot of these patients may develop elevated uremia, and then fluid imbalance we talked about, hyperuricemia. This is where uric acid goes up. Uric acid, contrary to what you would see in practice, they don't recommend treating hyperuricemia unless they're having symptoms being gout or stones. But if you don't have that, I know we see commonly that a lot of these individuals are on allopurinol, but you don't need to treat that hyperuricemia just on the basis of uric acid being high, based on the KDIGO guidelines. Again, cardiovascular risk is the main reason for mortality in CKD patients, and so managing them aggressively. We mentioned potential diabetes control and even statins, high-dose statins, for reducing cardiovascular risk is important. In terms of vaccinations, they need all the routine vaccinations, just like everybody else, but also if they have CKD, they should be getting the pneumococcal vaccine no matter what age they are. You may be familiar that now the U.S. Preventive Services Task Force recommends pneumococcal vaccine for 50 and over. But even if this is an individual who's 45 and has CKD, you want to give them a pneumococcal vaccine because they're immune compromised because they're CKD status. Now, in terms of managing acute kidney injury, you got to be a little bit cautious because acute kidney injury can be acute in chronic kidney patients, or it can lead to a worsening of their CKD. And what I mean by that is sometimes early stage hypovolemia you could treat with just fluids and reverse that acute kidney injury and therefore prevent a progression of CKD. But if you leave it untreated, maybe hypovolemia or maybe because they're sick in some way, maybe they have nausea, vomiting, diarrhea. If you leave them untreated for a long enough period, that leads to acute tubular necrosis, and now you have a worsening of their chronic kidney disease. Likewise, hypotension. If you have it just briefly, then that's potentially reversible, but long periods of time, that's going to lead to a worsening of their kidney function. Contrast use. The recommendation here is, it used to be that we tried some other medications, and now really the emphasis on hydration. So hydration before the procedure, potential hydration after the procedure, whole dose nephrotoxic medications, obviously, and then the KDIGO guidelines emphasize not to delay imaging on the basis of having CKD alone. SGLT2 inhibitors don't need to be stopped due to imaging. Routine N-acetylcysteine is no longer recommended. Okay, so that's a little bit of a change from the past where we used to use that to prevent CKD progression, but that really hasn't been shown to be effective. When to refer to the nephrologist? Well, certainly anybody with stage 4 or 5, you do need to make sure that they're seeing a nephrologist. If they have rapidly progressing kidney disease, then you're going to need to refer them. Anybody who's got persistent albuminuria, in spite of being on max doses of the appropriate treatments we talked about, they should be referred. And then anybody who has refractory hypertension or hyperkalemia should be referred. There is a kidneyfailuerisk.com risk calculator. It'll tell you the risk of progression and the percentage of progress based on their risk factors. So plug it into the risk calculator. It'll give you a 5-year risk, 10-year risk, and that can help you help you determine whether it's time to get them into the nephrologist or not, or potentially even higher level care. A lot of our nephrology colleagues use that to determine when it's time to start planning for dialysis. CKD, here, the point is try to involve your patients here in managing their kidney function. So showing them that kidney disease risk calculator can be helpful. Explaining to them that there are really medications that we used to not have that can be effective to prevent kidney disease progressions is another way of engaging your patients. And then make sure you're addressing quality of care quality of life, because a lot of these patients tend to be depressed. And so depression is very common. Making sure you're screening for depression and treating them appropriately if they have it is important as well. In the elderly, there's a lot of special considerations. One, they tend to be on multiple medications already. Make sure that they're renally dosed. Make sure that they're on appropriate medications. A lot of these patients, as Dr. Delay mentioned, is on multiple supplements that don't need to be there. A lot don't have good evidence for. The less of those that you're taking, the better it is in terms of just medication management, less interactions, less potential for affecting the kidney. So important to review that medication. Cautious about aggressive blood pressure management in this patient population, as we mentioned, also is something to consider. Okay, here's a little question. Which of the following is the most appropriate screening test for CKD in a patient with diabetes? Serum creatinine, estimated GFR, and urine albumin creatinine ratio, urine analysis alone, or BUN? This is a little bit of a trick question because all of these are good answers, but anybody?
B.
Which one?
B.
B, yeah, B, estimated GFR and urine albumin creatinine ratio, because that helps you to stage the kidney disease and make those treatment decisions appropriately. Which of the following medications have been shown to slow the progression of CKD in patients with diabetes? I think everybody knows this one. SGLT2s. There's a 60-year-old male with hypertension and CKD stage 3 with an estimated GFR of 45. 45 would be 3A, though right on the border between 3A and 3B. Blood pressure remains a challenge. 150/90. They're already on max dose of ACE inhibitors. So in this case, the point here is to add them on the next line appropriate medications, thiazide diuretics, calcium channel blockers. If they're later stage CKD, as we talked about in our hypertension talk, CKD stage 4, or you're going to switch them from their thiazide diuretic to their, or prefer a loop diuretic over thiazide diuretic. Okay, health economics, CKD is hugely expensive. Why? Because, a lot of these patients end up being on dialysis. Now, again, we didn't have a whole lot we could do once upon a time. We had ACE inhibitors and ARBs, and that was about it. But now we have really, a lot of effective tools that we could use to prevent that. So this will prevent a lot of unnecessary costs, not to mention improve quality of care. Okay, which of the following are common complications of CKD that require regular monitoring? Hyperkalemia, yes or no? Yes, yes. Hypercalcemia, yes or no? No, it actually causes hypocalcemia. Hypokalemia, it can sometimes, but much more hyperkalemia. Hyperparathyroidism, yeah. We talked about that because of low vitamin D, low calcium, high phosphate, and that leads to parathyroid stimulation. Okay, 70-year-old male with stage 4 CKD, estimated GFR is 25, on ACE inhibitor therapy, presenting with serum potassium of 6.2. At that point, you do want to hold that to ACE inhibitor, at least temporarily, with a monopotassium binder. Maybe if you As we mentioned, trying to make food for these inhibitors is important. Dietary potassium restriction is really important in this patient population, and obviously monitoring potassium levels. 68-year-old female with stage 4 CKD and elevated parathyroid hormone levels. So this is an individual where we would potentially start them on a phosphate binder if their phosphate is high. They would be started on vitamin D analog, both the less active form and the more active form of vitamin D, the more active being calcitriol, to manage for preventing secondary hyperparathyroidism and monitor calcium, phosphate, phosphorus, and parathyroid hormone regularly. Okay, so that's our talk, and we'll go over the highlights. I think we're going to be right in time. So CKD is defined by kidney damage or decreased GFR for at least 3 months. The CKD causes most commonly diabetes, that accounts for 40 to 50%, hypertension another 20 to 25%, glomerulonephritis for another 10 to 15% of cases of CKD. Use the CKD EPI equation to estimate your GFR. Use cystatin C to help improve the accuracy of the estimated GFR, especially when used in combination with creatinine. Obtain an ultrasound causes of CKD when the etiology is unclear. Restrict potassium in all stages. Sodium in all stages. Potassium, phosphate, protein in later stage CKD. ACE inhibitors, ARBs, mineral corticoreceptor antagonists, particularly finerenone, SGLT2 inhibitors, and GLP-1 receptor agonists have some degree of evidence for preventing progression of CKD in certain settings. Anemia management involves administering erythropoietin-stimulating agents, putting them on iron, targeting a hemoglobin of between 10 to 11. Commonly associated with CKD, low vitamin D, low calcium, high phosphate, high hyperparathyroidism, and hyperkalemia. ACE inhibitors don't need to be stopped, potentially even in advanced CKD, though you do want to make sure you're monitoring carefully, oftentimes to have help with a nephrologist. Manage elevated parathyroid to prevent bone disease. And that's it. Thank you.
Hey everyone, as you guys take your break, just a couple of quick, I sent everyone an email just now. So one of our last talks for tomorrow is called Rapid Review, where we not only do highlights of the common conditions, but also want your participation and questions that you may have throughout the talks. So I've opened the Slido app. You can just go to the email, click on it, and you can submit your questions throughout the conference. And that way, tomorrow we can make sure we address most of them. Okay. Take a break, and we'll go right back. I'm going to start in 5 minutes with your questions. Right before you go eat. We could, but it's just one day.
Oh, you can't bring that.
Oh.
Yeah.
I wasn't supposed to stop. It's at 10 minutes. I thought it was just hours.
There it is.
Watch that one. I want to make sure it's showing up on the slides. Yeah, please. 40 questions. Yeah, you're really wrong. Oh, it's not this issue. It's not, when I sent you an email. Please, yeah. Is anyone here on the YouTube live stream also? Can you see the slides? Not this one, but the actual projected.
Yeah, before, yeah.
Yeah, I didn't realize on the CKD one was projected. But all the other ones should have been projected. Okay, so you're able to see it, and can you see it advance?
Oh, I'm sorry, I just closed it.
Just, we'll be able to see it. It's okay. Should we advance?
Oh, no.
Yeah, that's one. Yeah, it's just a slightly later. Yeah. YouTube had like I think almost a 10-second delay on what they're seeing. How many of you guys are staying until Sunday? Most of you, okay. Yeah, we were looking to, so initially the talk was going to be 5 hours each day. Friday, Saturday, Sunday, 5 hours. And we were like, well, people probably going to have a good night on Saturday night, so it might be helpful to, so we did, that was one of the things we'd love your feedback on is, we usually do 4 or 5 hours, not 7 hours, or 6.5 hours. But with Vegas, we thought it might be beneficial to give Sunday totally off, to catch flights, or to just recover from Friday and Saturday night.
Agreed.
You guys okay with the longer format?
Yeah.
We'll ask again in the afternoon.
Yeah, that's what I'm saying. So the mornings are longer, afternoons only 2 lectures every time. So once you come back from lunch, we know that the retention is significantly decreased. So speaking of lunch, I'll say it at the end of this talk also, but when you go down the escalators, there's a restaurant called Giada, which has like a lot of food up there. There's also the Celebrity Food Hall, which is a pretty big short walking distance. It's 3 or 4 minutes walking. The Celebrity Food Hall has like a food court style. They have Korean, they have pizza, they have chicken sandwiches, they have some celebrity burgers also. And then you have the forum shops, which are kind of the fancier places. I probably don't think you'll make it with that because it's sort of sit down places. They have Peter Luger's Steakhouse. If you haven't tried that, it's probably worth it. Probably not during lunch because if you're going to pay that much for steak, you might as well get some wine and get some drinks and enjoy it as well right before BC comes tomorrow. If you guys are looking at some of the buffets, the Caesar's buffet is the biggest. Personally, the Wynn buffet is good. It's pretty, like you're looking at pictures and things like that. The Wynn buffet has like a lot more scenery. What else? I think the Michelin star restaurant that was here is no longer here. They suspended all the Michelin star ratings in 2009 or 2019. So they're no longer rated, but I'm sure the quality is good. It was Wingley. It was in the Wynn. It's still in the Wynn.
Oh, it's still.
I think so. Yeah, they stopped the Michelin rating program back in Kentucky. By the way, we're from Texas, from Houston and Austin. We have some good restaurants there too, so come give our economy a boost. We're always trying to steal people from California, New York. Unapologetically.
How do you watch on YouTube?
Oh, the email that I sent you guys, click on the link from there. Find it directly because I'll list it. Yeah, so find the email that I think it's today and today morning. Either one, that was like scroll down. Oh, not yeah. All right, you should be able to access the Slido from the email link I sent you guys. I can check it over, so if you have questions. Yeah. All right, we'll talk about depression. My learning objectives are listed above, so we're going to talk about how to approach depression in terms of history and exam, how to incorporate certain screening tools to aid in the diagnosis, but also in monitoring and tracking patients over time. We'll talk about the medications, of course, themselves, as well as the non-pharmacotherapy, and then I'll talk about the ways you can incorporate counseling and what kind of counseling techniques are supposed to be incorporated in terms of people that you refer to. All right, so is this really a problem? Obviously, we know that a lot of patients suffer depression, or at least some stages of depression, whether it's mild, depressive disorder or major depression. There's a lot of risk factors that go along with that, not only in terms of comorbidities, but also in terms of loss of days work, productivity, but also in terms of compliance with their other chronic health conditions. We know that there's a difference in the sexes in terms of how often depression is, whether it's diagnosed or manifested or actually prevalent. It's hard to distinguish because not a lot of times men hear that information. Also, in a lot of cultures, the word depression is kind of not something that people will volunteer. So they may have symptoms of depression, but they may not say that they actually have depression as a diagnosis. All right, in terms of depression and suicide, a lot of times we can't just ask for things like sadness or crying because it depends on who is being asked. Sometimes the symptoms might be more of the somatic symptoms. They're feeling tired all the time, they don't feel like doing anything, lack of energy, lack of interest in their previous activities, not wanting to do hobbies that they wanted to do, not taking care of their household, right? Whether they're not cleaning or cooking or taking care of the kids, they just don't feel up to it. So it could be some vague symptoms rather than just saying sadness and crying, for example. Of course, we have a greater risk for suicide if you have underlying depression. Oftentimes the completed rates versus depression versus attempted rates are also some things to think about. In terms of comorbidities, we also have anxiety issues. There's things that can go along with it. For example, they may have mood disorders, other behavioral health concerns, but there may be other conditions that are causing or attributed to it, whether it's a new diagnosis of cancer, whether it's now you had an amputation, you lost your independence. Maybe it's your heart failure or pulmonary disease that's gotten so bad that you can't do as much, and now you are no longer self-sufficient, whether it's for transportation or anything else. So there's a lot of reasons that this might be. If someone has lost their special senses, their hearing and vision, or they've lost their economic ability to take care of themselves, so they are isolated, they can't do all the things they wanted to do. In terms of symptoms, again, women will typically have the symptoms of sadness and depression and guilt, whereas men a lot of times will have other symptoms that they'll attribute, not necessarily say that they're having depression. So the CME CAPS acronym is something we want to take a look at. In terms of guidelines, there's more and more guidelines now that are okay with the screening and recommend screening. The challenge becomes if you don't have a way of addressing suicidality and being able to address your suicide risk, then those screening parameters in adults haven't been upgraded in terms of the level of evidence. The pediatric literature does talk about it for teenagers and adolescents. In terms of screening, it's actually part of our adult child exams. The issue, of course, is going to be about what interventions or what possibilities do you have that you can offer those patients and their families. So depression screening tools, there's several different ones. What I'll try to do is I've given you guys a little bit of information about the different screening tools. They're good and they're bad, and also a link directly to them. I've given you a link so you can see what they look like and see if you want to incorporate that into your practice. Some of them are copyrighted, and I've mentioned those to you so that you can do that however you feel is appropriate. But for the ones that are copyrighted, technically you're supposed to ask for permission before you utilize those. The PHQ-2 and PHQ-9 are useful because a lot of EMRs, Athena, Epic, I believe Clinical Works, they all kind of incorporate these in there, so you can actually have it in your note and you can track the rating. So that's one of the usefulness there. And it doesn't take very long. The Beck scale is a little bit more cumbersome. It takes about 21 questions, but typically if you're going to do this kind of stuff, you want to do it during a dedicated visit just for depression. Hamilton Depression Scale is also pretty nice. It actually scores pretty well. It takes about 7 minutes or so for you to do it. It doesn't take that long, but again, in the middle of everything else, it may not be appropriate. The GAD-7 is to look for anxiety, and if you have concomitant anxiety and depression, which a lot of people do, we want to make sure that we're addressing both. And a lot of times patients will say that they have anxiety but not depression, but honestly their anxiety is coming from their depression symptoms actually. So you want to kind of target this, and then of course the MDQ, which is a mood disorder questionnaire. This is to help. There's no absolute test to rule out bipolar disorder, okay? But it's looking for symptoms of mania and hypomania. So incorporating, at least getting one of the screening tools for depression, and then adding the GAD-7 and MDQ, at least on the initial diagnosis or initial starting treatment plan. Now the utility of the PHQ-2 as a screening tool, it's just 2 questions, right? And the question is, how useful are just those 2 questions? There's actually data that says even asking 1 question, are you depressed, can be very helpful, especially patients that come in with a lot of somatic symptoms. They come in complaining of abdominal pain, they feel achy all the time, they feel tired all the time. They just, they're having a lot of aches and pains. It's 4 or 5 different places that they're hurting. Before you just call it fibromyalgia, even if you do call it fibromyalgia, right, these are diagnoses of exclusions. You must exclude other things first. So making sure that they don't have some sort of vitamin deficiency, making sure that they don't have underlying issues that are organic in nature, whether cardiac or pulmonary that's causing their fatigue, thyroid, all these things we want to look for, as well as lupus and those kinds of things. But outside of that, even just ask these 2 questions. Once you have a score of over 4%, or 4 on the PHQ-2, which doesn't take much to get to, you're almost 85% sure that there's something wrong, right? And the PHQ-2 is supposed to be not a diagnostic tool, but a screening tool. So if the PHQ-2 is positive, we have to follow it up with a PHQ-9. But the point I was trying to make is that it's not hard to screen. It doesn't take that long. Your staff can do it. Your patients can get it. A lot of BMI to be part of their check-in process. So once you get that, and when you made the diagnosis, you actually say that they have which condition they have. For major depressive disorder by DSM-5, the key is, of course, all of these symptoms that are listed above for at least a fair amount of time, so at least 2 weeks. It's the presence of the symptoms, the number of symptoms, but most importantly, are they affecting the different realms of your life, right? Are they affecting, if you're an adult, your occupational life, your social life, and your personal life? If you're a schooling child, then your school. So you want to see if are they affecting the different parts of your life, and that's what allows it to be called major depressive disorder. Not just the presence of the symptoms or the duration, but the fact that it's having a significant impact on your life. Now, the difference is persistent depressive disorder, where they have that depressed mood for most of the time for at least 2 years, 2 of those following symptoms. But again, there's no gap, there's no manic symptoms, and more importantly, it's not causing significant impairment in their functioning. Okay. And as with anything else with DSM, it can't be due to another major condition, right? So for history, what do we ask about? We want to ask about medications. Have they ever been on medications? What they tried? How long they tried? Oftentimes patients will say, I took this medicine, it didn't work for me. Well, I didn't like how it made me feel. How long did you try it? I tried it for a day, it made me feel horrible. That's not adequate trial, right? We know. I took the medication, within 20 minutes, I was having all these symptoms. Well, that probably wasn't the medication, because it takes time for that to absorb. Because what happens oftentimes is patients read about it, and they see all sorts of stuff, and that they have all the symptoms. So we do want to tell patients about what to expect, so they don't just Google it, right? And we don't want to tell them, you're going to see XYZ on Google. These things, some of these things are real. Don't just wait 2 months or 3 months and not take the medicine. Let me see if I can adjust something for you, or change the medicine out, see if it's real. Or maybe we can combat it with something else. We want to ask about family history, because sometimes if patients know that their families have had certain conditions and they've been on certain medicines that work for their family member, well, that might be a reasonable thing to try with that person if it's a first-line drug. And we'll talk about what the first-line drug is. In some cases, that may not be appropriate because that patient's situation might be a little bit different, but if it works, let's try it. I do want to make sure we talk about contraception use for our female patients of childbearing age. And one of the reasons for that is because we want people to be as healthy, both physically and mentally, right, before they get pregnant. And we know that during pregnancies, lots of things increase. The depression issues can get worsened, physical abuse, domestic violence can get worse as well, and social situations can be not quite as supportive as you would hope. So for all these reasons, we want to make sure that patients are supported, but then there's other reasons for contraception, because not all the medications are considered category A or B. Most of them are category most of them are category C, some are category B, which means relatively safe. C is probably safe, we don't know, right? And then D and X are things we should not be using. So just be careful about the kind of medications that make sure they're on some sort of effective contraception. Speaking of effective contraception, I did OB for 19 years of my career. 30% of my income was based on withdrawal method, right? The pull-out method. So that would not be what we consider effective contraception. And then condoms that are still in the packets obviously don't work, right? So we want to make sure they're using it every single time for every single encounter. So stimulant use and herb and vitamin use is also something to think about. Herb and supplement use, because it affects the drug efficacy sometimes in terms of some of the medications, it increases their effectiveness, some of them it decreases their effectiveness. So we want to be careful what else are they taking. Some of the medications they take for stimulants or ADHD medicines, you have to be careful because some of these patients are very anxious, and taking stimulants is probably not helping that situation. Specifically also substance abuse, not just in terms of hardcore drugs, but also things that people think are benign, right? It's like marijuana, vaping, these things have significant impact. We'll talk about that more during the COPD talk, but these things can also have to be laced with other products that can be quite damaging. So a lot of marijuana can either be sometimes laced with cocaine, sometimes it's laced with ecstasy, sometimes it's other products, so they can be very stimulating as well. We want to ask about the sticky CAPS, right? So the acronym sticky CAPS stands for sleep issues, interest issues, guilt issues, energy issues, concentration issues, appetite issues, pleasure and psychomotor retardation or psychomotor agitation, and then also so that suicidality. So we're looking for those kinds of things, and that's a nice acronym to remember as you ask your history to see. Let them talk first, right? We don't want to just interrupt. Let them talk, and then you ask the other more pointed questions. We want to ask about their social support. What makes them in their darkest hour that they otherwise wouldn't do? And it can't be just things like, well, I would never hurt my kids, or this would be against my religion, because things like that can change when you're in such a bad situation. We wanted to see what kind of support do they have. Do they have support from their family members and from their social network? Do they talk to these people? Do they use them, or do they just not because they're the ones who take care of everybody else? They don't want to bother burdening themselves onto others. Or everybody's going through a rough time. You know, all these people passed away. We're all going through it. Last thing they want to do is hear me. So definitely, the reason to ask about these questions is because we've talked to patients about encouraging counseling in a professional setting, right? Not just your friend, because maybe there's things you don't want to talk to your friend about or your spouse about. There's value to paying somebody to do this professional advice, because guess what? If you don't like it, you can fire them. You can't always do that with your best friend or your sister or whoever else it is. And there's value in making sure that you have some sort of ongoing relationship with people. What's worked for you, what hasn't worked, and what are the side effects, right? To see if these are true side effects or something that they just felt initially, and see if there's some buy-in you can get about changing the medication or maybe even not to the medication in certain situations. We want to look at stability of the relationship because that's what helps people get out of trouble in the long run. We know that counseling plus therapy plus social support is typically a nice triad to have, otherwise people don't do as well. We do want to ask about admissions, suicidal thoughts, things that have led them into a second realm of issues, right? A higher realm of problems. So we want to get an idea about those kinds of things. We don't just want to ask about, are you planning on killing yourself right now, but are there ideations? Maybe they don't need emergent services, but maybe you need to have a little bit more closer follow-up for that person, especially if they don't sleep well, if they have lack of social support, especially if they've had prior traumatic events. That's not a person that you're going to refer to a regular counselor with a bachelor's degree. Maybe somebody who has a little bit more experience in LPC, who specializes in trauma, traumatic counseling, that they can have an ongoing relationship with. Living conditions is very useful. I mean, I used to help with the home health clinic as well as some of the county clinics, and these situations can be quite hard to manage, especially if patients don't have these resources. Trying to tell them to take medications and going to counsel, they're just trying to see what happens day to day, right? So some sort of infrastructure, getting through county services involved might be helpful, community health services involved, the THC, the community health organizations and FQHCs, that a lot of them have, if you're an FQHC clinic, federally qualified health clinic, they have to have behavioral services offered. So that's something to be, to offer. We have something called MCOT in Houston where they can actually send people out to help and watch how they are doing at home and then maybe get them into the system. So there's services like that in every county. So take a look and see what's available in your county as well. All right. Exercise is huge. I think there's plenty of data that says people that regularly exercise, there's a combination of the exercise and the endorphins released from that alone, plus the fact that if they're outside in the sunlight, the bright light therapy also has some significant data for depression management. So we want to get an idea of their overall risk assessment, how stable they are, right? How willing they are to seek help, but also are they aware of what's available out there? And then we want to look at the questionnaires and to monitor their disease process, but also to see if we're getting success. Because that's how we can help with deciding, should we augment? Should we add therapy? Should we get somebody else to help us out? So initially, you want to do an initial questionnaire, whether it's PHQ-9 or BEP or Hamilton, do something to do your initial depression screening after you do your history. Then at least once do the GAD-7 and the MDQ, okay? Once you do those three, then the following ones you don't have to continue doing all three. All right, so for the exam, obviously basic stuff, right? We want to make sure we look at the vitals and the heart and the eyes to make sure they're not overly dilated or overly constricted to make us worry about substance abuse. But you don't always have to look at the pupils. You can probably tell just by how they act most of the time. And then we want to see if there are other comorbidities, are there heart issues going on, are there lung issues going on, because some of those can be fairly affecting us as well. In terms of psychiatric issues, a lot of things. How are they dressed? How do they act? When I interrupt them, how do they act, right? Do they go on random topics? How is their speech? Are they pressured? Are they fidgeting quite a bit? Are they not wanting to talk about certain situations? And that's okay. The calendar may not be the time to talk about the sexual abuse or traumatic issues that they've had, but get an idea how they respond to certain stressors. And you can get a lot just by watching these patients. And so don't do this in conjunction with your heart failure and COPD visits. If you see there's a positive screen, get them in for a separate dedicated visit. If you have the ability to control your schedule, take a little bit more time, make a 30-minute visit if you can. And some of these visits you can also, because you want regular follow-up until they're stable, if the patient can't always come in because of work, some of these can be done with via televisit, okay? So think about other options to make it more likely that they'll continue. The GAD is a global assessment. It's a scale that looks at how, I think I misspelled that, sorry. I meant GAF, okay? Global Assessment of Functioning, GAF scale. And what that is the scale from 0 to 100. 100 means they're working great. What you're trying to do is you're trying to see where they fall in terms of their different realms, their occupational, their school life, their personal life. So it gives descriptions. So for example, someone who has a lot of depression symptoms that they talk about, and then you ask them how they're doing. Are they still going to work? Are they socializing with friends? How is their relationship with their spouse or children? Are they still doing the chores at home? Are they still paying their bills? Right, you ask all these other questions, and then you can kind of put them on a scale. So if they're doing most of those things, they're probably above 70. Once they go below 70, once they go below 60 and 50, then you definitely know that they're starting to affect their different occupational and social life. And we want to make sure we're following that. So in addition to following whatever screening tool you use for depression, I would encourage you to periodically also look at the GAD. You can just Google that. I gave you a link for it, and you can kind of say where they're at right now. Okay? But you base that on the entire story they give you. And as we know, we want to start with opening questions. How are things going? You know, tell me more, etc. You do that a few times. Let them see that whole story. And what studies have shown is that the average patient will stop talking in 3 minutes. And I asked them 3 times, anything else? Well, tell me more. 3 times. If you do that, within 3 minutes, they will stop talking. Now, you got to learn to bite your tongue and sit and listen, because you will get much more information from them talking, even if it involves their random neighbor story and their dog and their kids and all that big message that they give you. You will still get more information than just a pointed question, because you'll only get the answer to that one question. And the studies show that the average clinician interrupts within 17 seconds. But if we can teach ourselves to not do that, that 3 minutes, even though it might feel like 30 minutes, it's only 3 minutes. Sit down, eye level, don't let them sit up top, right? Eye level, let them just talk, and you will get a lot more information. Deciding on the treatment, so of course we want to see if there's biases that they have, that there are certain things that they go through, are they more activated, are they more depressed, are they worried about, are they thinking of getting pregnant soon, or are they already pregnant? Decide which one you look at. And then are they not a good pill taker? Are they going to forget, so maybe you want to use a drug with a longer half-life, right? What is it that based on their symptoms they need more of? Do they need more of the dopamine or the serotonin or the norepinephrine? Which of those drugs do they need more of? So that's what we'll go through. For treatment choices, we want to start the medication and keep them on until they're stable, and then at least 6 months before you consider taking them off medication. If they have a lot of other coinciding issues, poor social support, they don't exercise very much, they have all sorts of others, don't try to wean off until at least 12 months, because the relapse rates are higher. So side effects, we want to address some basic stuff. We want to talk about missing doses and how to take extra. Just because one tablet works doesn't mean that 3 is better, right? So the side effects with that, some of the medications with their contraceptive might be interacting, so when to take those medications are important as well. And then avoiding some of the Google searches, right? Because we want to get an idea that we tell them the basics so they avoid that Google search and just freak out when they see it. Because they're all going to say seizure, death, all sorts of patterns. We want to see them pretty close. The 2-week follow-up, I typically say, is not for medication efficacy. It's to see if they're having side effects or tolerating issues, or if they've done a lot of Google search and they're nervous, right? And then you see them again in 2 weeks. But that time, you'll know if the medicine started to work or not. So a lot of times we've always heard medicine is one of the best medications. We want to try to see what kind of support do they have, or are they still finding joy in their life, right? Are they still finding some sort of reason to stay around? Or are they always thinking, what am I doing here? What's the point? If that's the case, then that's a little bit higher risk for badness. So we want to see those patients more often. So when we start looking at treatment, psychotherapy, and or second generation antidepressant, okay? That's the first line. When we look at psychotherapy, we want to look for cognitive behavioral therapy or just straight behavioral therapy. In some cases, if you're having issues with couples, obviously there's going to be marital counseling involved. But at least initially, they need to see that person individually. Typically, cognitive or cognitive behavioral therapy or behavioral therapy alone is one of the most studied. There's some decent data now for interpersonal and psychedelic therapy as well. All right, so there is evidence for bright light therapy. There is some evidence for yoga. Adding acupuncture, there's no harm, but by themselves, as monotherapy, there's been no consistent data. All right, for treatment, the first thing is we wanted to start with first-line treatments. And so the list there are the first line. Those are the second generation antidepressants will be considered first line. SSRIs, SNRIs, the bupropion, mirtazapine, which has been added in the last few years, which is this one here. Those are the first drugs that we should go to. Okay. Then you could always choose combined drugs from different classes that don't always increase the same type of neurotransmitters. So you can augment that way. Then you would add a second generation antipsychotic. Okay. The first generation antipsychotics are your haloperidol, right? Which have a lot more tardive dyskinesia issues. Those are permanent. They may or may not happen with lower doses or higher doses. It's hard to predict. But even when you stop them, they may continue. So that's where the antipsychotics that are second generation or atypical antipsychotics came into play. They don't have the tardive dyskinesia really, but they do have some side effects, such as weight gain, some metabolic changes with the cholesterol, glucose, and that's something you have to monitor. Of these, aripiprazole, which is the vilified brand name, is one of the ones that's been very effective. I would tell you that even though the data shows 11 to 12 milligrams a day, you typically don't need that much. Okay? 2 milligrams to 5 milligrams works very well. This data was from the psychiatric literature, where patients have already been referred out of primary care. So that's why this data shows higher numbers. Okay? But in most of us, when we're augmenting for fairly relatively stable patients, 2 to 5 milligrams is reasonable. Okay? I'll address brexpiprazole later because it's a newer drug. For Kyadipine, which is the brand name Seroquel, typically 50 to 150 is enough for most patients. It is sedating, it does cause weight gain, so that's something you have to be careful about. Olanzapine, again, you don't need 8 milligrams. Typically 1, 2 to 5 milligrams max. If you're having to use this one, I think you need to have somebody else on board. Okay. With the Cariprazine, it has some good data on it as well, but it's off-label. And I'll share that with you later. So if you look at systematic reviews, which is one of the highest levels of evidence, right? And systematic reviews for randomized trials, in those data, they show that patients do get some symptoms with the typical antipsychotics, and the atypical antipsychotics are safer for that reason alone. You do have to monitor the lipids and the glucose for every so often. In some cases, you may have to get a baseline EKG as well. Now, the military patients, this is something that I'd address. If you're using antipsychotics, some of the military patients, it might trigger an evaluation for fitness for duty. So just make sure you talk to the patient first. Make sure they talk to their senior person and see what that's going to lead to. Oftentimes a note from you and it's going to suffice. But if that's not done on the front end, sometimes it can affect their livelihood. Because some of these guys have been doing it for many years. They want to stay in the military. They don't want anything to affect their ability to serve. And of course, also their benefits that they're due. Treatment classes. So first line, I'm going to go over these individually later, but second generation antipsychotics. This slide is just to give you the names of all the different drugs in the different categories. Okay. And then the second line after that is going to be tricyclics. It's not that tricyclics don't work; they do work. However, there's more of that's why they're not first line. Side effect profile in terms of anticholinergic side effects, as well as some of the issues in terms of weight gain. All right, atypical antipsychotics, we've listed them as well. Most of them affect the serotonin and dopaminergic system, which is why you're going to have a little bit more benefit. They don't typically have too much serotonin, so you're not going to have too much serotonin syndrome, but it is possible. And then you have the typical antipsychotics, which do work. Don't get me wrong, they do work. If you do very high doses of these, you're basically just knocking them out. You're sleepy and tired. You're not getting really what you're trying to aim for the antidepressant part. So treatment decisions, try any of the first-line drugs, bupropion, mirtazapine, any of the SSRIs, any of the SNRIs, and go from there, right? At that point, there's been several trials, meta-analysis of 522 randomized controlled trials say that these are good, they work well, they're relatively safe for most patients. All right, initial therapy, we don't want to use any of these. So ketamine, which we can't use anybody else use special licensure, they work, don't get me wrong, they do work, but that's not something that we can do initially. Mainly because of side effects. TCAs, we talked about. MAIs, I don't think any of us really prescribe that much of it. Anybody prescribe MAIs regularly? Lots of interactions, low therapeutic effect, lots of side effect, and drug interactions. All right, ECT works in those patients that are just drug therapy is not helpful. If you're on 3 drugs and you're not anywhere, consider referring to someone for ECT. It works really well if done in the proper hands. Proper hands meaning someone who's trained, boarded, and who does it regularly, so they know what to expect. So SSRIs, they're second generation, first line. They're relatively safe. Side effects, mostly we hear about sexual side effects. We hear a little bit about weight gain. Some of them are different in that regard. We do have to have a baseline EKG to make sure that their QT isn't prolonged before we start these drugs. And then these are the main ones that we see. I'm going to talk about the different ones in just a second. So these are the different SSRIs. I thought it was important for you guys to understand why you would choose one SSRI over another. So I'm going to skip the first one because most of us don't use this. One of the older ones has the most side effects, so we don't typically use that. Fluoxetine has the longest half-life. So if you have a patient who has poor compliance, use fluoxetine. Because even if they miss a day or two, they're not going to notice that problem. Okay? The other part is it is pretty much more activating. So if someone is depressed and severely depressed, they need to be more up. Fluoxetine is a good choice. If you look at citalopram and I didn't list citalopram. The citalopram, which is Celexa, and escitalopram, which is Lexapro, use those in patients who need a more even heal. A little bit of anxiety, a little bit of depression, and also use it in patients who are taking a lot of medications. So they have the least drug-to-drug interaction profile. So that's where you would choose those 2 drugs instead. Well, it also has the benefit of the decrease of premature ejaculation. The downside of paroxetine is that if you're a woman of childbearing age and you do get pregnant on this, there can be some significant cardiac events with that drug. Also, it has the shortest half-life. So if it's a poor pill taker, this is not the drug you want to use because they're going to have more rebound much faster. Okay? If they miss a day of this, if they've been on it for several months or several years, and they miss a day, they're going to tell you about it. They're going to know. They're going to know not to miss it again. Sertraline is pretty even keel. Nice drug, works pretty well. The biggest thing is it has one of the most weight gains. But it's a good drug. The only other downside of sertraline is that it works better at higher doses. So of course, at higher doses, you get more side effects. All right, what about the SNRIs? Sorry, I misspoke. SNRI. In those drugs, we're looking more at serotonin and norepinephrine, right? So the addition is the norepinephrine part. However, because there's a significant serotonin component, you would never combine this with an SSRI because you will probably get some sort of serotonin syndrome. And it's pretty effective. They like to advertise that they're more effective because they're newer, more expensive, etc. But there's no evidence to say that they're more effective. Okay? They're more. It's another option. And I'll tell you why you would choose that. A key to pay attention to: the serotonin to norepinephrine potency ratios. If you look at that, venlafaxine, which effects are 30 to 1. So it's still mostly a serotonin. The newer ones, duloxetine and desvenlafaxine, which is Cymbalta and Amnesty, these are a little bit better, but still, majority serotonin, a little bit of dopamine. The only one that's got a 1-to-1 ratio is a milnacipran. Okay. So that's how you would decide, depending on the patient, which drug from this you choose. Side effects are very similar to the SSRIs, and you have to just be careful about making sure you're not combining. Hyponatremia, and we do see this especially in the older patients. This is not just SNRIs, but also SSRIs can cause hyponatremia. All right, this is a table that talks about the.
When the presenter is not in use, please remember to remove the US.
Okay, I will. So the big thing here is that they have other indications as well. and the half-lives. So Cymbalta, venlafaxine for menopausal symptoms, they have indications for chronic pain, and so forth. Yeah. Bupropion, pretty well used. This is Wellbutrin. If you use the SR version, the benefit of helping with smoking cessation. One of the nice things about this, it doesn't cause the sexual side effects. So you can also add on therapy and it can help combat that. The other thing is that there's some benefit in the mechanism of action in terms of stimulation to be able to help with concentration and attention. So some patients who have some ADD type symptoms also, this might be a good drug to start with as initial therapy or as an add-on therapy. It does hit different receptors a little bit more, so you get a little bit more of the norepi receptors it does well, and dopamine. So a lot more dopamine, a little bit of norepi, almost no serotonin. So combining this with one of the SSRIs or SNRIs is very nice because you don't have to worry about the serotonin syndrome. It works pretty quickly. You don't have to wait a full 2 or 3 weeks like SSRIs and SNRIs. Within 3 to 5 days, people will know and they notice a difference. Again, it's nice it has initial therapy as well as add-on therapy as indication. The big things are sometimes people do get activated, people do get a little more agitated, but as long as you give them that heads up, they do get used to it. If they can't, then we take care of it and change it out. In some patients, it can lower the infusion threshold. Again, those are much, much higher doses once you go up 300 milligrams a day. That's when you start thinking about those medications. There is a newer drug that combines dextromethorphan with the bupropion, and there's some data, just in terms of time, I'll just tell you, the confidence intervals are pretty wide, which tells you that we're not really sure where the actual efficacy lies. Is it that much better for this drug compared to bupropion? For the most part, the data does not say that it's that much better. So bupropion probably is just as fine. Mirtazapine is another drug that that's used off-label for insomnia because it does hit some of the histamine receptors, so it makes you pretty sedated. It does cause hyperphagia, so people do eat more and gain weight. So if someone else already having those issues in terms of being underweight and depressed, this might be not a bad drug because it is very active and it helps with appetite, helps with sleep as well. Again, it is a first-line drug, relatively safe, pretty good data. It has, for the most part, it works pretty well. The only thing is that you have to just be careful about not combining, just be careful about the serotonin possibilities. Okay. TCA's second-line drug, mainly because of you have to go higher with these doses to make it work well. But they do have other indications. Someone who has chronic migraines, someone who has neuropathy, someone who has chronic pain, these medications work very well. Is it because of something else? There's signals for both. So there's indications independent of depression and treatment for neuropathy and so forth, but there's also indication for depression. So it's a nice add-on therapy. Because it does also hit serotonin, combining it with SSRIs and SNRIs, you just have to be careful. It's not contraindicated. You can add on therapy with SSRIs and SNRIs, and it works very well. So if you have a patient who takes either an SSRI or SNRI in the morning, and they're having issues with sleep, and they're still depressed, and they're not quite getting there, adding a low dose of amitriptyline, 25 to 50 milligrams, most of the time will help. Once you go above 100 milligrams and you're still not working, it's probably not the right drug for them. If the amitriptyline is sedating them too much, but it works well, switch them over to nortriptyline, which is Pamola. Now it's actually affordable. It used to not be, but it's affordable, and it won't be quite as sedating. But most of the patients I notice that they get benefit with this is they have chronic pain and have insomnia and depression. So when you add on therapy with this, it usually works pretty well. And also has that benefit of migraine prophylaxis. All right, for buspirone, this is Buspar. This is initially used for mostly for anxiety, but it actually has an indication for unipolar depression. It works quite well. If you have patients on SSRIs or SNRIs that have sexual side effects, adding this can help diminish the sexual side effects. So that's one of the nice things about this drug. It's relatively safe, relatively even keel. The big thing with this one is you have to make sure you don't augment too quickly. Milligrams for a week or two, then go to 7.5 twice a day before you, in a month, you go up to 15 milligrams. For the most part, STAR-D trial showed that it does help. STAR-D trial did a lot of things. It showed that most people, majority of people will be benefited with one drug. Of the people that don't get benefited with one drug, 75% or so will be benefited with 2-drug therapy. If they need 3-drug therapy or more, it doesn't matter what combination you get, you're probably not going to be in trouble. That's kind of the gist of what STAR-D shows. So the drug itself didn't matter, is regular follow-up, social support, and making sure you're doing the drugs in the right way. So again, this one has a pretty good affinity for serotonin as well as a partial agonist, and then it has dual effects: partial agonist for some of the receptors, partial antagonist for some of the other receptors. Relatively safe, pretty easy to use, very affordable. All right, what about the antipsychotics? We typically want to use these in conjunction as add-on therapy when they're not controlled. I would say that in most patients, at least try 2 of the other first-line drugs first before you go to an antipsychotic. There are exceptions, like anything else. Someone who's having a lot of psychosis symptoms, severe depression with psychosis, SSRI or SNRI plus an antipsychotic as a second drug. Very reasonable approach. Big thing with this is the metabolic issues you have to watch out for, and doing at least a baseline EKG to make sure you don't have risk factors for some sort of arrhythmia in the future. All right, the newer agent, brexpiprazole, again, lots of trials that were done. Is it better than the other antipsychotics? Side effect profile is not that much safer, and the manufacturer would make it seem like it is. It's not. The data does not support. It's higher expense use for patients in these situations, even for dementia. And otherwise, I'm going to skip over just for the interest of time because most of us don't use it. Probably need psychiatry for like lithium as well. Lithium works, narrow therapeutic window, lots of side effects, lots of drug interactions. So I'm going to skip over some of this because the information is there for you guys in terms of monitoring if you are using it. But again, it's outside the scope of typical primary care practice. Now, if you are on 3 drugs, right? SSRI or SNR, any of the first-line drugs, you are two first-line drugs, you've already added a second generation antipsychotic, and they're still not controlled. There's some data on adding T3, even if their TSH is normal. So you just have to monitor the T3, T4, and TSH, of course, so we don't make them hyperthyroid or hypothyroid, but at the same time, just want to make sure you watch it. But it works. There's some good data on it. Trazodone works very well. Again, the main thing is side effect is sleepiness and weight gain. It also has an indication for premature ejaculation. So these are some of the reasons you might use trazodone as second line, not first line. Why is it not first line? It's safe. It's just more than that. It's a sedation use, and they don't have the robust data as a first line drugs do. So I've given you guys a mechanism. Lots of antagonizes. Sometimes it's an agonist. But for the most part, it's based on serotonin. It does have a little bit of histamine issues. That's why you get the sedation with it. Pretty well tolerated. All right, Vinebrate or Vilazodone, again, relatively newer drug, supposedly for moderate to severe depression. There's some agents where serotonin, is it worth the cost of $150 per month? Consistently, the repeated articles that showed it didn't really say that it's more efficacious than the cheaper first-line drugs. So I mention all this to you guys because we are bombarded by ads. We are one of the few countries where drug companies can do direct-to-consumer advertising, and patients come in requesting some of these drugs. So it's important for us to know what the data shows us before we just give it to them. New medication, I haven't used this one, Gepirone. So mostly serotonin, and then it's just much more affinity for one of the serotonin receptors than bupropion, buspirone. And theoretically, it makes a big difference. There were a couple of trials done on this, and really there was some statistical significance, but not clinical significance when you look at the overall picture. Side effects, cost, everything else. Okay. Cost is substantial, $690 a month.
Oh my.
It was rejected, I think, 2 times by FDA, and in 2024 it got approved. Okay, vortioxetine, again, this is a drug that I haven't used, but I've seen my patients on it. Ones who went to psychiatry, who've been on multiple drugs before, 3 or 4 drugs, they switched them all to try it. I haven't seen that much of a clinical benefit anecdotally. Relatively safe, but again, the price point's pretty expensive. All right, ketamine and esketamine, I'll just summarize some of this for you. Ketamine works, more addictive, has some issues there's a lot of issues from the past, right, of people being sexually abused and physically abused because there's a lot of disassociation with it. People have retrograde amnesia with it, so lots of stuff that was done in the past in multiple different countries. So a lot of history behind it. But in the right hands, in patients who are treatment resistant, ketamine works. Because of side effect profile, the abuse potential, there was a new drug, a different isomer, now it's called esketamine. Also, it doesn't have the same high that ketamine would give you, but works. You still need a separate license or a little bit higher scheduled drug availability from a DEA to be able to prescribe it. It works really well in treatment-resistant depression. So it is something to think about and refer patients to with a psychiatrist who does take care of this. Just be careful who you're sending them to, okay? Because there are clinics that do this kind of stuff. But again, you want to send them to a board-certified clinician who takes patients and sees these patients on a regular basis. All right, these trials basically show that there is some benefit with using both of these. There's less likelihood for abuse with esketamine and ketamine, and then less of that craving. Both of these, so they're newer drugs. This is a capital receptor antagonist coming out to be second line after you add an SSRI, SNRI, double-blind trial, phase 2 trial so far. And with all these drugs, we want to see how do they work. So I've included the biological possibility of why they supposedly work. So supposedly it'll help with immune capital receptors. Maybe will help with the stress-reward ratio that we have in our society. Questionable improvement. Again, it's only phase 2 trial. We'll see what happens. So despite everything, there's so much other stuff goes into depression. So treatment efficacy is very varying depending on the trials you look at. But for the most part, the first-line drugs and the second-line drugs have decent number needed to treat compared to number needed to harm. They're all less than 10, right? They're pretty good. For these drugs that were tried, SSRIs, SNRIs, even for the tricyclics, they work without causing significant harm. But you get treatment-resistant depression. After 3 or 4 drugs, you're still not controlled. In those patients, you're going to need multimodal therapy. You're going to need multiple pharmacological agents, regular follow-up, some sort of establishment into the system so they can be followed by a counselor, a therapist, and social worker. So in most of these cases, patients do well. See them at 4 weeks. At that point, you're going to decide one of the two. Is this the wrong drug for you? In which case, I need to change it. Is it a drug that's not helping at all? Then we need to change it. Is it a drug that's helping a little bit but not enough? At that point, you increase the dose or you add something else. And then you follow up again. They're still not where they need to be. You add it again. How do you decide if they need more? Combination of your history, their report, some sort of PHP-9 questionnaire that you're documenting, and that GAD scale, right? You look at all that together. Now you have some subjective data. Yes, those scales that you're doing are still subjective. It's based on what they're saying, but it quantifies it, so you can kind of follow it a little bit better. Once they are in remission, I don't mean just control. Once they're in remission for more than a year or 2, relapse, unlikely for the most part, unless there's a huge stressor of some sort. 6-month relapse is pretty unlikely, so that's where the data comes in, that once a person who doesn't have too many issues, once they're on a stable regimen for 6 months, meaning they've been good for 6 months, you consider weaning off. If they have multiple issues, then you want to wait at least a year. All right, so partial and non-responders, you can also add therapy, right? If they're not doing any sort of counseling, we can switch or we can opt in. And the starting trial showed that most of the time, patients that didn't get medications, that didn't do well control after 3 medicines, it's very unlikely for them to be controlled. All right, a couple of discontinuations. So people that are well controlled, we want to start thinking about taking them off. We don't want to continue these medicines for the rest of their life. So if they quickly, abruptly stop, they may get some of these symptoms, and there's an acronym called FINISH. Flu-like symptoms, insomnia, nausea, imbalance, etc. Okay? This is what they'll feel if they just quickly take off the drug. I'm not talking about the person who's been on the drug for 3 months. They've been on the drug for 6-7 years, and they all of a sudden stop. They might have these symptoms. So we want to look at how to discontinue these medications. So the next slide, I believe, is talking about the tapering strategies. So I've given you guys about 5 or 6 different strategies based on the literature in psychiatry on what are effective ways to reduce their dose. Okay? Tapering 10% at a time, a 3-month taper with 25% reduction every 4 weeks, and so forth. There's a lot of different options. Take a look and see what you want to work in your practice. And not, of course, this is not a universal thing, right? Different people might need different strategies. But there's different tapering strategies because we want to encourage taking people off medicines when they don't need it anymore. And then geriatric patients, be careful about the lights because the sodium can drop. Be careful about the conduction issues, so make sure you look at the EKG at least at a baseline, and then try to use drugs that are not too dopaminergic, right? So they're not getting some of the tardive dyskinesia type issues. And really incorporate some sort of therapy for those patients. So St. John's wort, there are some efficacy data on there. It's not FDA approved. The problem is what you get, you have no idea. You have no idea how much of the doses of the medication there's in there. You don't know what else is mixed with it. Those are the big issues that we have with it. And then, of course, the side effects and the interactions. ECT works. I've given you some guidelines on who ECT might be a good choice for. Treatment-resistant depression despite 2 or 3 drugs, catatonia, other medical conditions, other psychiatric conditions. You know, they've had response to ECT in the past, family histories worked for ECT in the past, so, or they just can't take multiple drugs because of side effects. And then transcranial magnetic stimulation. This is looking at somatic treatment using some magnetic fields. Iffy data, you know, no harm though. Iffy data, no harm, that's how I would summarize this. And I'm giving you guys my references with that. There was one meta-analysis showed some benefit, then there's a newer version of it called data burst stimulation. This one has very, very weak evidence. All right, so the rest of the data is kind of talking about transcranial electric stimulation. One thing I would show you, when you look at the slides themselves, some of the effect sizes are pretty high. That's because, okay? The other thing is they changed the way the graph is written, so each point will take a big jump in effect sizes. So take a look at the data itself, it's not as impressive as the article's making it seem. All right, no evidence for these so far, and then we would recommend against using the following drugs just for the purpose of depression. Pharmacogenetic testing, this is heavily pushed because it's expensive, and people say, well, if you know how you process drugs, your pharmacokinetics, your pharmacodynamics, maybe the drugs will work better for you. The data in Medicare population has been done quite a bit, and the reason this isn't covered is because that really hasn't shown that to be true in clinical medicine. So don't let patients waste their money on this stuff. How do I approach my patients? First thing is I do the history that we mentioned. I do some basic labs, especially if I'm going to start some of these drugs that can cause metabolic issues. And then, of course, I make sure that I address contraception issues. First thing I do is I do one of the main scales, right? PHQ-9 or Hamilton or one of those scales. And then I would do at least initially a GAF and MDQ to make sure I'm not seeing what else might be the cause. At that point, I will do a fair amount of history, and then I'll kind of see where they're on the GAD scale. And I'll start them on a first-line drug. I'll have them come back in 4 weeks, see how they're doing. And then at that point, I'll either add medication or augment medication. And that would be another first-line drug. If by that time, if I haven't seen any benefit with 2 first-line drugs, we'll add an antipsychotic, use a antipsychotic. Now there are 3 or 4 drugs, they're still not better, that's when I would add T3. Okay. At that point, I'm getting help. It's a lot. Because that means I've missed something. They're not getting a social support, they're not having counseling, they're having something else going on. So that's how I approach my visits. There's some mobile apps. We CME Internet Travel Academy are not recommending these apps. We're just giving you guys some options that patients can perhaps benefited for some of the use of these apps in terms of monitoring and reporting. But that's the entire lecture. Any questions? I think we're on time, pretty much, right? So again, for lunch, please, there's several options out there. I would focus on the quicker options. If you go straight down the escalator, there's a restaurant called Giada. They have several different options there. And then look for the signs for Celebrity Food Hall. That has about 5 different restaurants, like food court style, pretty quick, pizza, burgers, Korean food, sandwiches. There's also a Starbucks there as well. So that's pretty close by, 5-minute walk from here. And we'll start back at 1, okay?
And we get 5, so you guys get full hour, okay? So we'll make it work.
If you guys are joining us live stream, we're gonna just cover the lens for an hour, and when we come back, we'll keep it going.
You can leave our stuff later.
Yeah, I think so. I mean, if there's anything valuable, please take it. Yeah.
I want to end the stream because I can stream.
Everybody.
What we can do is stop sharing. That's totally. We just need this moment. Take my turn off.
I think that, like, as you can see, people kind of join the live stream eventually. We have 6
What is the password for the internet?
No, don't choose the Palace Resorts, use the one that's the screen.
It's Caesar's Resort, right?
Yeah. So if you do the meeting one, that requires a password, but the Caesar's Resorts.
Caesar's Resorts.
Yeah, it looks like the sign required, all it is student second terms.
Okay, thank you.
But are you not getting a cell signal in here?
Oh, no, I am, but I figured I was gonna hook the computer up.
Yeah,
Instead of
yeah.
doing it.
there's no bodies. They're broken. They're at lunch. I mean, we haven't heard of them. Hi.
Hi.
I'm Kara.
How are you? Hey, Kara, how are you?
Is it Anish?
Anish.
Anish,
She's my partner.
pleasure.
Good to meet you.
Pleasure. Thank you for choosing Caesar's Palace. We popped our
Yes.
heads and I'm like, they went to lunch.
Nice to meet you.
Everything worked out okay. I saw we got the podium real quick for you guys this
We
morning.
did, we ended up not using it at all.
It happens sometimes. Sometimes you just feel like you need something to do that, but it works out. Everything's going all right?
Going good. We're actually coming back in March,
Love that.
and then maybe in October again after that.
Kind of same setup then.
Kind of same setup, yeah. Hopefully bigger, more people.
I love that.
Yeah.
Bigger room.
Yeah.
You'll probably have Adriano or one of our other managers too, but we'll be here.
Now, you guys have projectors too, right?
We
If
do.
We decided to.
Encore.
And that, the image is probably a lot clearer, I imagine, right? Yeah, yeah. So that's something that we need to consider, you know, what we're gonna do next time around. Because, you know, the image is a little unclear and then a little bit of sunlight coming through too.
It does. This room does, yes.
Yeah, because like when we did the slides,
How blurry is it?
it wasn't blurry. It's just that it wasn't all presenting well.
Contrast is not, as
Okay.
good as we'd like it to be.
Right.
So like, you know, this one, it's not, you know, it could be crisper. Like,
Oh, yeah, I see what you're saying.
We've always had TVs. So it's
Yeah.
not-
I mean, you can always try it.
No, I know, I didn't think it would matter, but it did.
So the TVs, y'all have that as well?
Encore Audiovisual has
Okay. the whole-
Lumen project, they have really,
Whichever option you
really
want.
special
Yeah.
projectors,
Okay.
and we have TV options. Sometimes the TV, if you think about it, if it's nowhere,
Mm.
you also have the same issue of like,
Okay,
did you
okay.
see that? Or
Do you think the projector?
I just think because maybe it's smaller,
Oh, the TV's
just the
smaller?
TV is smaller
Yeah.
than a screen, right?
Okay.
Yeah.
So
So
but
you
when
think
you're
a
making a
projector
screen,
works best?
I would say a more luminous projector.
Yeah.
And they have bigger screens too, so if you're in a bigger room, it
Uh-huh.
can be
And you have
brighter
more
and
people,
clearer.
yeah, you can
Yeah.
always.
Yeah, we had, you know, we also live streamed it on YouTube
Oh, okay.
because we have a few people joining us online, and then
Okay.
we projected the actual display from our computer to
Oh, nice.
YouTube. So that way, if they couldn't see it, they could, it's just,
Then
it's
they
a
could
hassle,
see
right?
it, yeah.
Yeah. Just an extra
Oh, is
step.
that part of the AV package as well? Y'all do that live streaming? and-
AV can do everything,
Oh, really?
Yeah.
it's just,
Cost,
cost,
right.
how you wanna,
It didn't,
Yeah.
that wasn't too much more for us to do, just
Okay.
because it's a click,
yeah,
whereas I think they charge several hundred.
that makes sense.
But obviously better cameras and stuff.
But everything's working out,
Yeah, the only
Mine
thing
is-
we wish we had was signage. I know you said it has on the.
so we have reader boards.
Yeah.
The digital reader boards, so right out here, it reads your meeting and then the room name and the
Yeah.
time. We don't have anything dedicated outside any of the single rooms, just the.
But I didn't know
large
that we
display.
could, like some places they don't allow us to bring it, but I know
You
that we
can.
could.
As long as it's only in front of your room.
Okay.
So for when you come back in March, in whichever room that you contract, as long as it's in front of that room.
But the other one, the women's conference, they have signs all throughout the hall.
So they do, but they're not in front of certain rooms. They can't walk
Mm.
anybody's rooms that's not theirs. And they have quite a few down the hall.
Oh, they have multiple rooms they're using?
They have a
Oh, I
lot.
see.
There's about 500,
Yeah, it's
More
main
of them.
conference, right?
there's quite a few of them, yeah,
500 people?
attendees.
Oh, wow.
So they have the large room down the way. Actually, I think they are like 600 still 5 today.
Hmm.
Yesterday they were 500, so. They have quite a number of people. And then this past weekend, we had 3,000.
Oh, really?
For a conference.
For which conference?
A different conference,
Oh.
like an insurance conference.
Oh, gotcha. These are women in health, what was it? Women's health?
I think that they're just healthcare
In general.
in general.
Okay.
It's a lot of people.
Those doctors, we might just go up and say hi.
No, I don't think any of them are actual doctors. I think it's just all just healthcare
Okay.
in a broad spectrum. That could be from anything to,
Mhm.
yeah.
Yeah, we are more for physicians and nurse practitioners and PAs.
Love that.
People that are actually seeing patients. So,
Love that. We're nowhere if we don't have a doctor.
Well, because the talks are dedicated towards those, right?
Right.
Medications and so forth. Thank
Okay,
you for
well, we
coming
wish
out.
you the great rest of your day.
If we wanted to change out the projector. that's
I can have
pretty quick, right?
I can have audio visual
Okay.
come down and see if we have one on site and just switch it out.
Oh, how much would that be extra?
I don't know, I have to
Yeah.
just ask audio visual,
Yeah.
but we could definitely look at it,
Okay.
for
yeah,
sure.
I'd like
Even if
to
they just
just.
come
At least
to know
see.
about it.
Who did we,
The elections.
who did
Chuck
we do?
was-
Chun?
Chun.
Yeah.
All right, I think he's here, I'll go grab him.
Well, I have a card from somebody.
Oh, he's probably just a tech.
Okay. Yeah,
Perfect.
he's the one who told us about everything.
I'll tell him, I'll have him come
And
by.
I guess we'd like to see the difference before we decide to pay.
Understood.
Right, yeah.
Yeah, I'll have him come by,
Okay.
just to tell you the difference and switch it out and see if it helps.
Yeah, we're starting at 1,
Okay, I'll go do
if
that right
that's
now.
possible, but even if it's not possible, 1 because
Yeah.
it wouldn't be worth it for today because we only have 2 more talks, right?
Mhm.
But it
Right,
might be
but
worth it
at
for
least
tomorrow.
maybe tomorrow,
Yeah.
we can switch it out tonight.
Potentially.
Potentially, yeah.
Yeah, I'll call him right now and I'll have him give me a price.
All right.
Great, thank you.
All right?
And then after tomorrow, you guys just bill us? Is that how we pay the
Mhm.
balance?
Yes, it's
Okay.
about 4
It
weeks
takes,
after.
yeah, it takes time, so.
Okay, yeah,
Yeah.
okay.
It takes time and you'll get from a notification email or something
Okay.
from our accounting team.
Yeah, I just want to make sure I didn't have to pay before I left because I fly out on Saturday.
We'll probably give you, we'll send you checks
Okay.
and you can click and sign on them.
Mhm.
You can just do a sign, we'll send you the bank checks
Oh,
that
okay.
match the BEO.
Oh, I see, okay.
But then the rest of it will come from our accounting team.
What else would there be? Oh, AV, okay.
Yeah, audiovisual would be another thing, like wrapped up in a
Yeah,
pretty
yeah.
little package from accounting.
All right.
Like,
Very nice.
Transacting, so maybe I'll just call.
Downstairs.
I'll just run to the restroom.
Yeah, and I will call, nice meeting you as well. Have a good meeting, and
Thank
I'll
you.
call our AV tech.
Yeah, well, why did we not go with Google Meet instead? Why do we not go with Google?
You said it was fine?
We recorded it.
Okay.
Those napkins are those napkins are already there. The brown ones are ours, so those white ones are ours. Yeah, it doesn't have to be today, there's only people left today, but we want to see, because what's mandated is the brightness.
Yeah. Yeah.
Yours, way better, I'm assuming.
Tell you what, I mean, if you do need a projector from us, I'll give you half off on it. I think it's like $700, so it'd be like $250. So, if you wanted to do that. And I can have, yeah, then I can have to switch out like. And
Carlos. Coffee, Livorno.
Hey guys, I'm just trying to get an ETA for the table on the stage, but I see someone bringing chairs already, so it looks like you guys are on top of it. Never mind, disregard.
This is, I'm still, okay.
This is your line. It's weird how I think let's see if it will back up. Just so I believe it's diabetes and then hypertension.
When
want to go first? Or you go first? How the King's Laws was that?
Gets the stick. That's odd. Stop it. Spent so much time figuring out what's wrong.
You start.
Oh, there's some questions coming in.
Says, I didn't realize it was linked to a CME trial event. Do you check equal levels for patients with CME and anemia? So this is all one company.
So you answer that, you're not going to be.
On the side, this
Try responding to her.
Shelley?
I think so. You're not responsive.
It is just an email backup, you know. By the way, do you want me to have it continue come to email as a backup or no? We couldn't do that.
I guess we don't need that. As long as it comes to voice and stuff.
So this is Nicole Barkley, custom CE reminder that we don't have to worry about anymore, right? That's what they spoke to. She said what she really wants to get it.
Yeah. Yeah, they are doing first.
Here's a request for savings in March. I'll sign up later. That letter. I signed it to you, so you should have links now for San Diego and for Milwaukee. Exactly.
Hey, how are you doing?
You guys want to swap this out?
Oh, yeah, that'd be great.
Okay. So we just got the power.
Yeah, I got you.
Okay.
We got you, buddy. This is your UPC, so why don't you guys take that?
Yep.
And then I'll give you this UPC back. That way you don't have to worry about it on the out. Well, this, is it marked? No. So here, take that one. They're both the same ones.
Well, this is the one, okay, that's.
I mean, if you, they're saying, does it matter? Do you want this one to go with that one, just to be safe? I don't mind. Yeah, let's do it since it's just, it's the exact same, but it's okay. Just so you guys feel comfortable.
Oh my gosh, the size is good. Just out of curiosity, how much are these for to buy?
Or to buy them.
To buy,
You can just Google it, it's Pebbles and type it in.
I would assume, you could probably find people selling them used, to be honest with you, for a decent price. Brand new, it's almost worth it to buy it used, and then you can replace the lamp yourself.
Yeah.
Yeah. Yeah, so you buy this projector, and then you could, not necessarily this exact projector.
Yeah.
But, and then you can buy them used and then just replace the lamp usually.
So what we're really looking for when buying these things is,
Today's your mind.
lumens, is that right?
Yeah,
it's a
exactly.
flip. This would be 5K.
Yeah, 5K, if you can get 5K, anything
7K,
5K.
7K would be good.
Yeah, now everything seems like it's moving up, but if you get 5K, you're pretty solid.
So tomorrow also you'll bring these in the morning? I guess?
Yeah, we'll probably lock this room up and keep it in here tonight.
Okay. What time do y'all open the room?
There's somebody here at 5 a.m. in the morning.
Oh, okay. Oh, my God.
Yeah,
Way better.
big difference, huh?
Good Lord. We've always had the TV, so we didn't realize that.
Yeah, it makes a big difference for sure.
Wow. Yeah. That's huge.
See, and you get one of these and you can dial it in like this. See how he can bring in all your corners too. So you don't have to worry about, that it being everywhere.
That's cool.
And just make sure when you guys use your laptop and you're using other people's projectors or whatever, you just always change your resolution on your laptop to 1920 to 1080.
Okay.
And then it'll always pick up
Okay.
on whatever you run it through.
Isn't mine?
Yeah, because it's sturdy. I could tell that it's running at that because your image isn't blinking. If you ever get a situation where your image comes on the screen and then it goes away, comes on the screen, goes away, just check your resolution on your laptop.
Okay.
1920, 1080, in that range.
Just bring up the back. When Mama brought it down, you can bring the screen, bring it up the bottom. It should go right in the leg then, right in the hole. I am not working.
Hole's a little higher.
Whoever know, right?
Yeah.
How's that? Good?
I'll make it work.
Retail's like 75. So,
Yeah, I mean,
That
but
looks good
it's
then.
not even
Yeah.
close to getting
Right.
right.
This should have been better, but that's all right. All right, cool. That was good.
Yeah, I think we do that way.
You want that?
I'll throw it. And then you may want to put the salad on the podium to get more room.
There you go. Lot right
Oh my gosh.
Yeah.
Oh my gosh.
So, and if we're ready to start.
Oh, thank you.
Target for this, but, the following year,
Yeah.
we'll, we'll charge it, but if, anything, if you could actually take a survey, capture the event, just let us know how the event went, that's all I want. Let us know how everything
Can you send
went.
me something?
Yeah, we'll send a link once everything closes out, and if you just give us like honest feedback, how everything went.
Yeah.
We'll just take care of this in the following year, we take it with this.
Thank you.
Right.
Thank you very much.
Yeah, absolutely. Hey guys, thanks for getting this in here right away.
Hey, what's up, buddy? How you doing, man?
Hey, it's on.
Great.
Quite better.
That's professional right there.
Yeah.
There you go. Turned off the everything, flipping through it and stuff.
What's that mean?
It's just all these function settings, so you don't see stuff popping up on the computer and it's switching signals. It will always go right back to that
Oh, okay,
image
okay.
and stuff, so, yeah, you're good to go now. I'm just a perfectionist. I don't even see what he's fixing right now.
Let me get my, sure. All right.
Cool, there you go, fellas.
What time is your meeting tomorrow?
We start at 7:30.
7:30?
Cool. Yeah, we can put it in the, we put it, we're gonna leave it in there. We're probably
Yeah,
just
leave
gonna
it in
leave.
here and we'll
Just have to
lock it
turn them on.
tonight.
Okay.
Yeah.
Just have to plug in the HDMI.
Okay, great.
All right, gentlemen.
Okay, so we'll lock the door and we'll be able to access it
Well,
after
no,
7.
we'll have, or do you guys have keys to the door?
No, we don't.
Oh, we'll have one of our guys will come through. They'll come through and they do a check on everything.
Okay,
And they'll make sure the equipment's still in the room, and then
Okay.
they'll lock the doors and everything.
okay. And so,
But I would take, if you, I don't know if you probably would be, you might want to bring your camera with you.
well,
I don't know.
it's not, it's like 30 bucks, right?
Okay.
Yeah.
That's fine. I just saying sometimes,
Yeah.
I just would hate for you to lose your equipment or something.
Yeah, I mean, we can take it, it's not a big deal, but
Yeah, it's up to you, but they'll lock.
if you're
the
leaving
door.
that in here, then I'm not too worried.
I don't know, you guys are done today at what time?
We should be done by 3.
Then I'm gonna tell Mike and put it on the shift notes that after 3 to have somebody come down here and lock this room.
Okay.
Okay, that's fine, cool. And then tomorrow, is there any way they can open it by 6:30?
We'll somehow be here at 5 AM.
Oh,
Yeah.
okay, great, thank you, cool.
Appreciate
Bye,
it.
gentlemen.
Thanks so
Have a good
much.
night.
Well, I guess the projector does matter.
Okay, can you open that little thing? The other camera, this little.
Yeah.
Yeah. Can you, see if it's, just want to adjust it, this looks straight. Yeah, I'm gonna fix your slides real quick so that you're broadcasting this. Let me know, what do you see? Not yet, right? You're not seeing the display quite yet. It's a little crooked, right, the camera? Okay, I see it. Better?
I think you overcorrected slightly less.
Slightly less?
Maybe a little bit more.
Which way? Which side? This side down?
No, the other way. Yeah.
Okay.
Right there.
Okay. Oh, we should have some, there's tape. Or that curtain.
Oh,
See if there's gonna be out there. I'm gonna just, slide back. If they have tape, we can do it. Okay, it's up.
Good. I think we need to call.
Why?
I mean, if we're gonna try to tape it, see anybody out there. Or should I just try to move it in as best we can?
yeah, if we grab our backpack.
So tomorrow, do you send a Google link? Or what? Or do you do?
What do you think? I'd say it's in Google if it's not too much of a hassle. Maybe it is.
It should be a hassle.
Should it?
Yeah.
Okay, let's do that.
There is no tape in here? You checked? No tape?
There was, I probably took it with me. Yeah, we changed the projector.
Oh, yeah, nice, good.
I think it was pretty quick. They came in real quick.
Oh, good.
We changed the projector.
Yeah.
this one, obviously, it's up. It's bright enough.
She's so good. She's a sheepdog poodle. So she's so big she takes a little vaccine. My dog is in San Jose, and then her dad is in LA. So everybody wants me to drive. And she likes it in California, but it gets too hot in Las Vegas. So hot. I thought it's really nice here about dogs. Like, I always walk her without a leash, and then in California they're so mean. I figured out how to leash. They're so mean. They're mean. Because of you, thank you. The whole time we lived in Vegas, almost 4 years ago, I seemed to ever get finished on the dog. Yeah, I know.
Oh, okay, thank you.
You have your blood.
Everything?
When I need you.
Hello? Are they taking their I've done pretty good. It's just the two. Yeah, that's it. But even then, I'm she's doing well on it. But are they pretty good at all of that? Oh. Is it because they don't believe in the medicine and they report it?
Yeah.
Yeah. Yeah.
Hi, everyone, we're about to get started. We're going to do diabetes next, and then after that, we have one more topic, which is dementia. A couple of housekeeping notes. Obviously, thanks for your feedback about the projector. It wasn't quite as bright, so we did. So you should be able to see it, those of you that are live, but also in terms of people that are on streaming.
Hopefully a lot more clear. Yeah.
Yeah. It's a huge difference. Also, I did send out, like I said, I sent a link earlier with an email that has the link to submit any questions you guys have. As the day goes on, please submit all your questions for all the topics from today. And then tomorrow, it's live, so it will constantly update. That helps us see what kind of questions we need to address tomorrow in our rapid review. And then I did bring certificates with me. Does anyone want physical certificates, or do you all prefer email certificates? Physical? Okay. If anyone wants physical certificates tomorrow after the conference, let me know, and I'll give you yours right then. I do have to send you an email one, because I have to save one for our records anyway, and I can't, so I'll send you an email one also, but if anyone wants a physical one, I can have those here with you, okay? And then that way you can tell me how you want the data. All right, guys.
All right, we'll go ahead and jump right in. So give me a minute to look at the objectives. Okay, and then, once again, we have the one pager. Take a look at that just to orient you a little bit. There's diagnostic criteria, the labs that we were ordering for diabetics, A1C goals, differentiating between DKA versus HHS. There's a little bit about the various medications for diabetes. On the backside, different classes of medications in a little bit more detail. And then the guidelines in terms of what medication is recommended when, in what scenario. And then some more details that we'll go through as we do this presentation. Excuse me. So just a little bit of background, 38 million Americans, that's 11% of the population, 15% of the adult population have diabetes, and it's growing over time. That means that we've got our work cut out for us. 8th leading cause of death in the United States. Cost is over 400 billion in 2022 in terms of both productivity loss and in terms of medical costs and productivity loss. Complications of diabetes affect you head to toe. It can cause potential risk of stroke, blindness, kidney disease, heart disease, neuropathy, retinopathy, you name it, head to toe, a lot of potential complications. And diabetics are hard in stroke. So if you look at the incidence of diabetes over time, we've had fairly reliable statistics that the CDC has been keeping since 1950. And what you see is that it used to be about 1% of the population, and now it's close to 10% or so, depending on if you're looking at diabetics. If you're looking at adults with diabetes, it's about 16%. So climbing over time. We'll start with a case scenario. This is a patient, Mr. Johnson, 62-year-old man with hypertension and 10-year history of diabetes, presents for his annual checkup. He has no known cardiovascular disease. His current medications include metformin, 1,000 twice a day, glimepiride, 4 milligrams a day, lisinopril, 20 milligrams a day. He reports no symptoms of hypoglycemia, but mentions he has been feeling fatigued a little bit more lately. His A1C has been well controlled over the years, but his latest lab values show A1C is 8.1%, creatinine is 1.4 milligrams per deciliter, LPL is 135, urine albumin creatinine ratio is 75, and BMI is 29. So which of the following is the most appropriate next step in managing Mr. Johnson's diabetes? A, increasing the dose of glimepiride to improve glycemic control. B, switching from glimepiride to a DPP-4 inhibitor. C, initiate a 2 inhibitor. And D, add basal insulin. So we're going to keep this one scenario in mind, and we'll come back to this at the very end. So let's talk about the various guidelines that are out there. So ADA provides yearly guidelines. Every year they put out an update, and they put it out right at the start of the year in January. And so that is the latest update. AACE, American Academy of Clinical Endocrinologists, puts out periodic updates. The latest one that they have was from 2023. And they're largely, fairly similar. There are some differences, and we'll point out those differences as we go through this. So for diagnosis, 4 ways to diagnose. You want a A1C between, A1C over 6.5 or higher is diagnostic diabetes. 5.7 to 6.4 is pre-diabetes. 2-hour fasting glucose with a 75-gram oral glucose tolerance test. It's over 200. That's diagnostic diabetes. 140 to 199 is pre-diabetic range. Fasting blood sugar between 100 and 125 is pre-diabetes. Over 126 and higher is diabetic range. And then a random blood sugar with classic hypoglycemic symptoms. If you have just a random sugar over 200 and you have symptoms of polydipsia, polyuria. That could be diagnostic. The fourth one, you can diagnose just right off the bat. The other three, you're supposed to do a second test to just confirm. So you have to have two, either fasting readings, or you can have a fasting reading and an A1C, and so that just kind of confirms that they have diabetes. We're going to focus on type 2 diabetes, but you do want to at first make sure you're dealing with type 2 diabetes, and so in terms of being able to differentiate it from type 1 diabetes, you look at the age of onset. In type 1, it's earlier onset, and it tends to be a sudden onset. In contrast, in type 2, they tend to get it over age 40, although we are seeing it at younger ages, and it seems to be a more gradual onset and progression of symptoms. The type 1s tend to be more on the leaner to normal body weight side, whereas type 2 tends to be overweight or obese. The type 1 diabetics require insulin right off the bat, right at diagnosis, whereas type 2, it usually isn't required until later stages. Family history is very common with type 2 diabetes, less so with type 1 diabetes. There are autolyne antibodies present, various sorts that you can test for to be able to diagnose type 1 diabetes, not so much with type 2. C-peptide is going to be high or normal in type 2 diabetes, and it's going to be low in type 1 because you don't have any insulin that's being produced. And then ketosis or DKA is common presentation. When you know diabetes, they usually present with oftentimes DKA, so they tend to be very sick. Whereas with type 2 diabetes, that's rare. Who should be screened? Again, it sort of depends on which guideline you go by. The U.S. Preventive Services Task Force guidelines do recommend screening everybody between 35 to 70 every 3 years for the fasting blood sugar, or one of the other screening methods. And then, depending on the results, if it's normal, you continue to screen every 3 years. ADA has slightly different recommendations, although they also recommend for everybody 35 and older should be screened. But also, if you've had a prior history of gestational diabetes, if you have pre-diabetes, if you've had exposure to certain high-risk medications like oral corticosteroids multiple times, if you have a history of HIV, history of pancreatitis, which can predispose you to diabetes, or if you're over 18 with a BMI over 25 or 23 in Asian Americans, and any one of the following risk factors, you could read through it, but included in that list is just inactivity, which is, a lot of people would meet that criteria, unfortunately. So once you, potentially made that diagnosis, you want to talk about lifestyle interventions. And there is no specific diet that ADA recommends, but the diet is what all have in common. That is that, their emphasis is to avoid processed foods to the extent we can and have more whole foods. And so emphasis on fruits and vegetables, nuts, legumes, whole grains, and minimize processed foods. They don't specifically recommend a particular diet like the Mediterranean, vegetarian, DASH diet. They just say, again, whole foods, avoid processed foods. Do you recommend exercise? About 150 minutes of moderate intensity exercise or 75 minutes of vigorous exercise. And also strength exercises in addition to the cardio. It's also been shown to improve blood sugar control. So 2 days a week of some upper body, lower body, and core strengthening has been shown to be helpful. Sometimes it's a lot for a patient to take in to, tell them, go exercise 150 minutes a week. But, studies have shown that even as little as just 5 minutes of exercise every day can itself improve blood sugar control. And so, the emphasis is really just to get up and help them to get up and be active in some way. Get them to make some sort of commitment to being a little bit more active. Maybe that means if they're sitting all day on their computer because their work requires it, perhaps there's some creative ways to get up, maybe they can do walking meetings. Standing desk, not so much. That hasn't been really shown to be particularly helpful, but if you have some movement in there, so perhaps a treadmill desk, that may not always be practical, but something like that where you're actually moving blood flow, that tends to help improve blood sugar control. And then in terms of pre-diabetes, metformin can be used. It doesn't specifically recommend that you use it, but it is something you can consider. in particular for younger individuals, especially also for women with gestational diabetes, and then those with a higher range of fasting blood sugar in the prediabetes range, or a higher range A1C in the prediabetes range. Those are patients that you could consider metformin for. But the foundation of treatment, really, in terms of prediabetes management, is lifestyle changes. So, making sure that they're getting some exercise in that pre-diabetic stage. A lot of this can be reversed with just a healthy diet and regular exercise. So diabetics are high risk for a number of comorbidities. So included in that list is osteoporosis. It doesn't change the screening interval. We're not necessarily saying, well, if you're diabetic, you should be screened earlier now, but you should make sure that they are up to date with their screenings for osteoporosis. Same thing for cancer screenings. There's higher risk for that. That doesn't necessarily translate to earlier screening for any of these, but they are higher risk for certain cancers. They are also high risk for metabolic associated steatotic liver disease, which used to be non-alcoholic fatty liver disease. There's a change in the emphasis and not, calling it alcoholic or non-alcoholic liver disease. It's more the emphasis on metabolic dysfunction. So a little bit of a change in terminology there. About 70% of patients with diabetes have metabolic associated steatotic liver disease. So important to potentially screen a number of these patients. So if they're over 50, if they have an elevated ALT or AST for the last 6 months, you do want to check and make sure that they are not at risk for fibrosis. So what you do is you calculate what's called a FIB-4 score. So these patients, it's a fairly simple calculation. All you need is that ALT, AST, platelet count, and their age. Plug it into a risk calculator. You can find this online, and you calculate the FIB-4 score, and that'll tell you the risk of this metabolic associated fatty liver, steatotic liver disease progressing into fibrosis. And if they are, you could look at those thresholds for defining what's high risk versus low risk. If they're low risk, then you don't have to do a whole lot more than evaluate in a year. And of course, emphasize those healthy lifestyle changes. If they're high risk, then you're going to send them to the appropriately managed and closely monitored. But the people in the middle, those individuals should have additional testing to be able to say if they should be really considered high risk or should they be reclassified as low risk. And so you can get a FibroScan, which can help you to determine the stiffness of the liver and get an idea of whether they're at risk for fibrosis, or something called an ELF test. The FibroScan is the more preferable of these. Okay. When you're evaluating blood sugar control in a patient who has diabetes, you want to check their A1C at least 2 times in a year, so every 6 months. But potentially more frequently, especially if they're not well controlled. So potentially every 3 months, or possibly even more frequent. And of course, there are various situations that affect their blood sugar control, and you can, in between A1C checks, you can also rely on finger stick blood sugar readings or continuous glucose monitors, which are now increasingly being covered by a lot of the insurances. So it gives you, real-time data, which can be helpful not only for yourself in terms of managing diabetes, but also for the patient in terms of being able to give them feedback. The A1C, of course, reflects the average sugars over the last 2 to 3 months. It is more weighted. A1C comes from the most recent 1 month, and then you have the previous 2 months that add to it as well. But A1C has some limitations. So in particular, if you have certain conditions, such as certain types of anemias, that can falsely raise your A1C or falsely lower A1C. So if you have a type of anemia where you have hemolysis, for example, and then your red blood cells are experiencing a shorter lifespan, which means that they're less time to glycosylate those hemoglobin molecules, which means that your A1C is going to be falsely low. If your red cells are in circulation for longer periods of time, perhaps because they have B12 deficiency, then you have more time to glycosylate those hemoglobin molecules and you can get a falsely elevated A1C reading. So those are some limitations to be aware of, but there are alternative measures. Fructosamine, which is gives you an idea how their sugars have been running in the last 2 to 3 weeks, glycosylated albumin, and then of course a continuous glucose monitor. I mean, you can get real-time readings with using that. And so, obviously, if there is a condition that is affecting the red cell lifespan, then that one of those other tests may be appropriate, and also just to be able to get more frequent readings, it may be appropriate to use some. So, if you're trying to just do a quick back of the envelope calculation on A1C, A1C of 5 translates to roughly a blood sugar of about 100, and then add 30 points for every point up in A1C that you go. So 6 is almost 130, 7, 160, and you keep going, roughly that kind of correlates. Okay, now let's talk about blood sugar A1C targets. Okay, what should the target A1C be? And there is a little bit of difference among the various guidelines that are out there, but basically, when they look at the big trials for diabetes, there's the CORE trial, the ADVANCE trial, and the VA diabetes trial. What they showed is that more aggressive control, particularly getting that A1C down below 7%, did reduce microvascular complications. It was clear across the board that it did that. It was less clear that it reduced macrovascular complications. In the ACCORD trial, it in fact increased mortality when they tried to get the A1C down below 6.5. So that was a little bit of an unusual thing that we're actually ended up increasing mortality with tighter blood sugar control. But it actually made sense given the methodology of the ACCORD trial, which uses a lot of sulfonylureas and hypoglycemic agents. Now we know better medications. So if we had newer trials, we'll see if that data changes. Now that some of the newer agents that we use, which we'll talk about, may not necessarily cause as much hypoglycemia. So ADA guidelines do recommend for most individuals to get the A1C down less than 7. But if they're younger and they have years to develop microvascular complications, and getting them down even more aggressively, less than 6.5 is appropriate. Here is a difference between AACE guidelines, where they recommend less than 6.5 for the vast majority of patients. AACE tends to be a little bit more aggressive in terms of A1C management. And then in terms of the CGM metrics, time in range, 70%, time below range, these are the targets that you should aim for, less than 4%, and then less than 1% of the time where their blood sugar is actually below 54. And you can go with a lower A1C goal. This is per ADA guidelines, if you could get there safely. So maybe you're going for medications that don't cause hypoglycemia, then it is reasonable to go a little bit more aggressive. But in certain individuals, a less stringent A1C goal is certainly appropriate, especially if they're older. Getting them down less than 8% is probably adequate in terms of a lot of microvascular complications, and macrovascular complications are unlikely, at that, given their life expectancy. At a certain point when you're looking at individuals who have, perhaps elderly, frail, multiple medical conditions, perhaps even in nursing homes, you do want to focus mainly on symptom control, so avoiding hypoglycemia and avoiding hyperglycemia. And so you don't really necessarily have an A1C goal at that point. You're just trying to manage symptoms and prevent those symptoms. So the potential complications when we manage blood sugar include hypoglycemia. CGMs tend to help prevent the occurrence of hypoglycemia because we're monitoring more regularly. ADA guidelines do recommend that these individuals should have glucose available to them, preferably in a glucose tablet, but you can use any kind of fast-acting carbs, including orange juice, even soda for that matter. And then they should be prescribed glucagon if they're on insulin. So glucagon can help raise blood sugar in the case that you're accidentally getting an overdose or just too much of insulin. Some of these individuals, when they get hypoglycemic, you want to try really consider not necessarily tightly controlled. So again, you're trying to prevent any serious risk of hypoglycemia. Hyperglycemia is another complication you want to try to avoid. And in this case, this can lead to DKA, or it could lead to hyperosmotic hyperosmolar syndrome. And both are not good, right? So typical population, DKA tends to happen more in type 1 diabetics. In contrast, you see more HHS in type 2 diabetics. In terms of blood sugar, the DKA is high, whereas in HHS is very high, right, over 600. Ketones tend to be present in DKA. It's usually absent in HHS. Obviously, you're going to have metabolic acidosis with DKA. With HHS, you're going to not have metabolic acidosis. You would have normal pH. Bicarb tends to be less than 18 in DKA and more than 18 in HHS. And then you do have severe dehydration in HHS in contrast to DKA. So just some things to be aware of in terms of being able to differentiate what you're dealing with. Okay, obesity and weight management. So this is from ADA's guideline. They actually recommend a little bit more aggressive weight management than some of us are used to. So if the body mass index is over 20, recommend really intensive behavioral counseling, and the focus is on healthy lifestyle changes. If it's over 27, then they do recommend pharmacological treatment. If it's over 30 or higher, then metabolic surgery should be considered. And the interesting thing with metabolic surgery is a lot of them have actually better outcomes than a lot of the pharmacological agents, including the GLP-1s and GLP-1 GIP dual agonists that we'll talk about here in a minute. There are, of course, various medications for treating obesity. A lot of this we'll talk about, Dr. Lay will talk about during the obesity talk, but the emphasis here is largely going to be on the GLP-1 agonist and the GLP-1 GIP dual agonist, which have really been shown to be particularly effective for managing obesity in this population. Okay, so now we'll talk a little bit about the main newer classes of medications. And I think you guys are well aware of that metformin and sulfonylureas. Now we're going to kind of focus on the newer medications that have come out in the last 10 years or so. Starting with the SGLT2 inhibitors, and then there's the GLP-1s, GLP-1 GIPs, and DPP-4 inhibitors. We'll talk about each of these, and then we'll talk about how to incorporate them in treating patients. So SGLT, the ones that are recommended are typically canagliflozin, dapagliflozin, empagliflozin. They work by blocking the absorption of glucose in the kidneys, and as a result, you have glucose being excreted in the urine. That can, of course, put them at risk for genital yeast infections, urinary tract infections, and so just something to be aware of. But these medications have proven to be effective not only in lowering blood sugar control, but also reducing major adverse cardiovascular events, particularly these three SGLT2 inhibitors. They've also been shown to reduce heart failure. They've been associated with reduced all-cause mortality. And so multiple benefits, and again, we talked about in the kidney talk that they've also been shown to reduce kidney disease progression. And so we did mention, urinary and genital infections also can cause dehydration and electrolyte abnormalities because of this mechanism, which makes sense. Canagliflozin, in one of the studies that was earlier done, did show a slightly increased risk of lower limb amputations. So, be careful in patients who have, peripheral vascular disease. But in the later studies that have been done on it, it didn't show in any of the other SGLT2 inhibitors. They are contraindicated depending on the particular estimated GFR. If it's less than 30, Certain ones are contraindicated. Now, remember, we said empagliflozin can be used to estimate GFR less than 20. I didn't mention earlier, but I did mean to, is that if you have them on these SGLT2 inhibitors and they then go down to less than 20 or less than 30, depending on the agent, you don't necessarily stop it at that point. Okay, so you can continue it as long as you've got it on board before they hit that less than 20 or 30 threshold. You wouldn't start it though if, let's say, their estimated GFR is 15. You wouldn't start them on any of these medications. This is a trial that showed SGLT2 inhibitors reducing rates of hospitalization for heart failure, death from cardiovascular disease, and death from all cause. So, really encouraging trial data. That was for dapagliflozin. This is for empagliflozin. Similar kind of data. Really fairly significant if you look at it. So, fewer heart failure hospitalizations, cardiovascular deaths, lower kidney disease progression, lower all-cause mortality. Not to mention the benefit of lowering A1C, having a modest effect on lowering weight as well, and even blood pressure. Next is the GLP-1s. So we mentioned these briefly. So here we have the various GLP-1 receptor agonists. And what these do is that they basically bind to GLP-1 receptors. That therefore slows gastric emptying. It also makes signals to the brain fullness so that they feel full earlier. It also stimulates insulin production. So as a result, you have lowering of blood sugar, and it also lowers glucagon release, so also reducing blood sugar. So multiple mechanisms for improving blood sugar control. They also are associated with significant weight loss, as you guys are probably pretty well aware. But in addition to that, they've also been shown to reduce major adverse cardiovascular events, lowers all-cause mortality, lowers risk of stroke, which is something we didn't see with the SGLT2 inhibitors. The SGLT2 inhibitors do have better data in terms of heart failure, preventing hospitalizations from heart failure. So both of these classes of medications really kind of quite amazing in terms of the degree to which it has benefits. And as we saw earlier in diabetics, GLP-1 receptor agonists, at least in diabetics, have been shown to reduce kidney disease. Drawbacks, mostly because of the nausea, vomiting, sometimes diarrhea, sometimes constipation. They are contraindicated if you have family history of medullary thyroid cancer or MEN type 2 syndrome, contraindicated in severe GI disease. Caution in those patients who have previous history of pancreatitis. It can trigger another episode, and of course, if there's any hypersensitivity. This is some trial data that looked at liraglutide, which again, you'll see here in this trial. This summarizes multiple trials that showed that the GLP-1s have been shown to reduce major adverse cardiovascular events, reduce cardiovascular mortality, all-cause mortality, progression of nephropathy, not to mention lowering A1C and weight. So then there's the GLP-1 GIP receptor agonist. So here we're talking about Mounjaro. This is the one that's approved as of now. And they work very similar to the GLP-1s, but in addition, they block the GIP receptors, which enhance that feeling of fullness. And so superior weight loss, blood sugar control tends to be even better. Similar kind of cardiometabolic benefits, and improves insulin sensitivity. The main drawback here is that we just don't have enough long-term data, in contrast to the GLP-1s, which we have had for a little bit longer. Same contraindications as with the GLP-1s. The DPP-4 inhibitors, here we're talking about sitagliptin, saxagliptin, linagliptin. They do lower blood sugar, but more modestly, and they're more or less weight neutral. They don't really cause hypoglycemia so much, but they have not been shown. There's no demonstrated benefit of cardiovascular or renal benefits compared to the GLP-1s and the SGLT2s. And so that's kind of the main class, the new classes of medications. Now we'll talk a little bit about the guidelines. And I'm going to start here, as I mentioned, well, I didn't mention, but I should have mentioned at the beginning. The AFP actually endorses the AEA guidelines, whereas ACP actually doesn't endorse either AACE or the AEA guidelines. They actually put up their own guidelines. And I think their guidelines are actually pretty interesting. So I'm going to, as I said, incorporate some of what they say as well. Here's what they have, and this is coming verbatim from what their recommendation is. First recommendation, add an SGLT2 inhibitor or a GLP-1 agonist to metformin and lifestyle changes in adults with type 2 diabetes and inadequate blood sugar control. This is a strong recommendation. They rated it with high certainty evidence. In terms of the SGLT2s, again, it has multiple benefits, which we talked about, and GLP-1 receptor agonists. Now they have a second recommendation. Second recommendation, they recommend against adding a DPP-4 inhibitor to metformin and lifestyle modifications in adults with type 2 diabetes and inadequate blood glycemic control to reduce morbidity and all-cause mortality. And again, strong recommendation, high level of certainty. What they're saying is, if you have better agents, don't go with the DPP-4 inhibitors. We can go with the GLP-1s, we can go with the SGLT2s, use those first. They've got better outcome data. Now we'll shift a little bit to the AACE guidelines and kind of compare, and we'll also, talk a little bit about ADA's guidelines. But what AACE has sort of two ways of looking at your individual diabetic patient. So they classify them based on their comorbidities. So for example, if they have heart disease, versus there's a glucose-centric control, which is another way of managing blood sugar. And there's different guidelines depending on the scenario. So let's say you have a patient with atherosclerotic cardiovascular disease. The recommendation is to start either a GLP-1 or an SGLT2. And then once you've started one, you can go to adding the other. If you have a patient with heart failure, as we mentioned, and as Dr. Pillay mentioned in a little more detail, SGLT2, that's a class 1A evidence for SGLT2 inhibitors in heart failure patients. And then second to that, this is AACE, GLP-1 receptor agonists are then recommended. If you have a patient who has a stroke or a TIA, remember we talked about GLP-1s having more data in stroke patients. So GLP-1s here are preferable. There is some evidence for using the TZDs, pioglitazone, in these patients. And so that can be an option. And if you start one, then you go to the other. Now, ADA actually differs a little bit here. In terms of stroke, patients who had a stroke or TIA, they actually recommend a GLP-1, not necessarily feeling that that is equivalent to a TZD. In a CKD patient, here this is a little bit interesting too. AACE guidelines say you can start with either an SGLT2 inhibitor or a GLP-1 receptor agonist, whereas ADA actually recommends starting with an SGLT2 inhibitor, citing that they have better evidence for preventing kidney disease progression. And then, of course, if one is inadequate, then you can add the other. In all these cases, metformin is also used if it's appropriate in that individual. Now, one thing I'll say about this, and something that's somewhat new in some of these guidelines, is that increasingly we're seeing that metformin doesn't have to be first line. So if you have a patient who has cardiovascular disease and diabetes, AACE in particular is actually pushing for using SGLT2 inhibitors and potentially GLP-1 receptor agonists in that context in preference to metformin. Now that may not be what you experience when you write for it because the insurance is going to reject it, right? A lot of times they're going to want to see that these patients have been on metformin. So, but that is starting to get increasingly into the guidelines. Metformin for the longest time has always been first line. Now, maybe first line, but maybe not in certain scenarios. In terms of their glucose-centric control regimen, they recommend it for patients who are obese or overweight to use GLP-1s or GLP-1 GIP dual agonists. And then if if needed, or actually they do say or SGLT2 inhibitors, whereas in contrast, ADA actually recommends the GLP-1s and GIPs over the SGLT2s. SGLT2 inhibitors have been shown to reduce weight, but it's a less robust weight loss in terms of managing obesity. For hypoglycemic risk, GLP-1 receptor agonist or GLP-1 GIP or an SGLT2 inhibitor are appropriate. If cost is an issue, now this is a little bit interesting, sulfonylurea is an appropriate option. And so you could still use that in the case of a patient, they just can't afford GLP-1 receptor agonists, or maybe they can't afford the SGLT2s. Certainly sulfonylurea could be an option, and TZD could be an option in that scenario. For severe hyperglycemia, typically the recommendation is to go ahead and start on insulin, basal insulin, plus oftentimes adding in a GLP-1 or a GLP-1 GIP receptor agonist. And again, in all cases, metformin if it's appropriate. When do you start with combination therapy and why? Well, you want to start it because it has been shown to reduce the progression of diabetes in terms of preserving beta cell function. And so trying to get that blood sugar control in those patients who are very high A1Cs fairly quickly is important. So if their A1C target, if it's greater than 1.5, here they consider starting potentially two medicines, SGLT2s or GIP, GLPs in combination with metformin. And when do you consider insulin therapy? Well, if their blood sugar is very high, and A1C is over 10, particularly if they're symptomatic, polyuria, polydipsia, and they're not meeting their treatment goals, then it's appropriate to add in insulin. In the ADA guidelines, they actually recommend that a lot of those patients on insulin should also start with a GLP-1 receptor agonist or a dual GIP-GLP-1 receptor agonist, because that will counter the weight gain that tends to happen when patients take insulin. Remember, that weight gain then causes insulin resistance, and you're going to have higher doses of insulin that's going to be required. So a way to prevent that is to add in one of these newer medications, the GLP-1s or the GLP-1 GIPs. All of our diabetics are inherently higher risk for cardiovascular disease, so aspirin is recommended for prevention. You do want to manage their blood pressure fairly aggressively, although the treatment goal is similar to what AHA, ACC had recommended, less than 130 over less than 80. If you have a reading of between 130 to 149 and 80 to 89, now keep in mind this is ADA guidelines in contrast to ACC, AHA guidelines, which differ a little bit, you're going to start them on one agent. If their blood pressure is over 150 over 90, you're going to start with two medicines at once. Anybody remember what the guidance says from ACC, AHA in terms of when you start two agents at one time? It was a bit of difference. Now, if you remember the Accord trial, which was done in diabetic patients, didn't seem to show as much of a benefit in aggressive lowering. So, there may be some influence in terms of that. In the Sprint trial, they actually did not include diabetics, and so ADA weights these a little bit differently as a result. If you are going to start on a single agent, it could be an ACE or an ARB, or it can be a calcium channel blocker or a diabetic. But if you're going to use two agents, then one of them should be one of the RAS inhibitors, ACEs or ARBs. And then if you're you're going to add the other classes of medications, those main three classes, ACEs, ARBs, calcium channel blockers, and diabetics. And if you're still not a goal, you may need to add in a mineralocorticoid receptor antagonist. As we had mentioned earlier in our hypertension talk, if they're not a goal with three medications, you do want to screen them for hyperaldosteronism, but you also want to start them on potentially spironolactone or one of the mineralocorticoid receptor antagonists. We did talk a little bit about the steroidal versus the non-steroidal mineralocorticoid receptor antagonists. Here we're talking about the steroidal being the spironolactone or plerixafor, and non-steroidal being finerenone. In kidney disease, we really do prefer, they emphasize using finerenone because it has better outcome data. In diabetics, you could go with potentially either one, but the non-steroidal mineralocorticoid antagonist, we were talking about finerenone or Corindia is the brand name, has fewer side effects in terms of less hyperkalemia, less gynecomastia, so potential benefits in terms of better tolerance. Screening for asymptomatic cardiovascular disease is something that's commonly done, not really what's recommended though. For most patients who don't have any kind of chest pain, shortness of breath, they're just there with diabetes and they don't have any other issues, and they don't necessarily need a screening EKG or a screening a stress test. Neither do they necessarily need a screening ankle brachial index unless they have symptoms, in which case it would be completely different. Then you would obviously screen them. And then you could consider it in patients who have long-standing diabetes and multiple cardiovascular risk factors to do an ankle brachial index. Statin therapy is recommended in all diabetics, with some exceptions. So for most individuals, you're going to have them at least on a moderate intensity statin if they're between 40 to 55, and that's regardless of what their LDL is. And so even if their LDL is perfectly good, we know that statins stabilize plaque. So it's important to have them on some sort of statin. Have multiple ASCVD risk factors, then they really should be on a higher intensity statin. Particularly if they have a history of cardiovascular disease, and they're definitely going to need to be on a high intensity statin. And the high intensity statins are basically atorvastatin 40 or 80 milligrams, or rosuvastatin 20 or 40 milligrams. So here's how you decide, whether per ADA guidelines the patient needs to be on a statin. If they're under 40 and they don't have any clinical ASCVD risk factors, then they don't necessarily have to be on it, but they don't say one way or the other. They could, particularly if they have multiple risk factors, even if they don't have clinical ASCVD. Mostly the emphasis is on lifestyle changes. But if they are over 40 and they don't have any additional cardiovascular risk factors, you do want them on a moderate intensity statin. Now, most of our patients, though, are with diabetes, probably are over 40, and they have some ASCVD risk factors. Maybe it's hypertension, maybe it's just being having a higher baseline cholesterol, smoking, multiple risk factors. They tend to have some risk factors. Their LDL goal is less than 70 based on the 2025 ADA guidelines, and so they should be on typically a high intensity statin. And then anybody with atherosclerotic cardiovascular disease, so those patients who've had an MI or syndrome, their LDL goal, based on the latest ACS guidelines, is to get that LDL under 55, which is a change from previous years. I mean, we'd always seen less than 70, for the longest time, but now, some of the European guidelines have been recommending less than 55, but now ACC-AHA actually recommends less than 55 for those patients who've had a cardiovascular event already. Secondary prevention. Again, they should be on a high-dose statin, high-intensity statin. You may need more than one agent to be able to get them to their LDL goal of less than 50% from baseline and less than 55. To be able to get their second-line agent could be ezetimibe, tends to be the next in line because it is generic and it does have outcome data that show reduced events, cardiovascular events. But you could also use a PCSK9 inhibitor. These would be for patients who need a significant reduction in their LDL because Zetia is going to reduce it maybe 15%, maybe 20% max. If they need 50 to 60% drop in their LDL, you're going to use a PCSK9 inhibitor. There is a newer PCSK9 inhibitor that's called a small interfering RNA molecule therapy, and it's called inclisiran. Inclisiran is used twice a year injection. It's just twice a year injection, and it also lowers LDL 50 to 60% from baseline. There is also bempedoic acid, which is a newer medicine, but it's similar in efficacy to ezetimibe, which, lowers LDL modestly, 15-20%, as I mentioned. Probably not adequate for most patients, and it's a lot more expensive. Retinopathy, neuropathy, foot care, obviously screen for it. If they have normal exams, you can screen for retinopathy every 2 years. You want to make sure you're checking their feet, at least on an annual basis, with monofilament test, a tuning fork, vibration perception, and you're trying to detect any kind of neuropathy. And if they have neuropathy, they're higher risk for autonomic neuropathy as well, gastroparesis, cardiovascular autonomic dysfunction. These people tend to have labile blood pressure, so be on the lookout for that. In terms of managing neuropathy, you've got the gabapentinoids and SNRIs, as well as the tricyclic antidepressants that you could use for this patient population. Okay, back to our clinical scenario. Mr. Johnson, 62-year-old, 10-year history of diabetes. Here for our annual on metformin, on glimepiride, lisinopril, no symptoms, but except just some fatigue. A1C was well controlled, but now it's 8.1. LDL 135, urine albumin creatinine ratio 75. What are you going to do for this individual? SGLT2 inhibitors, right? Yeah. So, some of the other ones are possibly things you could consider, but really, in this patient population who has CKD, he has proteinuria, he is diabetic, he does need lowering of his A1C, SGLT2 inhibitors, by far the best answer here. Okay, we'll talk about our highlights. So, once again, 70% of patients have metabolic-associated steatotic liver disease. Make sure you screen for that. Make sure you look for, calculate their FIB-4 risk score. Individualized treatment goals based on their health status. A1C less than 7% is appropriate for most patients, but for complex patients, less than 8%, and very complex elderly patients, you may even forego a particular A1C goal, just treat for preventing hypoglycemia or hyperglycemia. SGLT2s have proven benefits for reducing all-cause mortality, major adverse cardiovascular events, heart failure, reduced kidney disease progression. This is not, by the way, a class benefit. It is particular to certain SGLT2 inhibitors, which we can talk about. GLP-1 receptor agonists have been proven to reduce all-cause mortality, major adverse cardiovascular events, stroke risk, which is not a benefit that we've seen in the SGLT2. It also has been shown to reduce CKD progression, especially in diabetics, and reduces heart failure progression as well. And again, it is also not a class benefit. Start with insulin if you have evidence of catabolism. If they're losing weight, they're losing protein, that means that if their A1C is over 10% and they're having symptoms, give them, start them on insulin, ideally combine it with the GLP-1, helps them to lose weight. DPP-4 inhibitors not shown to reduce all-cause mortality, definitely not a preferred first-line agent for most individuals. It is still reasonable to consider sulfonylureas and TZDs and or insulin if access or cost is a concern. Blood pressure goal is less than 130 over less than 80 for most individuals. If they have albuminuria, ACEs and ARBs, finerenone potentially, or finerenone and an SGLT2 inhibitor because they have chronic kidney disease, so all these agents would be appropriate. High intensity statin if they're diabetic between 40 to 75 with at least one cardiovascular risk factor and their target LDL is less than 70. For secondary prevention, that means they've had a cardiovascular event, aim for an LDL less than 55 based on the newest ACS, AHA, ACC guidelines. And you may need to use a second agent in addition to the statin, typically ezetimibe, PCSK9 inhibitor, inclisiran, and acid. And then, of course, optimize blood sugar management and lipid management to reduce microvascular disease. Okay. Questions? Thank you.
Okay. Is this after lunch? It might be beneficial to take a little stretch break, and then we'll come back in 5 minutes. A couple of key points for tomorrow. If anyone's joining virtually live tomorrow, I did send in the text before. We're going to be changing from YouTube to Google Meet. This is for recording purposes and for the clarity purpose. I think it would be better for Google Meet. We're obviously going to be here still, and if anyone is I'm going to be bringing the certificates tomorrow, so if anyone wants a hard copy, please let me know after the meeting tomorrow. We just need to make sure everyone fills out evaluation forms tomorrow before we can give certificates, and then all those who want an emailed one, not a problem, we'll send it by email also. Just need to make sure you guys do the evaluation forms, which are going to be online. I've sent it to you in the email. It's pretty quick. You click everything, and then just make sure you fill out your feedback regarding our conference, what you liked, what you didn't like, etc. So we really appreciate your time. And let's start back in about 5 minutes, guys.
Yeah.